Good morning, everyone. Warm welcome back to those of you who joined us yesterday, and welcome to all of you joining today only. My name is Akshay. I'm one of the consultant pediatricians and the course director for the Royal London Pediatric Courses. And I'm going to hand over to Dr. Susie Minson, who's going to do the first talk. There are three talks on pediatric nephrology. So over to you, Susie. Susie is my consultant colleague. She's the clinical lead for pediatrics at the Royal London, and her special interest is pediatric nephrology. So, welcome, Susie.
Thank you. I'm just going to go ahead and share my slides. Yeah, we're going to start with a poll anyway. Let's do that. Okay, amazing. Hopefully everyone can see that. So I feel like we started with quite an easy question. You guys have done brilliantly. Um, okay, so we'll get into it. So yeah, I'm Susie. I'm a general pediatrician. I work at the Royal London, and I have an interest in pediatric nephrology, and I do a joint clinic with Great Ormond Street. So I see lots of children who are on that kind of secondary care, tertiary care border. So we'll try to cover a few things this morning. So we'll start with UTI and dysuria. So we'll start by thinking about kind of dysuria and some of the differentials. And of course, not everything that's dysuria is a UTI, but we'll think about how UTIs present and their diagnosis, and particularly the red flags. Like we know most children are going to be fine, but which are the ones we need to worry about? And we'll talk about the treatment and workup. And then there was a nice update for pediatric UTI right at the end of 2024. So I'll just highlight the changes in those guidelines and we'll talk a bit about antibiotic prophylaxis. And then the last bit of the talk, we'll sort of focus on what to do when things aren't so straightforward, like the children that we probably need to kind of spend a bit more time thinking about. Okay, so we know that dysuria is a really common symptom and the differential is quite broad. So for sure UTI, but also kind of vulvovaginitis, balanitis, threadworms are all quite common causes. And then less common, but still things that we need to think about would be things like CSA, nephroblastoma, stones, and glomerulonephritis. So quite a lot of different things we need to kind of think about for these children and young people. And in terms of dysuria, I think the key thing is to evaluate it in the context of the overall clinical picture and the rest of the urine dip. So if a child is systemically unwell and or the urine dip is positive for leukocytes and nitrites and you're worried, I think it's always reasonable to treat as a UTI while we're waiting for culture results, but really important to send the MSU. And we'll kind of come on to talk about when we think about, how we decide which children need workup. One of the really key things is understanding what organism you've grown. So it's really important that that MSU is sent, and ideally before you've given any antibiotics. And then all these children should have a clinical examination as well. Okay, so just to touch on sort of vulvovaginitis and threadworms, because this is so common in, particularly in prepubertal girls, and I see lots of little girls referred to my clinic who have often been treated for multiple like UTIs, but actually when you look at their cultures, they often haven't had significant like positive growths. It's more just that they have dysuria and they often have quite a lot of leukocytes in the urine dip. And this is probably more likely to be like a vulvovaginitis picture. And the most important thing with these ones are simple measures. So things like cotton underwear, gentle soaps, having salt in the bath can be really helpful. And then threadworms as well. So we know that threadworms typically present with itch or pruritus, and that is, I think, the most common presentation. But sometimes, and especially in girls, it can present more with like discomfort or pain. And I think also then if they get some excoriation from scratching, that can then lead to dysuria. So it can muddy the water a little bit and it can be quite tricky to know what's going on. But again, in a girl who's having recurrent symptoms where the urine dip isn't positive or you're not growing anything on culture, you can treat empirically for threadworms, and sometimes in my experience that does lead to clinical improvement. Okay, so if we think about now the UTIs, we know they're really common. 3% of girls, 1% of boys will have had at least one UTI by the time they're reaching puberty. And I think why we sort of worry about it as pediatricians and why it's quite tricky for us in a way is that for lots of these children, we know that this is essentially a minor illness that they'll have full recovery from with no sequelae. But it also could be that this is their first presentation of a significant renal tract abnormality. And we also know that infection in the growing kidney can lead to long-term damage. So the growing kidney is much more vulnerable to damage than in an older teen or an adult. And so it can be that damage done by urinary tract infections in childhood can lead to, significant renal impairment, which is often not something that's going to be massively clinically significant as a young child. But actually, when you look at adults in middle adult life who are having renal replacement therapy, often that, the root of that has lay in recurrent infections in childhood. So there's a lot for us to kind of be thinking about and managing with these infections. The clinical presentation really depends on both the age of the child and the severity of the illness. So, typically, in a lower tract infection, you're going to see frequency, dysuria, maybe just crying, and of course, this is quite difficult in children who are non-verbal or in children who aren't yet toilet trained. If children are more unwell, they may have more systemic upset right through to potentially kind of a urosepsis type picture. So in terms of the diagnosis, the urine dipstick is key. We want a clean catch urine, and if there's nitrites and leukocytes, that does have quite high specificity for infection. Important to remember that in very young infants, particularly those in the first few months of life, you don't tend to get nitrites produced, so that can throw us off sometimes. And in infants, sometimes it can be difficult to get the urine, and we might need to think about an in-out catheter or suprapubic aspiration. And then, as we've said, essential to send off the urine for culture. So as we've said, most children are going to be fine who have a UTI. So the red flags that I'd be particularly looking for on history and examination is if this is a child who's had lots of urine infections over time, if they're having recurrent infections. If there's a history of poor urinary flow, that's always a bit of a worry. Child with significant constipation, spinal lesion, any presence of an abdominal mass on clinical examination, or a child who's got other features that might be worrying for poor renal health, so poor growth, failing to thrive, or presence of hypertension. In terms of treatment, most children can be treated with oral antibiotics and will make a full recovery. Important that when you've got a UTI, we encourage them to have lots of fluid, that we know that helps. I've written here that all children under 3 months should have IV, and that is our protocol at the Royal London, although we are currently involved in a national trial to see if we can treat some of these children with oral antibiotics. So that might change in the future, but I would say at the moment, we would want to be treating these infections aggressively in the youngest infants. I would also say low threshold for going for IV treatment initially if a child is very systemically unwell with it, if they're not tolerating the oral antibiotics, or if they have a history of underlying renal pathology where we know they've already got a degree of renal impairment. Those children, again, we would want to treat aggressively. And then further investigations. So we know that most children who've had a single urinary tract infection with no other kind of red flags that we touched on are at really low risk of having underlying renal pathology or long-term renal damage. So we want to target our investigation to the highest risk children. And generally speaking, the highest risk children are going to be those who are youngest when they get their infection, those who've grown an atypical organism, so a non-E. coli UTI, or those who are having recurrent infections. So when we think about further investigations, there's really three main types of imaging we do. So renal ultrasound is the sort of least complicated, the easiest to get usually, and that's really good for showing us structure and size. So that will help us pick up if these children have got two normal sized kidneys, if there's any asymmetry, if there's any kind of obvious evidence of something like cysts or a duplex system or any of those things. DMSA is a scan that really looks at function and scarring. So in a DMSA, you're looking for the renal parenchyma to actively take up the marker, and that will show you if you've got sort of normal functioning kidneys or if you've already got evidence of damage. And then the MCUG, or the MAG3, is a dynamic scan, and that is looking at how urine flows through the whole renal tract. So that's a really helpful scan for picking up things like vesicoureteric reflux, obstruction, those sort of things. And I've put this slide here. I won't read it all out, but this is just to summarize the 2024 NICE guidelines around what investigations are needed at different ages. So I won't go through it all, but this is for your reference. But essentially, to summarize, it just really shows that the youngest children need lots of investigation, and older children only need investigation if they're having lots of recurrent infections or lots of atypical infections. And then I wanted to talk about antibiotic prophylaxis because this sometimes comes up as a question. And the goals of antibiotic prophylaxis are essentially to protect the kidneys, either while you're working them up to see if there's an underlying problem, or if you know there's a problem while you're waiting definitive treatment or you're waiting for them to grow out of it. So sometimes we would start antibiotic prophylaxis even on the basis of antenatal imaging, or if they've had infections in early childhood. We would generally use trimethoprim first line and then maybe nitrofurantoin second line, but it should be guided by the MSU result. So you wouldn't, if they've had an infection that's resistant to trimethoprim, then that wouldn't be a great choice for your prophylaxis. You should then use nitrofurantoin. Really important to increase the dose as they grow. And because we know that the children that are most likely to be on prophylaxis are often the youngest, because when they're growing rapidly, it's really easy for them to outgrow their dose before you've even really noticed. Um, the NICE guidelines for December 2024 has added an update about this to say that it should be reviewed at 6 months. So, important to make sure that children aren't staying on it for ages without, reevaluating whether they need it. Although certainly children who have abnormal imaging, who are young, may well need it for longer than 6 months. So it's not wrong to do it for longer than 6 months, but you should just have that as a review point and a clinical decision. Okay, and then I also wanted to tell you about methenamine, which is a new addition to the NICE guidelines. So this was also added in the December 24 update. And this is a urinary antiseptic, and it's licensed for recurrent UTIs in children over the age of 6 years. So it reduces the frequency of UTI, and it's most effective for E. coli. So it's not really suitable for children who are having infections with things like Proteus or Pseudomonas or Klebsiella, but children who have recurrent E. coli, especially the ones who basically have a normal urinary tract but are just getting recurrent infections, can really benefit from this. And this is licensed for use in primary care as well, so you can advise GPs to consider this. Um, if you get like a request through things like advice and guidance. So just now, before we finish, I'll just talk a little bit about what to do when the imaging comes back abnormal, because usually children that we send for ultrasounds and DMSAs, they generally come back quite reassuring, but sometimes something comes up that we weren't expecting or we're not sure what to do with. So duplex kidney is quite a common finding. This occurs in around 1% of the population, and it's a varying degree of different kinds of anatomy, but generally speaking, it will be like this. So you'll have the duplex ureters, and they will implant kind of often in different places, but sometimes it can be different to this. Sometimes you have two at the top and then they join further down. But anyway, it doesn't really matter exactly what the anatomy is, but we know that although this is common, it does lead to an elevated risk of UTI and an elevated risk of slightly slow drainage. So children who have been found to have this on the ultrasound, I would generally also request that they have a DMSA and a MAG3 just to see what the urine's actually doing through these duplex ureters. And if they are having slow drainage or they're having recurrent infections, I would have a low threshold to use prophylaxis in this group because we know that their anatomy isn't totally normal. If it's very severe and they're having really recurrent infections or they've got evidence of significant scarring, you might consider surgery for these children to kind of reimplant the ureters and try to get a better drainage. And then vesico-ureteric reflux is relatively common. And as we said, it tends to be identified most easily on the MCUG or MAG3. And again, it's a spectrum of severity. So it can be very mild, where during micturition, the urine just comes part of the way back up the ureter. But it goes through a spectrum to where the urine is coming all the way into the renal pelvis, and in the most severe cases, causing really significant dilatation of both the ureter and the calyces. So this is um, concerning because it gives both an elevated risk of UTI because you've got the urine kind of going round the system, but also if you do get a UTI, there's an elevated risk that this will cause damage to the renal parenchyma just because you've essentially got this what is infected urine coming back up the renal tract towards the kidney and risks damaging the parenchyma. So a child who's having reflux, if they're getting infections, again, will need prophylaxis, at least for some time, and more severe cases will often need surgery. And then renal scarring, which we've also talked a little bit about, but this would be identified on DMSA, and the DMSA is used to identify non-functioning renal parenchyma. So if we look at this scan here, this would be very typical. So this side is normal. You can see this is a fairly normal kidney-shaped side, and this side you can see it's a kidney, but it's like there's a bite taken out in the lower pole and the upper pole. And this is where, like, if you did an ultrasound, you would see kidney here. The tissue is there, but it's not functioning parenchyma, so it's not actually filtering in doing its job like it's supposed to. And this can be for a number of causes. It can be congenital. You can just be born with bits of renal parenchyma that aren't working, but it can be secondary to infection where you've had damage. And usually there's a reasonable correlation between how much of your parenchyma isn't working and how is your renal function. So in a case like this, generally speaking, this child I would expect them to still have pretty good renal function because this kidney looks fine and most of this kidney looks fine. But you can imagine that if a child's having recurrent UTIs and you're taking out a little bite of parenchyma with every infection, cumulatively that will have quite a significant impact on their renal function over time. So again, children who have scarring demonstrated, I would have a low threshold for prophylaxis, and I would also follow them up. Even if their renal function is normal, we want to see how their renal function goes over time because this would be a risk for longer term renal impairment. And then last of all, solitary kidney, which we also sometimes find unexpectedly on ultrasound. This has, again, an incidence of around 1 in 1,000, so not that uncommon. Can be sometimes associated with other anomalies, but not always. And usually these children will have normal renal function. And in fact, the solitary kidney kind of knows that it has to work harder. And so you get this compensatory hypertrophy where it will be larger than you would expect. But these children also kind of have a potentially higher risk of UTI just because they have already only one kidney. So again, if they're having um, recurrent infections, I would have a low threshold to have them on prophylaxis. And they also have some additional risks. So children who have a solitary kidney do have a longer term risk of hypertension, and they should have that monitored, although that could be potentially in primary care. And in girls who have a solitary kidney, they should have a pelvic ultrasound at early puberty. So I would usually do it at the first signs of puberty, like before they would start menstruating, because they have an increased risk of gynae anomalies on the same side. So kind of hemivagina or hemi like a septum, which can lead to sort of hematocolpus if they start their periods and this hasn't been identified. So that's just an important thing to bear in mind for these girls. Okay, so in summary, we've talked about UTI, it's common in children, and we need to worry about it because it may be the presentation of a renal tract anomaly. We know that infection in the growing kidney can cause long-term renal damage. Investigations will depend on the age of the child and the type of infection that they're having, and we've talked about the management of common abnormal findings.
Thank you, Susie. Thank you. We've got your talks always generate lots of questions. Last time I remember, Susie, you had hit 100. So there are some common theme questions. So we've got Ranjit who's asked about urine collection, your views on SPA. Likewise, Lana's also talked about contamination in little kids and how to collect urine or what's the accurate method. Your views on it, Susie?
I think this is always so difficult, isn't it? I mean, I think the best thing if we can get it is a clean catch because it's not invasive. It generally gives a good sample, but we all recognise how challenging that can be, especially in a youngish infant, especially in an A&E department where there's lots going on. I think really it's then a clinical judgment about how you're going to get the urine. So the first thing I'd say is I think if a child is presenting with signs of sepsis or they're very unwell, it's not wrong to give the antibiotics first without getting the sample. We should always prioritize doing the safe thing. And I think that sometimes that happens, but we should try to get a sample. And then your options really for an infant that is um, not, able to pee on demand is really going to be to either do an SPA or an in-out catheter. And in my experiences, if you're going to go for what is essentially an invasive method of urine collection, the SPA is probably superior in terms of the the sort of aseptic technique for collecting it, and you're more likely to get an accurate sample. But yeah, I think it's a clinical judgment on how unwell the child is, how long you've got to wait to try and collect a urine sample, and the overall clinical picture. I think the other thing is if you have a strong clinical suspicion that it could be a UTI, so a child who maybe didn't have normal antenatal imaging and you didn't get the sample, then you can, and you've treated and they've clinically responded to antibiotics and you didn't get an alternative source of infection, you could always do the ultrasound for that child anyway, even in the absence of definitely knowing if it was a UTI, and that way you'll still pick up a significant renal tract anomaly.
Lovely. I think so. There are some questions about the duplex or the solitary kidneys. So Dr. Ahmed Hassan asks, do you suggest regular ultrasound surveillance for babies with single kidneys plus blood pressure and urine dipstick?
I think it's difficult. Yeah, I mean, that's a really good question. And I think that is quite difficult because it's often the numbers of children with this is reasonably large. In our clinic, we do follow those children up. So if they have a solitary kidney, we tend to do ultrasound when they're little, maybe every 2 to 3 years, just to check that it is growing well with compensatory hypertrophy. But if they reach kind of puberty then and that they've had their growth spurt, so when they're kind of 12, 13, if that kidney is growing well and their renal function is normal, we don't need to monitor them so closely. And at that point, I would discharge them usually to primary care. It's also quite difficult in our area at the Royal London. Often our colleagues in primary care really struggle to do blood pressure in little children. But once they're kind of 12 to 13, they are usually happy to monitor that in primary care as well.
And then let's take just two more questions or a combination on prophylaxis. So Paul and Susie have asked questions. So Paul has asked about prophylactic antibiotics. How do you decide whether to continue them at the 6-month review?
So yeah, so I would say there's kind of in my in my experience, there's sort of two different groups that you're giving prophylaxis to. So if it's a child who you know has reflux or you know has scarring, I would generally continue antibiotics until they stop having urinary tract infections and until they're toilet trained. So in little children, especially the ones that are in nappies, I think it's much harder to clinically identify a UTI, particularly for the parents in those little children that are often limited language, no, not toilet trained. That those ones I think you should keep on prophylaxis till they're a bit older. For children who you've started antibiotics because they're having kind of just a sequence of UTIs and you can't seem to break the cycle, if you've done 6 months of prophylaxis and they haven't had a UTI, I would always stop at that point and just see how we go. And I think for that group, in my experience, often the 6 months of prophylaxis is just enough to break the cycle, let everything settle down, and they usually do very well. They rarely need to restart it.
Perfect. And then Susie's asked a question on duplex kidneys, kids who are on prophylaxis. Do you have a rough guide of how long they should use the prophylaxis?
So again, I think duplex kidney, I would put it in the same group almost as um, the kind of reflux group. Often, even these children who do have slightly slow drainage with the duplex, as they grow and their anatomy just gets a bit bigger, often everything does get better. So I would treat duplex the same way as reflux. If they're not toilet trained, they're not verbal, I would continue it. But if they've got to the point where they're confidently toilet trained, you feel like you could spot a UTI quite easily, I would stop and then just be very vigilant for the presence of UTIs. And if they get a UTI when you stop prophylaxis, then I would generally restart.
Brilliant. Susie, thank you. For all our delegates, the other questions will be answered by Susie. So let's crack on and go to the next talk, Susie, which is on hematuria, I guess, and IgA nephropathy.
Yes, absolutely. So this next talk, we're going to focus on hematuria, and then we'll talk mostly about HSP, which is now called IgA vasculitis. So hematuria, we're going to focus on the causes of it, the red flags, how we're going to do a workup for it, and then as I say, I'll come to talk about the IgA vasculitis update. So hematuria may be the presentation of underlying pathology, and it can either be the kind of initially the presenting feature. Parents who see hematuria are usually quite worried, and it's often the thing they bring their child with. But it also might be that it's just microscopic hematuria that we find incidentally when the urine is dipped for another reason. And really, the way we would work this up and think about it really depends on whether it's macroscopic or microscopic. So for macroscopic hematuria, the red blood might be seen kind of in the toilet, in the stream, or in the nappy. And there's quite a broad differential. First thing to say is it's not always blood. So it can be urate crystals in a kind of often in a newborn infant, you know, those little orangey bits that you can sometimes see in the nappy. Beetroot also causes the urine to be quite alarmingly red in some people, which is kind of normal, but especially in children, they might be having beetroot for the first time, so we don't always know this. And then some drugs, so definitely rifampicin, but there are others as well. Always consider trauma, which can be directly to the perineum, but could also be abdominal trauma, and always consider child sexual abuse in this group. You might see hematuria macroscopically as part of a more global bleeding disorder, such as leukemia or ITP, but I would say that in general it's quite unusual for the urinary tract to be the only site of bleeding. So if they're having bleeding from other places like, you know, nosebleeds or their gums or they've got petechiae, then you may well see macroscopic hematuria, but it would be rare on its own. Then UTI, which we've talked about, or urethritis, Wilms tumor or nephroblastoma, of course, we would worry about. It may be part of nephritis or nephropathy, particularly if the blood is described as being quite dark. So lower tract bleeding from the urethra tends to be this bright red blood that you either see as drips or that's kind of mixed in with the urine, so you get this pinky colour. But if you've got bleeding from higher up in the renal tract at the glomerular level, so bleeding really in the kidneys, that tends to be more like brown, and patients will often describe it being like tea or cola coloured. And then renal stones as well. So in terms of the workup, key things to ask about in the history would be the presence of bleeding from any other sites, history of trauma, systemic symptoms around fever or dysuria, recent food or drugs, whether it's painful, if they've got stinging with it, and whether it's red or brown. And on examination, be looking for signs of trauma, the presence of an abdominal mass, the rashes such as petechiae or purpura, and then more globally, if they've got hypertension or signs of fluid overload that might make you think more of a nephritis, and then the rest of the urine dip as well. So in terms of investigation, if this seems very much like a UTI in terms of the clinical presentation as well as the rest of the urine dip, I wouldn't necessarily do further investigation. We know that some degree of hematuria can be really common in a UTI. I would have a low threshold for doing an ultrasound in these children, because you're going to be able to pick up a Wilms tumor that way, but also other things like sort of cysts or potentially obstructing stones would all have signs on the ultrasound. Consider doing blood tests, particularly full blood count and coag, as well as renal function. And then if children are having recurrent episodes of hematuria, or if the bleeding is quite heavy, you could also refer to urology for further assessment. And sometimes you do need to do a cystoscopy just to have a really good look inside the lower renal tract and bladder to see what's happening. If it's macroscopic but it's tea or cola coloured, then I would go more with the kind of typical workup that we would do for microscopic hematuria around nephritis. So for microscopic, obviously this is more commonly a chance finding when you dip the urine. You could still have this as part of UTI, but would always make us think more of nephritis. And when we talk about nephritis, that's really a broad group of conditions that are causing inflammation in the kidney. So the most common in childhood is post-strep glomerulonephritis, but it could also be HSP or IgBA, or things like lupus. So lots of things can cause that. There's also Alport syndrome, polycystic kidney disease, and then it can be kind of vulvovaginitis or balanitis. Those dipsticks are super sensitive, so you don't need a lot of like skin irritation to have a small amount of blood. Um, some people have idiopathic, and it can be familial, that there's always a small amount of blood on the dipstick. And then there's, of course, overlap with macroscopic. So any child who's had macroscopic hematuria, even once the urine clears to the point that it doesn't look like there's hematuria anymore, it's usually identified on dipstick for a period of time after. But children with persistent microscopic hematuria usually do need some workup. So in terms of the further workup, there's obviously lots of things this could be. The children who need most urgent assessment are children where there's any suspicion of either something like ALL or ITP with a bleeding tendency or a Wilms tumor. Or if you think there could be a chance of child sexual abuse, children who have signs of hypertension or fluid overload that makes you worry there's a sort of renal failure element, or children who have stones that you think are causing obstruction. So these are the kind of massive red flags that we want to think about ruling out when we have these children. For microscopic hematuria, this group are not so much a kind of big emergency, but we do want to be able to identify those children who have nephritis, especially if there's any degree of kind of progressive renal disease or underlying systemic disease, because picking these children up early will help us like optimize their health. There's a potential for intervention with something like immunosuppression. So we do want to pick them up. So what I would generally say is if you've seen microscopic hematuria, especially if it's in the context of a viral illness or of vulvovaginitis, something like that, because of course children tend to only get their urine dipped either when they're unwell and we think they might have a UTI. So I would always just let things settle and repeat it maybe 3 times over like a month or 6 weeks, just to see if it really is persistent. Often it just goes away. And most children, even who do have persistent microscopic hematuria, will be normal and will only need monitoring. But I would always ask about a history of sort of tea or cola coloured urine in the past, sore throats, if they've got vulvovaginitis, and then also asking about family history of renal pathology or of hematuria. So we know that sort of renal pathology, many of these things do run in families, so that can be really important to know. But also kind of benign hematuria runs in families. So sometimes when you're taking a history, the mum might say, oh yeah, well, when I had my urine dipped in pregnancy, there was always a bit of blood. And so that is a bit of a clue. And then in terms of examination, looking for signs of fluid overload, looking for rashes, and checking the blood pressure and the urine dip. So in terms of the investigations I would do, I'd always do a U&E, LFT, coag, and then the kind of more nephritis screen like the ASOT, ANA, immunoglobulins, and complement. And then, as we said, again, even in this group, I would have a relatively low threshold for doing an ultrasound and quantifying the urine protein. So I've put this in here for your guidelines, but this is the one we use at the Royal London. So we've kind of divided it into macroscopic and microscopic. Children who have persistent microscopic hematuria, but all of the rest of their investigations are normal, so all of the blood tests come back okay, we discharge them to primary care for annual BP and urine dip. And if they develop either hypertension or proteinuria, then they need to come back for further workup. But if things stay okay, then they just need this annual monitoring. And then the children who have abnormal investigations, we would kind of divide into urology or nephrology, depending on what the underlying cause is likely to be. Okay, so just for the last few slides, I wanted to talk about IgA vasculitis or henoch-Schönlein purpura. So there's been a new guideline that came out just towards the end of 2023 that's joint between the UK Kidney Association and the RCPCH, which just updates kind of management and clarifies this name change. So um, IgA vasculitis is a systemic inflammation of small vessels, and you get this perivascular IgA deposition. It's the most common vasculitis of childhood, and it has quite a broad range of things. So we always think about it as nephrology, but actually the range of presentations you can get is huge. So you typically get this cutaneous vasculitis or purpura, but it can also give you arthritis, GI tract pathology or pain, and then nephritis. And actually, in terms of the disease burden acutely, the things that children often come to hospital with, or that they often have the most difficulty with in the initial presentation, is things like the GI disturbance or the arthritis. But in the long term, the nephritis tends to be the thing that causes the most morbidity. And it's quite a broad spectrum. Many children will never have nephritis or will only have very mild renal involvement, which will not be a problem in the long term. But for a significant proportion, they do have long-term renal problems. And certainly if you look at adults or people in their early adult life that are at end-stage renal failure, having dialysis or transplant, this is quite a significant number of them, actually. So we know that some people do progress to significant renal impairment all the way through to end stage, and that can be quite a long process over many years. So the clinical presentation, oops, sorry, I've lost can't see my bits here, but yes, anyway, you typically get these purpura. Sorry, on my slide, I can't see the words here, but I think hopefully you guys can, or it's in the things I've sent you. You get these classic purpura, which are on the lower limbs and again can be on the buttocks. And just I put in this slide just to highlight that in children and young adults with more pigmented skin, it often is much darker and can easily be kind of not recognized from what we're maybe used to seeing in our textbooks of these very bright red purpura. So just to be aware of that. The rash is present in over 95% of cases. So if there isn't a rash, it would be less likely, and think of alternative diagnoses. They may also have joint swelling. They normally have a degree of kind of systemic upset. So they don't feel awful, but they often have a bit of a fever, feel a bit washed out. And then you might see PR bleeding, abdominal pain, arthritis, all these things. If the skin rash doesn't look typical or the distribution isn't typical, the new guideline advises skin biopsy. And we probably don't do skin biopsy enough in these cases. So the skin biopsy is diagnostic essentially. So if there's any uncertainty, that's a really helpful investigation to do. In terms of the management and monitoring, what we want to do is treat the kind of in the acute presentation, we want to treat things like the GI disturbance or the arthritis, and then we want to in the longer term, focus on management and monitoring of the renal function to pick up those children who are going into a more aggressive nephritis. So to monitor for nephritis, you should do a urine dip at baseline and then weekly for 6 weeks and then monthly for 6 months. That's in the new guidance. So you're looking for development of significant proteinuria. Then for blood pressure monitoring, the BP needs to be checked at baseline presentation. And if it's elevated or if they develop significant proteinuria, it needs to be repeated. But if the blood pressure is normal at presentation and they don't have proteinuria, they don't need to keep having their blood pressure done. And that's a change in the new guideline. So the previous guideline also recommended kind of weekly blood pressure monitoring. And certainly in our centre, this has been quite a significant update because getting the blood pressure done in primary care was so challenging that we were seeing these children a lot. But actually with the changing guideline, we've been able to rationalise our protocol for management. So when we think about nephritis, it is defined as, in the context of IgAV, the new guideline identifies significant proteinuria as a protein creatinine ratio of over 250 for 4 weeks. So that's really a lot of proteinuria. That's near to nephrotic range. Or a slightly more modest urine protein creatinine ratio elevated for 3 months. So even children who have a little bit of proteinuria often won't meet these criteria, or anyone who has proteinuria with significant renal impairment or a clinical nephrotic syndrome. So if you've got such heavy proteinuria that you've dropped your serum albumin and you've become edematous. So children who meet these criteria they should be referred early to tertiary renal center because these children are the ones that may well need a renal biopsy and have the most to gain potentially from very aggressive immunosuppression. So children who have this and then have biopsy evidence of ongoing aggressive nephritis would often be kind of pulsed with methylprednisolone. As for these children are by far the most at risk of going into kind of significant renal impairment, moving towards end stage renal failure, and they're the ones that have the most to gain by being picked up and having aggressive treatment. So, in summary, we've talked about hematuria as a presentation, the management of it, and the need to kind of distinguish between macroscopic and microscopic, focusing on the key aims being to identify significant underlying renal or systemic pathology and identify those children who need ongoing monitoring. Some children will need referral for renal biopsy, but most can be managed in primary and secondary care. And then we've had a little update on IgA vasculitis.
Thank you, Susie. Very, very popular talk, and questions are coming up. So brilliant. Some common theme questions again. So we've got a couple of questions from Tejas and from Sunil about exercise-induced hematuria. How common is it, or if there's nothing else on workup, only sort of a bit of hematuria, what do we do in monitoring these kids?
Yeah, no, I think that's absolutely the case. I have also seen that quite young people who, I mean, it tends to be the older children, sort of maybe the more like the teenagers. If they're doing a lot of sport, they can have a degree of, exercise induced both hematuria and proteinuria actually. So in that group, what I would do is I usually give them some dipsticks and get them to dip their first morning urine over a bit of time and kind of do a bit of a log because I think if the early morning urines are clear, that's extremely reassuring and is much less likely to reflect underlying pathology. I think again in that group, if they don't have morning proteinuria or hematuria, I would be reassuring and I wouldn't kind of continue to monitor or work them up.
Uh, so Arif asked a couple of questions. I think so. The first one was answered in your last slide about the blood pressure issue in HSP, and I think so. That's what the plan is, isn't it? With difficulties in getting blood pressure in GP practices.
Yeah, I mean, I'm sure that this is, I mean, obviously it's a huge problem for us locally, but I understand it to be a problem, nationally, really. So I think that is one of the reasons why the national guidelines have changed to kind of reduce the need for this really regular blood pressure monitoring. I mean, yeah, I think it's very difficult in young children who need regular blood pressure monitoring to do that anywhere other than in secondary care. I mean, the other thing we've done is often our community nurses, children's community nurses, have been quite good at sometimes being able to do that at young people's homes as well. So that might be another option to think about. But yeah, certainly in the new guidelines, if the blood pressure is normal at presentation and they remain well, we don't need to keep kind of trying to do their blood pressure.
And then Arif has a follow-up question on role of steroids in severe joint pain affecting mobility. And that's, I think so, maybe a discussion rather than straight away starting, isn't it? I don't think we would be
Yeah,
throwing
I
it
mean,
that easily.
absolutely. And I think one of the things that's really helpful in the new guidelines is that it really emphasizes the role of specialists in managing the different elements of IgA vasculitis. So recognizing that this isn't really a renal problem as such, it is a multi-system vasculitis, and that children who have significant, for example, joint involvement, that should be managed by rheumatology rather than, nephrologists necessarily. So I think I agree. Like I wouldn't rush to give steroids, and I think, but maybe they will need steroids, and certainly some children with this will benefit from steroids. I think the other thing, just to be really clear on, is that it's really important prior to giving steroids that you feel confident in the diagnosis, because once you've given steroids, it will make it slightly more tricky, to get information from potentially from a biopsy. So I would always kind of discuss these children with, specialists early if we're looking at that sort of thing.
And I think so. The same question by Dr. Go about steroids in IgA nephritis, HSP. Again, I don't think in secondary care we would be doing it. This is something discussions have to happen, isn't it? With tertiary.
Yeah, I think generally speaking, yes. I mean, absolutely, steroids are definitely used in this condition, and some children will benefit from them. But I think it would be after discussion with, tertiary specialists and discussion about whether a biopsy would be indicated prior to giving them as well.
And then one more question. So Dr. Rakesh Ravi from Newham asks about IgA, HSP nephritis, and IgA nephropathy, Berger's. What's
Okay.
your approach and what are the differences?
Oh gosh, okay, yeah. Well, I mean, first of all, they have quite similar names, but they are really different conditions. So I think that's the first thing to be really clear on is that this is, so yeah, I think like IgA nephropathy is a sort of different condition that involves kind of IgA deposition around, and it tends to present in older children, and it doesn't tend to involve the rash. So I think, yeah, they're very different. I mean, they can both have hematuria, but yeah, I would sort of generally not kind of um, think of them as the same thing, although their names are quite similar.
Lovely. I think, Susie, we've answered a lot of questions. And let's go to your last talk. Thank you, Susie.
Okay, great. So this is the last talk, and this one is going to be about proteinuria and then childhood nephrotic syndrome. So we'll think a bit about proteinuria in general and the workup, and then we'll come on to nephrotic syndrome. And with the nephrotic syndrome, I feel like people are generally quite confident with managing it in the acute setting, and those are obviously the children that tend to come into hospital. But I'm going to focus a bit more in this talk on the kind of outpatient management and follow-up of children who we know have um, nephrotic syndrome. Okay, so oh dear. So proteinuria, and again, apologies, these are not pulling through, but proteinuria is often a chance finding on a dipstick. It doesn't tend to be the presentation unless it's very heavy. And once you get to 3 to 4 plus proteinuria, that's the kind of degree of proteinuria that if you have that for over time, you will drop your serum albumin and become edematous. And it's always important to interpret it in the context of other things in the urine dip. So the differential for proteinuria is quite broad. It can be a normal orthostatic response, and children tend to have a more exaggerated orthostatic response than adults. So we touched on this in the Q&A, but it's not uncommon for children to have, 1 to 2 plus of proteinuria, particularly towards the end of the day, especially if they've done like PE or sport and they've been active. So if you see a child in clinic, towards the end of the day, you may well see some protein, but it shouldn't be there on the first morning dip. It's also normal to have a little bit of proteinuria in the context of a fever. It's very common in UTI, but usually it would be associated with either with leukocytes and nitrites. Of course, nephrotic syndrome, and in nephrotic syndrome we would expect to see heavy proteinuria, so 3 to 4 plus. But also we see proteinuria in the context of any renal pathology. So really, when you get glomerulonephritis or any degree of renal failure, you get this sort of filtration of protein at the glomerular level, which you shouldn't really see. So any proteinuria should always raise the concern of renal pathology. So when we think about heavy proteinuria, we're talking about 3 to 4 plus on dipstick, and that is likely to be significant. It would be rare to have that degree of proteinuria just from like a fever or an orthostatic response. You could see this for sure in the context of a UTI, but again, you would expect other findings on the dipstick. Then nephrotic syndrome would be the most common cause of persistent heavy proteinuria. You may also see it in kind of renal failure, particularly when your renal function becomes significantly impaired. So an EGFR down at around like 30 to 40, you can start to have a lot of protein leak. And then nephritis, so any inflammation at the glomerular level will also tend to give you this protein leak. So we're quite a broad differential. In terms of the approach, I would always ask about the presence of things like dysuria and fever. Is there any suggestion of a UTI? Asking about family history, if they've ever had hematuria, and then general signs of hypertension or fluid overload. Does this look like a child who's got, evidence of nephritis or renal failure? The rest of the urine dip, and then thinking about kind of whether they've got signs of nephrotic syndrome. So have they got evidence of edema or ascites? So when we think about nephrotic syndrome, it is relatively common. It's 2 to 4 cases per 100,000 children in the UK, and it's by far the commonest glomerular disease of childhood. It's much more common in South Asian populations. So at the Royal London, where I work, we have a really big clinic for this. And when we talk about the syndrome, it's a clinical diagnosis, but we know that there are different kinds of histological changes and processes that drive this clinical syndrome. But by far the most common is the idiopathic form. And although we don't do biopsies in most children, if we did, they would have normal histology. So the clinical diagnosis requires a triad of heavy proteinuria, so more than 3 plus or 300 milligrams per millimole if you're doing it on the quantification. And you have to have such heavy proteinuria that you've essentially dropped your serum albumin to less than 25, and then you've become edematous. So all 3 of these things are required. Can you move the slide on, please? So at first presentation, Children need basic investigations. You need to do some bloods, and you really need to do that anyway to make the diagnosis with the low albumin. I would generally send the urine for quantification, and it's also helpful if at the start you can check their antibody status for varicella. What we want to do is identify children who are likely or possibly going to have a different diagnosis or a different histology. And those are children who have atypical features. So children who are either very young in the first year of life or post-pubertal, children if it's associated with macroscopic hematuria, although microscopic is quite common. If there's an associated significant renal impairment, if they have hypertension, if that needs to be really, if it's before they've had prednisolone. Once you've treated it, hypertension is quite common. Or children who've got a kind of slightly borderline proteinuria, so not necessarily like 3 or 4+, but children who've had 2+ proteinuria, but for quite a long time can also drop their serum albumin. And in those children, their clinical picture might be more one of like a nephritis. And then if there's any doubt, you're not sure, it can be helpful to send more of a nephritis screen, which will help you to distinguish between nephrotic and nephritic syndrome. Next slide. So in terms of the initial management, and I think this is often what we're actually a bit more confident with and we see a lot in hospital, we want to get children into remission, reduce and or prevent the kind of risks of acute morbidity, which are primarily kind of becoming intravascularly very depleted, venous thromboembolism, but also reducing their risk of being on long-term steroids, which we're aiming to do, and then monitoring them for complications. So there's a national guideline for this, which I put here, and so at initial presentation, we would normally do 4 weeks of high-dose steroids at 60 milligrams per meter squared to a max of 60. And then if they're in remission at 4 weeks, you wean and you go to 40 milligrams per meter squared on alternate days for another 4 weeks, and then you just stop. So that would be the full protocol for an initial presentation. Next slide. And then as well as that, other things you might consider in the acute treatment phase would be giving IV methylprednisolone. So this would be an alternative to oral prednisolone if they aren't tolerating the oral steroids. So this is particularly good, I think, for children where they've got a lot of ascites, and if they've got sort of diarrhea or vomiting or just really severe abdominal pain and they're not tolerating oral medication, then IV treatment can be really helpful. I've also put penicillin B prophylaxis on here. In the protocol we use, the Great Ormond Street and Royal London ones don't include this, but I know a lot of other centres do, and this is given as prophylaxis for peritonitis. I would always give a PPI for gastritis cover. These are really big doses of steroid, and I also think it's really important to warn parents that these are high doses of steroids and that they are likely to see side effects, especially around kind of sleep, appetite, behaviour. And I think what often happens is children, expend a few days in hospital as part of their acute admission, and then as they go home, these steroid side effects really ramp up. So really important to warn parents. Next slide, please. So then in terms of what happens next, this is often where people get a bit more confused or it's a bit more tricky. So we would say that they have gone into remission if they achieve trace or negative protein for 3 consecutive days. It is defined as steroid sensitive if at any point in that first 28 days of high dose steroids they go into remission, regardless of how long it takes. Where it's steroid resistant if they don't achieve remission. And then children who go in remission but relapse, either when the pred is weaned or within 14 days, are dependent. Then relapse counts as 3 consecutive days of proteinuria. And the important thing to note is that for relapse, you don't need to wait for the albumin to drop. Frequently relapsing counts as 2 or more relapses in 6 months or 3 in a year. Next slide, please. So in terms of how this falls, about 10% of children will be steroid resistant. So it's quite rare, but these children should have early tertiary referral. They may need a biopsy and they may need a different approach from steroids. So some of these children will have tacrolimus, and overall, this group of children will have a worse prognosis. Of all the ones that were steroid sensitive, about 20% will never have another relapse. So those children do need follow-up, but most of them will not need sort of long-term follow-up. They just need safety netting. But actually 70%, so the majority of children will have relapses. So although I think we often, are quite reassuring when we talk to parents, we do need to recognise that for many children, this will be a long-term condition. So Of the ones that have relapses, about half will meet the criteria for frequent relapses. Next slide, please. So as we said, relapse can generally be managed in the outpatient setting. And what tends to happen is the first time that children get nephrotic syndrome, it's like no one knows what's going on. So they get really nephrotic. So they've got this really low albumin, they've got really edematous, and then you have a long time to get them back to their baseline. Whereas with relapse, what we're hoping is that parents will identify it quite quickly so we can get them on steroids, get them back into remission, and they don't need quite so they're not quite so tricky to manage. And the relapse protocol is generally a bit less steroids. So I've put it on here, 30 milligrams per meter squared until remission, and then you kind of go down 20, 10, 5 over the next 3 weeks, and then you can stop. So the ideal is that with relapse, you're going to have less steroid exposure. But if they're really edematous or they're very unwell, or they're not going into remission, then you need to give the high dose. It's really important that families will be dipping the urine every day, just to check when they are going to remission, because knowing when they're in remission is going to be really important. Next slide, please. So then we're left with this group of children who are having either really frequent relapses, or they're not having frequent relapses, but we just cannot get them off the steroid. And this group of children are by far the ones that have the most steroid burden, they get the most side effects. So this group of children are the ones we might start another drug just to try to reduce their steroid exposure. I'd usually do this sort of in discussion with the tertiary centre, and there's a few different options. So Lebamazole is an anti-helminthic drug, and this one is highly effective, but generally for the children where their relapses are quite mild and they're very steroid sensitive. So the ones that are kind of going into remission really quickly. For children who have more kind of difficult to control relapses, who are needing like high dose steroids to get them into remission, generally tacrolimus or MMF will be a better option. But in any case, there's often a bit of trial and error. So you often have to rotate through these to find the best result for each child. But children who are not responding or not well controlled with lebamazole, tacrolimus, or MMF, you might think about giving a rituximab infusion, but this is only approved where other therapies have failed. So they need to have tried these other options. But in children who are not responding to those, rituximab can be highly effective. Next slide, please. So this often comes up about immunizations. So generally the advice is that where possible, children should follow the normal schedule, but we would always recommend avoiding live vaccines in children who are on immunosuppression within 6 months of rituximab or within 3 months of high dose steroids. So certainly for our kind of frequent relapsing group, this is quite a lot of them because they've often had a relapse and are weaning down on steroids, or they're on a second agent, or they've had rituximab. So for these children, they need to avoid live vaccines. And these particularly tend to be an issue for either the MMR booster, just because of the age that it's given at, and the intranasal flu, which is given at school. And often because with that one, especially because it's intranasal, people don't often they don't think of it as that bad, but we need to tell families don't tick the box for the flu at school. They can have the IM flu at the GP. And we also need to remember that even for vaccines, which aren't live vaccines, they may not make an adequate response. So sometimes they might need to have these vaccines again when they're older. Next slide, please. So yeah, an infection is also something that comes up a lot. So we know children with nephrotic syndrome are at risk of infection, particularly with the initial presentation and in relapse. And it can be any infection, but especially like peritonitis or chest infections if they've got pulmonary effusions. Important to know their VZV status at diagnosis. And then if they have a significant chickenpox exposure, we should repeat it, even if they've previously been immune. And if they're non-immune, you have a low threshold to think about giving immune globulin. If they develop clinical chickenpox while they're on immunosuppression, we would generally treat with acyclovir, which can be oral, but if they're becoming unwell or they're getting worse, then IV would be helpful. Next slide. And this I just put in because I think that, families who have children with frequent relapsing or steroid dependence, it is a big burden. It's a kind of unpredictable condition. There's a lot of side effects on the steroids for both little children and in our young adults. Our older patients really struggle with acne and striae, and they hate it. There's a lot of uncertainty. Families have to constantly be monitoring for it. And I think probably compared to other long-term pediatric conditions, there's probably less understanding in the community, in schools and nurseries, people haven't even heard of it. So I think we do need to really support this group of families, and they need a lot of explanation and reassurance. I think that's the last slide. Thank you. So in summary, back to before, we have proteinuria relatively common, may be normal and resolved, but may be a sign of underlying renal pathology. We've talked about nephrotic syndrome, the disease course, atypical features, and when to refer. Thank you. And apologies again for both the technical issues and the upper respiratory tract infection.
Man, Susie, you're doing wonderful. Don't worry. I mean, thank you. You know what? My heart would have been in my mouth. The way you were so cool and relaxed. Brilliant. Thank you, Susie. I don't think we have a lot of questions. So maybe just there was a couple of questions on methenamine. You know, the new med you're talking about. People are asking about how long to use it, when do you stop it, that sort of thing. Maybe we can just take one of that question that reduces your
Yeah,
question.
of course. So that's a medication that's for prophylaxis of urinary tract infection, and it's licensed by NICE for use in, I think I've lost the slide now, but I think it's for children over the age of 6. So it's sort of the slightly older group, and it's most effective in children where their recurrent urinary tract infections are with E. coli rather than the more atypical organisms. So if you're starting it, the same as for antibiotics, I would do it for 6 months. If they're having infections on it, it's probably not effective. And for that group, I would probably stop and switch to like a more traditional prophylaxis with antibiotics. If they don't have infections, after 6 months, I would discontinue it and then see where we are.
And likewise, Anna's asked, do you routinely acidify urine using Hiprex? Hiprex is the same med, is my guess. That's a commercial name. By using
Yeah,
alongside vitamin C. Do you do it routinely acidify? I don't. I mean, normally we don't. No?
we don't generally do that in children. I mean, I think sometimes families ask about it, but yeah, I would go for the one that's licensed.
In fact, delegates can take your cup of coffee and other things while Susie answers. I mean, we will come back at 11:20. But maybe, Susie, do you want to take one more question and then we take a break?
Yeah, of course. Yeah.
So, I mean, the question which was asked was about uh, the role of prophylactic antibiotics indications. It's there in your slides, but anything specific about it?
No, I mean, I think that the key kind of there's two key groups that I would consider prophylaxis in. So the first, which I think is often one that comes to us in secondary care, is just children where everything's essentially normal, but they're just still having recurrent infections. And I do think for that group, there probably is a degree of like they've just got a urinary tract that's become very inflamed. And so even though you are clearing the infection with the antibiotics, they're just getting another infection very fast. And I think that group do really well with a short course, like 3 to 6 months of prophylaxis, either with antibiotics or methenamine. So that group, I think we don't need to worry too much, but it often makes a huge difference to the family and the young person if you can sort of break that cycle. Then the other group are the group where you're worried about their kidneys. So either they've got scarring or they've got reflux or duplex or something that means they're high risk. For that group, again, I would get them on prophylaxis because I think that is something we can do that is like, going to protect their renal health in the long term. And again, I would do 6 months or until they're toilet trained. And then after that, I would stop. But if they get infections again, I would just get them back on prophylaxis. We know that kind of prophylaxis is small doses of antibiotics and is safe in the long term and much better than having frequent infections.
And yeah, sorry. So just let's take Susan's just asked a very relevant question. Last question. Nephrotic syndrome. Kids not tolerating it. They're vomiting the pred. Do you give stress doses of hydrocot or methylpred when they don't tolerate their medicines because of vomiting illnesses?
So that's such a great question. And there is actually currently some work going on nationally around this because historically we have not tended to worry about this in this group. So I think if a child is not tolerating their oral prednisolone, you can think about giving IV methylprednisolone. And I would definitely do that if they are in relapse because getting them into remission is really important. I think a child who's in remission and weaning down, but they're not tolerating, is slightly more tricky because you would be less keen to give methylprednisolone. I think it's important. We wouldn't generally do a routine protocol for stress doses in nephrotic syndrome. That isn't in the guideline that we use with Great Ormond Street. But what it says in their guideline is that if a child becomes significantly unwell, so I think more thinking about a child that you might be wondering about sepsis or severe infection versus not tolerating it, to have a low threshold to consider giving rescue hydrocortisone for those children. So I think it is more of a clinical judgment based on how unwell they are. But I also think we might be changing this advice quite soon. So I will look forward to giving an update when there is any national guidance.
Lovely. Susie, big thanks again. Amit is my consultant colleague. He's now my boss. He's our clinical director. And he is a general pediatrician with epilepsy and neurology, which are his interests. So over to you, Amit.
Thank you. Thanks. Yeah, so nice to be back again. Great to see such a big audience actually. So still loads of interest in this really important course. Two talks today. One of them is new, one of them is refreshed, let's say. So I'll start with that one. So it's about first seizures, what we'd expect from somebody presenting with a first seizure, what you should do and approach to that, how you should then proceed in terms of referral, perhaps diagnosis, safety advice, all the actions you should take, and then a little bit about initial management. And obviously, very happy to take the questions through the usual route. We will answer all of them. So what I'm going to cover is exactly that. So first seizure clinics, everybody knows first fit clinics. First seizure clinics, I suppose, is what they're more officially called. Why do we have them? What do we actually look at? How do we do it? What do we advise? How do we diagnose and treat epilepsy? And any key practice points in this talk, I think highlighted red, um, just to remind me really. So why do we have first fit clinics? So firstly, epilepsy is a common long-term condition. So people often talk about the triad of asthma and diabetes and epilepsy, but normally epilepsy people say that because they say, "Oh, we don't get as much as asthma and diabetes," but it is really common, and the best available figures we've got are out there. They're still quite old, that number, but as in we haven't got newer ones that I know of. But the idea of 63,000 or 112,000 under the age of 25, 63,000 under the age of 18 across the UK. I think that's a massive underestimate. Just knowing the size of our caseloads where I work, it would seem to make up a fair proportion of that. But if we do take that and extrapolate it, that would give us about 2,000 children and young people in London. We know it's more than that. But that would equate to one or two people in every mainstream primary school, four or five in every mainstream secondary school, and obviously a lot more proportionally in a special school. And the reason we have first fit clinics, well, that came about really from the turn of the century. There were loads of issues, sorry, there were loads of reports that came out, like concerns about quality. So under and over diagnosis, both were a problem. Lack of communication across the system, loads of variation in how people approach things, and lots of fragmentation between those different services. And in more recent years, even this is becoming much more embedded now. I'd say over the last 10 years, loads of evidence about the broader impact of epilepsy. Not necessarily know that we don't necessarily know the causative pathway, but it's a brain condition. It causes lots of things that would also relate to a brain not working perfectly. So lots of cognitive issues. Certainly, children are at risk of those. Psychological issues, stuff about their learning, clearly, lots of emotional issues and quality of life. So there was a school age study years ago, which I still always quote, and it said 95% of people who were school age with epilepsy had issues in at least one of those areas, but they were not recognized as having them. So they hence were not getting help, whether that is medical or in a lot of cases educational or mental health. If we didn't know to look for it, we weren't going to do anything about it. So the key questions I think we'd ask at a first assessment, well, this is what I do in a first fit clinic, essentially. I go through, are these seizures? Sometimes people are referred with things that are not, but they're suspected. That's fair enough. If I think they're seizures or it was a single seizure, do I think this is epilepsy? And there's a sub question, if so, do they need treatment? Next question is, what do I do for the patient now? And I think actually all these things apply when you see them, even as not a person who does epilepsy in a clinic. If you see them in A&E or in primary care or whatever model now, if you see them in a neighborhood MDT type thing, who knows? These are fair enough questions as an approach. So let's see if these work. This is all interactive. I know some other people have used Menti. If you scan this with your phone, the QR code, you should be able to answer this. Tell me and the audience, what you think are clinical features that would be sensitive for an epileptic seizure. Yeah, lots of responses coming through. Great. You should be able to do multiple responses. And as soon as you scroll down and press submit, they should appear on here. Yeah, so lots of people spreading their votes. I think people probably put multiple answers, which is great. So quite a lot of people think loss of consciousness is a thing that would mean it was an epileptic seizure as opposed to anything else. Jaw clenching is in there. Movements of the limbs. Obviously, we can have different types of seizures. So, but I get that point, and lots of people think post-event confusion. All right, thank you for that. I will move on. It's interesting, isn't it? So actually, the only thing there's not great evidence for any of those being very specific. You could have a vasovagal event and have jerking. You can clench your jaw with that. The only thing that actually, if you have a reliable history, and even that's difficult, would be eyes, the eyes being opened as opposed to being closed. So sometimes if you think about a non-epileptic or a functional seizure, if you've got your eyes firmly closed whilst doing this, the movements that are being described, or if you've seen a video or something, then it's really unlikely to be an epileptic seizure. And the other factor is the first one there. That's taking a good history from somebody who does it all the time, which is great for people who do it all the time because it gives a bit of support for the fact that we might be doing a decent job. The rest aren't sensitive, and that's really interesting because those are all things we ask about, and sometimes we ask very closed questions in that way, don't we, when we're asking about the nature of an event? And maybe we shouldn't be because maybe we're sort of fishing for things that aren't there. Is it a seizure? So these are just other things it could be, and then the second talk will go into this in more detail. But here's a broad way of thinking about it. You can have things that are syncopal, things that are behavioural, things that happen in sleep, things that are movement disorders and not seizures at all. Even migraine, and then what we've just called miscellaneous. And this is what the International League Against Epilepsy have as a nice classification. I think it is a good way to think about it. There's a different way that I'm going to go through in my other talk. So if we think they're seizures, the history is absolutely key. So what we call the semiology, which is how the event starts and then progresses. So ideally, you want to get history from the young person. You want to get a history from somebody who's witnessed it. How were they before? How did they feel? Were they feeling absolutely normal and this came out of the blue, or were they unwell with something, or did they just have a feeling or experience something that was different than normal? That can be key to try and classify what the event is, and if it's a seizure, what type of seizure. Obviously, what happened during it, which the young person may not know themselves, but you still ask them, and if they say actually there's a big chunk of time that's missing, that's useful too. And how were they afterwards? So we talked about post-event confusion, for example. So if they've had a really prolonged paroxysmal episode, let's say we don't know what it is yet, and then within 20 seconds they're back to normal selves, that is not typical for an epileptic seizure if it's completely disproportionate. You need to consider the things that aren't epilepsy. Video, I think, is going to be what actually should be in red because it's a key practice point. It's really difficult to get, and I do get that with families, but if possible, it is the thing that might discriminate or distinguish, probably a better word, between something that is a seizure and perhaps epilepsy versus something that you can classify as something else. And it's also a good way for you to be able to share it with colleagues who, if you're not quite confident to make that call, they might be. And it speeds things up for a family. In their past medical history, things about obviously their birth, if they've had HIE, they've got a structural brain issue because of that, then clearly they have a good setup for epilepsy. That's a relevant risk factor. There might be other comorbidities, certain genetic comorbidities you know about, or even autism, ADHD does increase your risk of seizures or epilepsy over the life course. So that's relevant too. And obviously a family history. So those are the key things. There are other things that are relevant too, but those are the key ones. Special note about febrile seizures. So these are seizures in the context of a fever at the right age, obviously up to sort of 5 or 6. Doesn't have to be at the upstroke of fever like I always used to learn. It's in the context. So you could have your fever afterwards. You could come to ED having not had your fever and suddenly you have it. You could have had a fever, the seizure, and then a couple of hours later had your fever, and it's still, if you're otherwise happy that it's not anything else, can be classified as a febrile seizure. Complex febrile seizure is more than one in the same illness. That just needs a longer period of observation rather than anything else. Don't necessarily then need to refer any of those. Apart from febrile status, I think is probably one that you should, because that does and has been demonstrated to increase the risk of epilepsy. And the red flags I put there are about Dravet syndrome. So if you have really earlier than expected febrile seizures, so not in that typical age group, so sort of less than 6 months typically, or if the seizures that happen in the context of a fever are hemiclonic and then progress to being multiple seizure types. Hopefully you get it from the hemiclonic bit. That's a cardinal seizure type for people who develop Dravet syndrome. If they have febrile status, that's, as I've mentioned above, it's a risk factor, and the fever and hot water thing. So these are things to look out for, and there's a link there at the bottom. In the should I refer bit, so if you were to see them in a setting that's not an epilepsy clinic and think, what should I do? Well, I think if you think it's something that's not epilepsy, so that slide a few slides ago that talked about non-epileptic events or paroxysmal events, and you're confident to call it that, then you can reassure them. especially if you've got a really clear history or a clear setup for, say, a breath holding attack. We do that all the time, I'm sure. If you're not sure, you can discuss with a pediatric team, or if, depending on your setting, a pediatric neurologist. But it doesn't need to be then necessarily, if you're happy that the child's stable. However, if you think it's a seizure, then there's clear, nice guidance. You go down the route of looking for causes of a provoked seizure rather than an epileptic seizure. So you do the bloods as listed. You do 12 lead ECG, and unless you've got a high index of suspicion that it's a cardiac cause, which I would normally not, then you don't need to go further down that route. But that's as a baseline. So next question is, what advice would you give after a first seizure? This is another one to scan and enter what you think is relevant. It's interesting to know what people do say in this setting. So you can just type in and it'll come up as a word cloud this time. No solo swimming. Okay, I like that. Kind of. So swimming is fine. Swimming is fine. If somebody's supervising, if there's a lifeguard and it's a pool, that's okay. If it's open water swimming or swimming in the sea by yourself, then I agree. Then no solo swimming bit. But a lifeguard can help somebody who's having their first seizure. And I would hope they would get there. And I would hope they would help somebody who had another event that's not a seizure. So lots of stuff about BLS. Great, I agree. Recovery position. Yeah, we'll talk about that. Water safety relates to that. It's getting really small and I can't read it now. What to do? The prolonged seizure is there. Monitoring whilst asleep. Yeah, that's a hard one because there isn't anything proven, validated that I, as a professional, can say, go and buy this piece of kit and that will make it all better, because it won't. It would actually give false reassurance. So as professionals, we tend not to recommend that. The only thing there's evidence for is you can get breathable pillows. So there's a charity called Epilepsy Sucks, which is not a great name, but it's what they call themselves. And if you Google that, then it takes you to a breathable pillow section and a link to buy them. And there is a little bit of evidence about that. But again, it's no replacement for vigilance, unfortunately. And vigilance after a first seizure and anxiety because of the vigilance that's required is extremely high. It's the highest it'll ever be, even in somebody who goes on to develop a really complex epilepsy. Okay, thanks for all of those. I think we'll incorporate most of them. So the two elements really. One is about first aid, and like what you do, what your response is. So you need to keep your child physically safe. You need to time it, because that whole thing about when to call an ambulance depends on the timing usually. So typically 5 minutes for a bilateral tonic-clonic seizure. Sometimes once it's been identified as focal epilepsy, you can have a 10-minute cutoff for that. Some special circumstances will be very individualized, like Dravet syndrome. We tend to say administer emergency medication earlier than 5 minutes, but typically 5 minutes. And then the recovery position afterwards. If they can video it, then even better. And I try and encourage families to do that, mainly because it gives you a timing as well. And selfishly, it's useful for me and for them. It's good too, because then we help to more precisely classify their seizures and epilepsy over time. A bit about seizure safety is the second element. So some people touched on that before. So I think no unsupervised baths is a big thing for me that keeps progressing by itself. That is the main thing. Depending on the age, it doesn't really change things. They might be supervising them anyway, but I think I always highlight that one. Otherwise, I'm not too restrictive. I'm realistic, and I do say, look, the bit about swimming, as I've said when the word cloud was up, the bit about cycling is sort of say, do you cycle? Do you ride a scooter? They say, yeah, okay. Do you wear a helmet? I say no. And I say, well, you said everybody should wear a helmet, actually. So I try not to stigmatize it. It is important, but it can't stop them doing it. And nor do we want to. We want to actually get them back to doing normal things that they enjoy and that help them thrive and develop, and etc. Height, I wouldn't ban them in the playground, which sometimes happens. It's about the supervision that you think is appropriate to a parent, and that needs to be worked out over time and might change over time as things get controlled anyway. Special note about public transport being on the edge of platforms, I suppose, is a quite useful thing to say. I won't dwell on this too much, but in terms of describing seizures, it evolves. So there's another change from the ILAE last year. Essentially, there's the description of what happens. The main change is previously they concentrated on the description of how it started, so talking about focal onset, even though it then evolved. But actually now they're just saying describe the semiology and the chronology of each event, or of the typical event, which I think is more useful. I think that's good. The bit about describing the clinical seizure separately from thinking about the origin of what's going on electrically is probably another point. So generalizer thinking has been up in more recent years that is not useful, because actually generalized is referring to the what's happening electrically that might manifest differently. So a generalized seizure, for example, can be a bilateral tonic-clonic seizure, but it could also be an absence. And those are very different in how they look, and then in terms of how you go on to treat that, the care plan you make, and that sort of thing. So those are probably the key points. And the third point is that it sometimes changes. But I think being as descriptive as possible about seizure or suspected seizure episodes, about literally what was seen and what was experienced, is useful. And that again translates to a care plan. So a school want to know, what am I looking out for? They don't want to know exactly how you've classified it electrically. So that is a really important thing to emphasize. Okay, next question is, if they're seizures, is it epilepsy? So the ILA, you make the rules, those haven't really changed. 2 unprovoked seizures more than 24 hours apart. So you could have a couple of episodes in the same short time period. That's kind of one, if you see what I mean. So if this was to happen, this is what I think we're mostly familiar with. That equates to essentially, all else being equal, about 60% risk of a further seizure. That's a tipping point where we're saying it's more likely that you'll have another one than less likely. Hence, we're going to call it epilepsy. That recurrent risk. A second way you could define epilepsy is by having one seizure, but knowing that you have something that you as a professional equate to a similar risk. You think it is more likely than less likely you'll have another one, even after just one episode. And that will be based on the past medical history and stuff that you've taken and their risk factors. So again, the child with HIE, they've got something unilateral. They've had a focal epilepsy, a focal seizure, sorry, that matches that. Or they have a recurrent risk that is equivalent to somebody with epilepsy. It is more likely to happen than not. So I think that is another circumstance. And the third is if you've got an epilepsy syndrome. So you could have had an event you weren't sure about, you get an EEG done, and it gives a diagnosis that matches that event, and that event is due to an epilepsy. So you could call it then. So that's somebody. So same what we used to call benign Rolandic epilepsy, we now call selects. That is a good example of that. You could have had one of these, and you think, oh, that sounds like that thing I remember reading about that is a Rolandic seizure, and you get that confirmed. Or that's not having had 2 episodes, but it is then fulfilling criteria 3 here. Okay, another poll. Yes, okay. This is always a fun one. When would you, as a pediatrician or healthcare professional seeing children, prescribe buccal Which of these circumstances? So somebody said they will never prescribe it. Okay, I guess that's about confidence. Most people are saying after a prolonged seizure. And once you start to see a big group here, people start to put that as their answer. So it's quite good to maybe pause here. Most people have said after a prolonged seizure. Some have said after an epilepsy diagnosis, and only a few have just said after any first ever afebrile seizure. Yeah, so the majority were right there. So it's a risky medicine, okay, and I'll mention that in a minute. But it's you don't give it to everyone. I know people are desperate to say we're doing something active. I don't just want you to have had this terrifying event and then send you home with nothing. But in reality, that's what you need to do. You need to give the safety advice and the RCPCH leaflet stuff. That's realistic, and it is the stuff that will help. If you give them a medicine that's actually really potent, and we've all probably seen respiratory depression because of buccal you're actually making the problem potentially worse. You're giving them false reassurance that this is going to help. It also is quite restrictive having buccal. So there's really good evidence that it affects participation, sometimes at school, so school trips. And they say, oh no, risk assessment, can't go on that. Certainly affects extracurricular activities and clubs and things like that. And if they don't need it, we've actually done them a disservice by thinking maybe acutely we wanted to do something nice for them. So it's if you've had a proven prolonged seizure, I think that's the circumstance that most of us as pediatricians should be prescribing it. Okay, so after first assessment, so there's the first time you've seen somebody with a suspected seizure. These are the things, just as a reminder to go through, that you are looking at. What are their risk factors that this could be epilepsy, even though it's just one seizure? Just to get a picture in your head, and do they fit any of those criteria even after, or potentially even only after one seizure? But actually, if they've had one seizure anyway, there is, in most places, a first seizure pathway in accordance with NICE guidance. The aim is to see them in less than 2 weeks. That is not, we know from Epilepsy 12 national audit data, That is not common, but that is the aspiration. So quickly, whether that's directly from primary care or somebody who's come to ED. If you're seeing them and they've had their second episode and it was similar to the first, and you don't think it's an epilepsy imitator, you think it is a seizure, then in most places the pathway is the same. You just refer them as if you would refer seizure to the same people. There's a scenario where you're seeing somebody who's had more, so they're actually frequent and recurrent ones. Then you need to decide, is this somebody who needs discussion now? Is this a circumstance where they need some input from somebody with an epilepsy interest or a neurologist, again, depending on your pathway, before they leave? So they've come to ED before they go home. Is this somebody who might need to start medication? That does happen. It's the minority, but it can happen. The baclomidazolam thing I've talked about here, it's a risk and benefit balance. Most children, you just need to tell them when to call an ambulance. You need to emphasize that there are risks. Once somebody's got baclomidazolam, it's very hard to take it away, even when they go on to have epilepsy as a diagnosis, but they're very stable and they're on regular medication, and that risk really gets lower and lower over prolonged seizure. If you are prescribing it and it is an appropriate thing to do, then it's not just a question of writing a prescription and saying, be on your way. They need some training. They need some guidance about actually how to administer it safely. So the initial investigations. So as I said, nice guidance, very clear about, is this a provoked seizure? Well, you need to outrule these things acutely. You don't need to do an MRI acutely or neuroimaging unless there's an indication like there's persistent focal neurology. That's obviously a different reason to do it. What's underlying the fact that they've had a seizure. But if they've come back to baseline, then you don't normally need it acutely. Once they get the diagnosis of epilepsy, it's part of that workup. And there are some epilepsies that get defined as by an electroclinical syndrome, i.e. their EEG confirms a certain pattern, and they may not even need one anyway. So I've listed some of those there. Okay, next poll. Oh yeah, this is about EEGs. So when would you request an EEG as a pediatrician or as a healthcare professional that sees children? Okay, so only one person said never. Two. Some would do it after a paroxysmal episode, so something that was they're not sure what it is yet. Most are saying they do it after a first febrile seizure, and a lot are also saying after a diagnosis of epilepsy. Yeah, so I would agree with the majority again. It's once you're saying we think this was a seizure, rather than going fishing for, you've had some sort of event, I'm not sure if it's a seizure, or let's just do an EEG. And the reason is, what use is an EEG? Well, it's not a perfect test, okay? So firstly, the nice aspiration about when you should have one has changed. It's an aspiration again to try and get it within 3 days. Most places can't do that. And where I work has actually become in it within a couple of weeks, which is fantastic, much better than it used to be. But it seems to vary and it's very patchy across the country. The key thing about requesting one is, what is your index of suspicion that this is a seizure? You need to go into that investigation with an idea of how likely you think this is. And I think it's really important to convey that to a family, because if you just do an EEG and it's normal, a family often will think, well, okay, then what's the next test? But the reality is you did not think it was a seizure. You've requested an EEG. It's normal. Great. That's not surprising. But the family are probably hanging on thinking that investigation was the be all and end all. And it's not true. It's just another piece of the jigsaw. Key thing is to say, even if you have a clinical diagnosis of epilepsy along the lines of what the classification we talked about earlier, the EEG is normal a lot of the time. Okay, especially if you've had a bilateral tonic-clonic seizure, like half the time it could be normal. So, but that doesn't mean it's not epilepsy. Okay, it just means you're capturing them in between seizures. Equally, on the other side, you can see discharge in people who don't have epilepsy or seizures. We know that from a research setting. The big common group that we often see, that some focal discharges in children with autism. That does not mean they have focal epilepsy. It can be complicated because you might be doing it because of an event you think is focal epilepsy. But don't go doing EEGs on everybody thinking it will become clear, because it may muddy the waters. It doesn't rule it in and it doesn't rule it out. But it does aid your classification. So if you have a good idea about what you think it might be, and you think it warrants an EEG, great. If you think they have epilepsy already, you've diagnosed that, then great. It helps with classification potentially, but sometimes it can be normal and it doesn't move you on at all, but at least you've looked. Things that increase your yield of positive findings in the EEG and do help you then is if you can do it quickly, which is why NICE have made that recommendation. If you do repeat ones, there's a cumulative increase in your yield of picking up abnormalities. If you do capture sleep, so that's normally in most places by giving melatonin rather than sleep depriving. And in certain circumstances, if you use provocation, so with absences, if you were to get them to hyperventilate, that should bring out a classic pattern, which is great. So it's much more sensitive to that. And if you're thinking about epilepsy with some photosensitivity, then photic stimulation at the time of an EEG. Okay, then the next question is, if it's epilepsy, so you've now moved on in your thinking, you've now got the child who had a suspected seizure, you've decided it was a seizure, you've now decided you classify them as having epilepsy. Does it need treatment? So this is usually what we do in an epilepsy clinic rather than what you might do when you're seeing them in ED. However, if you've seen somebody with recurrent seizures and you're seeing them in ED, then it is a consideration for you. Well, it's something about the frequency of seizures, isn't there? Because you would think increase the risk. Whereas somebody who's had two very spaced out events, you probably don't need to be having this conversation acutely. Because ideally, if you can go through a little bit of process that we do in an epilepsy clinic and then classify it with the investigations, that might help with your choice of an anti-seizure medication. You can estimate their risk of seizures over the next 2 years, and that's the point about the 60% that I talked about. If they have 3, then I think it goes up to about 75 to 80%. If they have 4, it goes up and up and up the more that they've had. And it's a balance between risks and benefits treatment. So you always need to outline the risks, and best practice at the point of diagnosis of epilepsy is to go through the following things. So I always talk about I escalate things basically. I say, you've seen your child have a seizure, you know that they could hurt themselves. There's a risk, even if it's a focal seizure, that untreated seizures and untreated epilepsy are more likely to generalize. They're more likely to have prolonged seizures and status and go to intensive care and all the morbidity and mortality associated with that. And then there's the SUDEP question. So sudden unexplained death in epilepsy is a thing. It's not directly related to having a prolonged seizure. It's just if you took a massive cohort of children without epilepsy, it's very rare for them to die. If you take a big equivalent cohort of children, but they have a diagnosis of epilepsy, their risk goes up. And the thing that helps to mitigate that risk is having good seizure control and being on regular treatment. So it sometimes is a way of somebody who's resistant to treatment, but I really want them to have it. This is a good thing to go through because at least you've done your duty and been really frank with them. But families of children who've unfortunately died from SUDEP say that they wish they'd had this talk as well. It may not have changed anything. It's very difficult to prove that, but it is something they feel is important, and hence it's become part of good practice. In terms of anti-seizure medications, though, and that discussion, the risks are often overestimated. I think families are very wary of it, but as I said in one of the very first slides, there are loads of associations, a broad impact of having epilepsy on cognition, on learning, for example. That often gets blamed on the medicine, but it's more often the medicine. So you need to put things into that context if you're having this discussion. You need to outline side effect profiles of any agents that are being discussed. BNF's great for that, but obviously the more experienced you are in prescribing things, the more you have a more focused conversation on those sorts of things. And it's a discussion, and there's a bit of shared decision making here. I would try and bring the young person into it because things like formulation matter as well. How do these tablets come? Actually, is it available as a liquid reliably? No. So that means tablets. Can you take tablets? These are all key things, obviously. And of course, the family. So it's this balance, hence that picture. If there's a clear electroclinical diagnosis and you've got a very precise classification, the main reason we do that is because it might change treatment. Okay, so classic thing is childhood absence epilepsy. Ethosuximide has brilliant efficacy. That would be your drug of choice. Otherwise, if you've got no classification, you're basing it on the semiology, on that history, on what the seizures look like. And broadly speaking, the bilateral tonic-clonic, the convulsive seizures that most of us think of, the best evidence is actually, and the ones I would use more commonly, and there's a big study called the SANAD study, and then the SANAD 2 study across children and adults, and they showed lamotrigine and levetiracetam were the best. Lamotrigine, side effect wise, tends to be the best tolerated, whereas levetiracetam has a higher rate of being discontinued down the line because of side effects, but they have equal efficacy. Sodium valproate's still on that list. There are MHRA restrictions around that, and there's a really good BPNA RCPCH statement on that that's worth looking up. So you wouldn't go for that first, but you're not banned from doing it, but there's loads of considerations and a bit of a process around that. Focal seizures, same two agents really is probably what I use now, but carbamazepine is also really highly effective for focal seizures. So you go through the side effects, you think about that child's comorbidity. So again, classic scenario is a child with non-verbal autism and behavior that challenges. So you need to say, well, levetiracetam would work, and it would work quicker than lamotrigine. So if they're having frequent seizures, you might well be considering it. But some people do have issues with their behavior worsening, and some people will have issues with sleep. Maybe you just bring that evening dose forward, but have that frank and open discussion, and then you can make a sensible decision. So I've got a few cases to finish off this talk. These aren't interactive on in the second talk. There's a bit more for you guys to do. So, but think as I talk through them about this approach. Are these seizures? Is it epilepsy? Does it need treatment now? And what could you do for them now? These were real cases I've come across or been referred. So the first one is a 3-year-old who gets referred having had this one episode. They, I think that's head turning rather than head jerking, actually. Just noticed that. And eye deviation towards the left. It then evolves to a bilateral tonic-clonic seizure, and the whole thing lasted for 6 to 7 minutes. It stopped by itself, and they had 10 minutes or so of being drowsy and post-ictal. And they had a bit of a cold, but no fever. And there is a background, although they were born at term, they are a looked after child where we know the biological father had epilepsy, and there was drug and alcohol misuse in pregnancy. So for that one, there is no word cloud for this one for time purposes, but sounds like a vocal seizure to me. Sounds like the first one. It was prolonged. So what I did with this child, and there's a family history. So with this child, I was referred them as a suspected seizure. They had an MRI and an EEG. The MRI was normal. The EEG showed focal epilepsy. Shortly afterwards, anyway, we were having the discussion. They had a second stereotypical event, as in it looked similar. And so they started on treatment, I think levetiracetam, and had good control. This one's an 11-year-old who the history comes from school rather than a witness from the parent being a witness. They were getting changed at school, started to get a headache, feel a bit breathless and sick. They stood up after a few minutes, dropped to the ground. Maybe they lost consciousness. The witness from who was the teacher said they looked quite relaxed in general, but their fists were clenched. And sometimes they did that and they were scratching the floor. Only lasted for 15 seconds, but then kept happening again and again. And their legs didn't seem to be involved at all. And there wasn't any other relevant history. So there's potentially a quote, doesn't sound like a seizure to me. Potentially, this could be a vasovagal, but the fact that it kept happening, and then there was actually some more history that came out, some more mental health history, more about anxiety really, and these were classified as non-epileptic or functional. This one's an 8-year-old who was an 8-year-old boy, and he had this very clearly described event where he was just walking down the street and then he suddenly stopped what he was doing. That's what we call arrest of activity, but he was still standing. He had flickering of his eyes, which is always a thing. So when I said eyes open is a sensitive, but eyes closed sounds like, well, flickering is always the one in between where it might get described either way. So you need to be careful of that one. But then associated with lip smacking, eyes deviated to the left, and there was drooling. Lasted for 1 to 2 minutes, a few minutes to recover. And he can't remember what happened in the middle. And most importantly, there were some stereotypical events in previous months. So this, again, is a focal epilepsy. They go down the route of EEG, MRI. This is one, if you saw them acutely, you might want to have a discussion because they've had several events, pretty much, monthly or every 1 or 2 months. So you might want to have a discussion before you send this one home, unless, they're going to be seen like within the next week in an epilepsy clinic. This one, very quickly, I'll just say it was one that came in with a video and it was brilliant. So 13-month-old, normal development and completely well, but was having these episodes when they were sitting in the high chair where they were rhythmically sort of rocking themselves. They had hip flexion and adduction, stared ahead into the distance, and they were quite sleepy. And the video was key. So these were gratification episodes or self-stimulation. And this one I always put into highlight because it came in on a Sunday evening into my email as a routine referral. But it was a 13-month-old who'd had several months of jerking movements. And there was a video, and there was jerking movements with flexion of the neck and jerking moves of the upper limb. and then they sort of relaxed back down. They did have normal motor development, but there was an issue with their babbling that they were previously doing that they'd stopped doing, and they weren't responding to their name. And these were spasms. Okay, so this is not a routine referral. This is an on-the-day discussion, a neurological emergency. So that's just to differentiate that from some of the other things we've spoken about. So the summary is that the focus history and video, if you can get it, is key. The first day febrile seizure goes to a first seizure clinic in your local pathway. If you think it's epilepsy, that's probably the same pathway, unless you think it warrants a discussion on the day. We've talked a bit how to use EEG and give buccal appropriately, and how safety advice is crucial. And let's not stigmatize and restrict too much, okay? And think about the impact on the family. So that's that one.
Thank you, Amit, and thank you for stepping in. Susie's all good. So what we'll do is we'll do your second talk, and then Susie will do her proteinuria. Just for purposes of time, maybe we're over by about 3-4 minutes. Just let's take a couple of questions which I've highlighted. One is Bilal asks about, some pediatricians get reassured by normal EEG. What should be the approach? And again, you've gone through a lot of that in detail, isn't it, in the talk?
Yeah, it's about your clinical index of suspicion. So if you thought going into the EEG it was normal, it was a seizure, but it comes back normal, it's still a seizure. That hasn't overruled your opinion at all. And as I said, I will see somebody who's had several events and they have epilepsy. I've done the whole chat that I've outlined, but they go on to have their EEG and it's normal. That's a common finding for somebody with a confirmed epilepsy. So it shouldn't make you go back on what you thought.
And likewise, Arif asked the question about, is there any scenario where you would say EEG straight away after a first seizure?
Yeah, that's hopefully was clear. You do them after a first seizure if you don't think it was something else. If you're confident clinically it was a seizure, yes, they should be having an EEG. 72 hours is the aim. It doesn't normally happen that quickly, but yes, you should be organizing it.
And a question about buccal midazolam, febrile seizures. What's your take on it?
If they're prolonged, then yes. So in line with an epileptic seizure, they won't need regular medication because we categorize them differently. But in terms of a care plan for their febrile seizures, most children don't need it apart from call an ambulance if it goes on for more than 5 minutes. If it has gone on for more than 5 minutes historically, then you might consider buccal midazolam as part of that care plan.
Lovely. Amit, there are some other questions which you could answer later on. So
I'll go through them afterwards. Yeah. Okay. Let me do the next one. So, yes, this is a completely new talk. So hopefully people like it. So I've entitled it this. So it's about non-epileptic events. But good news, it's not a seizure, and I'll tell you why in a couple of minutes. I don't like that, so I put it in inverted commas. So we'll cover things that are often mistaken for seizures, things that are important not to miss, and a very basic clinical approach that I think is useful. So what do we mean? So, I've always called them paroxysmal events. The ILAE have this thing where they call them epilepsy imitators on their epilepsy diagnosis website, which is referenced in the previous talk. Brilliant website. You should all take a look at it. Even if you're seeing someone in clinic or in ED, you can go on it. It's a good little aid memoir of things. Then they got called paroxysmal non-epileptic seizures, but that has a very unfortunate acronym. So they've now decided on paroxysmal non-epileptic events. So PNEE. That seems to be used in most widely now. So the good news bit I'm highlighting because if it's something isn't epilepsy, it doesn't mean it doesn't have an impact. Whether it's something that you might even say it's quite benign. So let's say no, it's not benign, but let's say breath holding attacks. You're actually relaxed as a general pediatrician. We've seen these loads. I know what this is. It's great news. It's not epilepsy. Well, to them, it's still like, God, it was terrifying. And you're saying it can happen again. So that's important. And in this paper that I referenced here was more about functional non-epileptic seizures. And families themselves said, saying it's not epilepsy, and somebody has quoted that the pediatrician said, good news, it's not epilepsy, didn't change things because they had a really resistant condition that really affected their child's ability to be in school and so on. So it's not good news. Just say what it is if you know what it is. So that's one learning point, I suppose. So I put this up earlier. You can think about the non-epileptic things in this kind of framework. But I think it's also really maybe actually more useful to think about it by age. So we're familiar with most of these things. Things happen in the neonatal period, and then split it up into things that have their onset in early infancy, the first 6 months, versus late infancy, versus after 12 months, versus school age. Typically, some of these things can happen in different age groups, in which case you might not be as confident in calling it, and that's fine. So I'm going to go through some of them. So neonatal, and there are some videos, which is what I'm keen to get to. In the neonatal period, most of us on this course will have been the neonatal SHO going to a postnatal ward. Remember that. So jitteriness, see that a lot. We diagnose it a lot, right? So even the midwife says it's a jittery baby. So you go along, you say, yeah, it's a jittery baby. Is the sugar okay? Yeah, the sugar's okay. The key thing is they otherwise examine normally, and whilst they're doing it gentle holding, it doesn't carry on. Then there's the benign. Lots of things get called benign. It is benign, but I like to highlight we don't use it so much anymore in terminology because other things that were classified as benign aren't actually benign. Neonatal sleep myoclonus. So key characteristic of that one is that it only happens with sleep. Not surprisingly, given the name, and that those babies will examine normally. Key thing not to miss in the neonatal period: hyperexplexia. Most of us probably haven't seen it. I've seen it a couple of times. It doesn't mean we shouldn't suspect it. Okay, so this is this really exaggerated startle to what an otherwise normal stimulus, whether it's touch or whether it's noise. And you get really, I haven't got a good video of this one, unfortunately, but you get really exaggerated flexion of the limbs and a retraction of the head. And that key thing is you tap them on the forehead, and that's a kind of not quite pathognomonic, but yeah, I suppose it is if you know what you're doing. But that triggers it. They tend to be hypertonic on examination, so it's not a normal examination. So it's a red flag. And they get progressively more, and to the point where they actually affects their breathing. They can have apneas. So it's a good one not to miss, right? So this is one that requires a neurology referral. They will do a genetic panel because there are associated genes, and the treatment they'll probably start before that, getting that confirmation, which is clonazepam. So that's my sort of red flag in the neonatal period. From early infancy onwards, again onset, so the first 6 months, again what used to be called benign, so an infantile myoclonus. So this is a child who again examines normally, developing normally. They describe, or you see video of these sort of jerks, and they can be quite frequent, and they tend to be quite situational. So certain activities, feeding is probably the one at this age that tends to come up. And then there's Sandifer syndrome. I think most of us will have seen this or at least diagnosed it and said, yeah, it's probably that, which is often in infants, but can be in older children as well, depending on their development for other reasons. So if they've got other developmental delay, you may still see signs of this. And it's basically due to reflux. And as it comes up, it causes this posturing, so back arching and almost like a dystonic posturing of their limbs and often turning of the head as well. May happen with feeding, may happen just after feeding, but the point is the history of reflux. But otherwise, I've said normal examination development, but I've also said you could have developmental delay. The point is you've got a reason for that delay. If you think it's all due to these movements, then clearly it's a different classification. Bit rarer. Probably won't see this, but benign, again, paroxysmal tonic upward gaze. So these are people who have their eyes look up, and it can be something that is intermittent, and it's somebody that can be quite prolonged and stay there for a little while in an episode. And you can sometimes get that. You can get it associated with ataxia and sometimes not. They can have this for years, and this is a neurology diagnosis. Okay, I wouldn't want to make this one either. I might suspect it. It might be on a list because I've read about it, but it's one it would be, you can understand this might be mistaken for a focal seizure. For example, one of the cases I had, he was walking down the street, then he started looking the other way. So it's important in that differential list, but it's important if you're going to give this label. I probably wouldn't just be throwing this around as a general pediatrician, personally. Paroxysmal torticollis again. Another thing that can be, well, I think we all know torticollis, so it'll be that turning of the head, and it can last for minutes, which is where it sometimes comes up as are these focal seizures, versus hours, which is not a focal seizure, and you probably then becomes more and more this rarer thing. It's got an association with the kind of a migraine variant, so you can get the features listed there as well. From late infancy onwards, so from six months onwards, mentioned this, didn't I, as one of the cases. So these gratification episodes. So typically somebody sitting in their high chair. The one I showed you actually is a case as they came into our rapid access clinic. I was late to see them because I was seeing another case in the Bay. Went to go and see them, and the dad said, "Oh, she just did it. You missed it." I was like, "Oh, right. What were you doing?" So I just had her on my shoulders, and she was happy as anything. I was like, "Put her on your shoulders again," and he did that, and she did this, and I could make the diagnosis like seeing it live, which is really useful. So yeah, again, this can be confused with a focal seizure, but again, it's very situational. The right age group, normal development, normal examination. Breath holding attacks. I think most of us will be familiar with the features here, but it's a child in this kind of age group onwards, but often toddler age as well in preschool, who becomes upset and crying for whatever reason that they do, and then they have expiration and they stop breathing. But then that can cause an anoxic seizure. So that is the progression of it and the causative pathway. And you get stiffening and jerking. And again, it can look like a focal seizure, usually more than a tonic-clonic, but there can be bits of jerking, which looks like a convulsion. There is an association there, not a causative thing, with iron deficiency. So it's worth checking. And if you check that and they're iron deficient, you correct the iron deficiency. And the episodes wouldn't necessarily say stop, but they space out and they tend to recover from them more quickly than they otherwise would have. Shuddering attacks is what it sounds like. So it's this kind of shaking of the limbs with that kind of motion. And it's really what we talked about with infantile myoclonus. So if you look back at that, they're frequent and there's certain activities. Now, in the late infants, in the 6 months and over group, it's kind of the same thing, right? But they're just older. So there's very much an overlap, but excitement is the big key when they get to this age. So you get an excited child. They're really, they've seen a toy that they really want. They do this shuddering motion. And then I think so the other last thing in this category, which is sleep related ones, which are rhythmic. So these are things like you get one of the cameras, can't remember what they're called now, one of the cameras that we never used with on my kids, even though we bought them. The monitor, sorry, like a video monitor, that's what I mean. And then they say, oh, they've been doing this thing where they're banging their head on the cot at night and they're rolling around in a certain way. And again, video is really useful for this. They happen in the transition between sleep and wake. And they might do something similar each time, but they're not seizures. Okay, they're happening in sleep essentially, and you can help to classify that ideally with a video. Rarer, something called spasmus nutans. This is in the small print. But I've seen it once. I think one of our neurologists diagnosed it when I was a registrar, where I currently work. And this is a triad that you get in late infancy of head nodding, right? Nystagmus was always there, head nodding, and then a head tilt as well. And it's again, not a general pediatric diagnosis, but a video is going to be really useful. You could send it to a neurologist. And this can continue for years. But the point is, if you've got the classification that it's this, it is something that will go away. The key thing is there is an association with space occupying lesions. So all these children, if you're thinking they have this triad of features, will need an MRI. So into the toddler preschool group. So reflex anoxic seizures is probably the first one to talk about. Again, like with breath holding attacks, it's again a bit of a continuum or an overlap on a Venn diagram. Very similar in terms of what causes them, but it's an unpleasant stimulus rather than the breath holding mood related thing. So I've seen it with children who have an accident, fall over or bump their head. It can cause a bit of confusion. Is it head injury or not? But it's usually quite a minor bump, but it's the unpleasantness of the stimulus that causes it. And people who've had venipuncture is another thing that comes to mind as something where it's happened. So might not get a video of this, but you get a really situational setup for it. And this is a group of children who might evolve into having vasovagal syncope when they're older. That seems to also be you see it in that cohort. Motor stereotypies, worth mentioning as well. So these are things that often people call behavioral, or they say they have these mannerisms. They can be quite simple. They can be quite complex, and they can be primary in children who are otherwise well and don't have any other comorbidities, and often seen in children who've got autism spectrum disorder. So when people talk about stimming, this is essentially that same category. Okay, so you've all probably seen children or heard about descriptions of these children and what they do. Parasomnias is another group to talk about. So these are confusional arousals is probably what I talk about a lot, or night terrors. So these often happen in the first third of sleep. How they look is a bit of a wide spectrum. There is a useful slide that I've got for your information, a few slides on, in terms of distinguishing between parasomnias or focal, usually frontal lobe seizures is the differential. But the difference is parasomnias aren't normally frequent, whereas the frontal lobe seizures are. Parasomnias don't normally cluster. So you can, in fact, I'll touch on that slide when I come to it. Another one that's nothing to do with a kind of convulsive element, but is really common, are staring spells or daydreaming versus absences. Okay, and again, they're usually situational, but by that I mean when a child's not being stimulated or distracted. So often they're just sitting eating at a table or in the high chair, or so, sometimes I suppose there's a setup where they do it when they're sort of being when they want to be distant. So say if they're being told off or something, that sometimes is a bit of a situation that comes out. They're normally much longer than absences, which absences normally 5, 10, 15 seconds, maximum 30 seconds. These can sometimes go on for a minute plus. They're more common in children with a learning disability or autism spectrum disorder. They can be distracted out of it, okay? As opposed to you're in the middle of a conversation and then so you suddenly go blank, okay? Which is unlikely to be these. They're more likely to be staring absences. And then in the school age, vasovagals, obviously, I think we all would have come across those. There's usually, again, a situational element. So is it postural or is it prolonged standing, or sometimes people are just prone to it anyway. Often there's the collection of autonomic symptoms. So they're looking pale or flushed, feeling sick, nauseous, some visual changes perhaps. The key thing is with vasovagals, a bit like that, one of the first talk about what's specific for an epileptic seizure. Actually, loads of things can happen when you drop down having had a vasovagal, and there's that got recorded in this kind of famous study from decades ago when you were allowed to do these things, and they made loads of medical students hyperventilate in a room whilst filming them, and they saw that you can have tonic-clonic things that look like tonic-clonic events. You can certainly get stiffening, other things that look like seizures. Essentially, they're not prolonged. Those movements, they're brief. The recovery is usually quite quick, so it's not usually that classical post-ictal period. So if they have a fairly quick recovery in terms of their awareness, then you can probably safely classify this, and I'm sure we will do that fairly regularly. Tics is obviously another thing that comes up at this age. So this is this uncontrollable thing. It's an urge. It's not pleasant until you've done it, and to do something that's you wouldn't classify as voluntary, you have to do it. So hence it's involuntary, and it's brief. And obviously we know there can be eye blinking, clearing of throat, sometimes often simple tic disorder, sometimes a bit more complex. They tend to wax and wane over time, so it's not usual that people just have one tic and it goes away over time. It's usual that they have one tic, and then as that one's waning, another type of tic comes and takes its place. There is a bit of a threshold for the only intervention that's really useful, which is psychological, something called habit reversal therapy. Usually you need to have some sort of OCD type framing around that, some sort of elements of that. But there is good evidence for those that qualify for that. Migraine, I did mention earlier is in that epilepsy imitators slide. So the key thing is it's what are your differentials. So sometimes you get people who have aura. So one I remember actually is a bit rare, have like an Alice in Wonderland syndrome where things suddenly appear small, and they're usually quite articulate school-age children who are telling you exactly what they see. Or one differential are these occipital seizures causing this sort of visual change versus this is more migrainous. And then hemiplegic migraine. This is a focal seizure. Well, again, usually the hemiplegic migraine is longer than you'd expect, much longer than a focal seizure, so it's not that much of a differential. Go down the migraine route in terms of that. And then I'm going to gloss over non-epileptic seizures or functional, but obviously clinically we don't gloss over them. They are really impactful. They take up a lot of clinician and professional time, and they're really resistant. Okay, they can look really different, but they don't look like seizures. There's lots of cardinal things, and again, there's a slide in a few slides' time that goes through some of the key things that would mean it's non-epileptic rather than epileptic. It's key to try and introduce that concept early. So even if you're not saying this is definitely what they are, say this is one of our considerations, and this is why those things happen if it does end up being that. There is evidence that the sooner it's introduced, the better the outcome, even though that outcome will take a long time. Okay. And there's lots of elements to the management after that, and it's very goal directed in terms of step-by-step improvement. Early access to psychology and CAMS makes a difference, clearly, and making it something of a sensible care plan that's not an epilepsy care plan, but a care plan so that they can integrate into school is really, really important. Dystonia and dyskinesia are also something that sometimes gets confused. They're normally quite different, but I can remember a baby with really severe HIE who was having both dystonia and both and seizures, and which were which, and which plan do you go down, which routes do you go down when they're on the ward. They were on the ward for years really, and they constantly were having EEGs to try and capture are these ones dystonia, are these ones seizures, but usually it's quite obvious. So yeah, they shouldn't normally mimic it. And dyskinesia, there's something called other movement disorders. There's something called PKD, paroxysmal kinesiogenic dyskinesia, that has been referred to me before in an epilepsy clinic, but it's something that's happens with movement initiation. It's really a brief episode. So I've had one where there's kind of turning out of the hand, like a posturing, when somebody was going to start running in PE, and it would happen all the time. They're a bit embarrassed by it, but good news with that one, I won't go into it. It's very treatable. Just give them a bit of carbamazepine at a very low dose, even though it's not a seizure, and it works very well. But these are things that sometimes get confused. So I said there would be these slides. There's about 4 or 5 of these. This I've already been through. So night terrors and sort of parasomnias versus frontal lobe seizures. There are clear cardinal features that make it more likely to be one than the other, but they are differentials. Daydreaming and absences, again, I've been through, but it's there for your reference later. These are a long list, which I won't go through, of things that you tend to see in non-epileptic seizures or functional seizures. And this is a comparison of a few different things, so breath holding versus syncope versus what you might see in a seizure. And these are the kind of the movement disorder, the dyskinesia bit, for example, the tics, the stereotypies. So the very basic approach is it's all about the history, a bit like the epilepsy bit. If you can get a history that's very reminiscent of an epilepsy imitator, and you're thinking about it by age, because I think that's really useful. If you can supplement that with video, brilliant, because that's really what you need to be confident, I think, as a general pediatrician or as the first contact professional. If it's something you've seen before, or you're comfortable that it is this and there's no features that make you suspicious it's a seizure, and the examination is normal and fits with that, or I suppose in the case of Sandifer syndrome, you fits with it that have reflux, then you can diagnose that. You can classify it, you can reassure them. If you've got video, you can pass that on to somebody that you think might help to confirm that, whether that's somebody in-house or neurology. However, if there is, and you don't want to miss the things that I've said, you don't want to miss. So if the examination is abnormal, or it's a paroxysmal non-epileptic event that you think will need further investigation, so the spasmus nutans one, for example, they've got the triad and you're like, brilliant, I know what it is. Well, they need an MRI still, and you probably need to ask a friend to say, I think it's this, do you agree? So that goes down another route. So it's very simple in terms of a framework. History is key. I won't go through this again. Same as what was in the epilepsy slide. Again, just making the very quick point, EEG is not usually useful in most of these that we've in this talk. And I think the key thing that's different here is in that bottom point. If you've got frequent events, but you're thinking epilepsy is a bit of a differential, then it is useful, right? Especially if you can capture it. But you need to think, what am I going to do? And what am I going to say to the family if that EEG is normal? It doesn't capture it. So you could say we're doing it for this reason, but you don't capture it. Okay, the events aren't that frequent, so we're never going to really capture it. You need to have a clinical idea of what you think it is my message, and not rely just on the EEG. Okay. So if we've got time for a few videos. This is the first case. So let's say she's a 4 or 5-year-old girl who's doing these eye blinking episodes. These are all publicly available ones, so trying to show them. Oops. So what do you think that was? It's a very quick video, so you don't get much of a chance to think about it. It'll come up as a word cloud. Absences. Okay. Tick. Yeah, behavioral staring. Yeah, so she came with eye blinking, and given them what the topic is, then these ones aren't absences. And they're not even daydreaming, because it wasn't just staring, because the daydreaming, as I said, is normally much longer. So absences is one differential, but it's actually the blinking that she was doing. She was too young to articulate that she felt really this urge to do it, but these were ticks. Okay, this one.
Is that fun?
So you can see the sort of movements he was making. Oh, try and move that on. Yeah. So those were stereotypies.
It's okay. It's okay. Get in closer. Come on. Okay, buddy. It's okay, buddy. Breathe. It's okay, buddy. Breathe. It's okay. Come on. It's okay. It's okay.
So he was having a good cry before this, for whatever reason. I don't know him, and you can see in expiration, there was just that pause. And because of that, he had this posturing.
It's okay.
What do you think that was? Yeah, so both those things are true, right? Breath holding causing an anoxic seizure. Excellent. So I think, again, like I sort of said in the talk, I think everyone's quite comfortable with those. This one I'm just going to show you. It tells you, unfortunately, it's a YouTube video. But it's a shuddering attack. So this was happening in the context, according to the people who shared the video, they've just been quite excited. So when I say it just looks like shuddering, I hope you appreciate what I mean by that. I tried to
معلش
demonstrate it
ماما
earlier.
ليش هيك تسوين حبيبتي؟
Oops. Okay. There's a question for this one, though. Would you do an EEG for that child? So mostly no, right? And I think I would agree with that. I wouldn't, because I'm confident in the clinical diagnosis. The only thing I could say is you're probably able to capture them. So there is an argument, I suppose, about absolute clarity. So I think if you're not confident you want to do an EEG, but you know you can probably capture this because the parent can do what situation provokes it, there might be an argument in it. But I think clinically it's better not to, if you're confident. Last couple, we're almost done. Let me get these here.
Mamma l'ha già fatta, sa. Tu la devi fare?
Watch what he does with his hair.
Sa, non si sale, ti ho
Does it
detto.
twice.
Non si sale. Pulisci e andiamo. Attento dietro che ti sbagli.
Okay, so that is a paroxysmal torticollis. And then this one, quite situational. No sound with this one. Child with developmental delay tend to happen in and around feeding. And I think I've seen it much more with infants, but here you can see the back arching, not so much posturing with this child. And that's Sandifer syndrome. So they had a good history of reflux, so you could be quite secure in that diagnosis. So, summary of that one. It is useful to think about the age of onset, I think, as a classification when you think about paroxysmal non-epileptic events. The approach is very simple, very in parallel with the first seizure one. History is absolutely key. Video really complements that and actually, I think, really improves that because on a pathway, you could either be confident or you could share that with somebody. If you're confident, you can reassure. If you're not, you can share the video and reassure. However, there are some paroxysmal non-epileptic events where it does warrant investigation and onward referral. You don't want to miss those. EEG, you need to use judiciously only if you've got a true diagnostic dilemma, and especially in the scenario where you can capture the event. Okay, that's that's the end of that one.
Thank you, Amit. I mean, really useful. We get so many of these as reference from primary care, and some sort of framework definitely helps. Let's, for purpose of time, just take a couple of questions. I've highlighted them. So, question: clinical anoxic seizures. Do you carry a EEG for parental concerns? I think the answer is clear, but yeah.
I wouldn't do, and the reason is it's not about gatekeeping and a thing. It's about being honest about what the investigation may or may not show. And I think when there's parental concern, it's unlikely that one normal investigation will do. They'll then ask what's the next investigation, then you're trapped.
Elizabeth asks us, do you need to investigate an infant with the sleep rhythmic movement disorder or just a reassurance?
Reassurance. And video is usually the thing. And I think most parents who are concerned tend to have these video monitors, so they can probably share video with you.
Arif, last question. Can breath holding happen in less than 6 months? Seen a few. Again, it's interesting, isn't it? I mean, clinically, anything can happen. Age-wise, it's just in textbook.
Exactly. And I think your index of suspicion changes a little bit. Your differential list changes. So you may just want to be more wary about making a diagnosis, but you can still make it. You just need to say that actually, do you know what? Even though it's not as typical, I'm confident. And whatever you need to get that confidence. And I think, again, video and sharing that with colleagues increases that confidence.
And then the last one is the experience we've had on one of our patients in the ward, isn't it? The classical functional neurological. And then calling that early is really important, isn't it? Just saying that this is not an epileptic seizure is really important, as you highlighted.
It's really important if you're confident to say that at the start. If you're not sure and it's grey, be transparent about your differentials, because then you can introduce that concept. You can say it could be option 1, 2, or 3. Option 3 is this thing called functional neurological disorder. We see it very commonly, and this is the treatment pathway for that. It's not medication. There's no investigation that's going to show anything. Talk about the biopsychosocial model. Even though you're not saying nailing your colours to the mast and saying, I'm definitely saying it is. It doesn't matter. What you don't want is to do loads of investigations for the child and use it as a diagnosis of exclusion. That's not the right way to diagnose it. And it certainly means it's going to be more resistant in terms of being accepted as diagnosis.
It's my very great pleasure to welcome 3 amazing speakers for the next session. We're going to start off with Andrew Prendergast, who's going to talk to us about PUOs, Kawasaki's, and lots of other things. So I'm really excited about these talks. Thank you, Andrew.
Brilliant. Thanks, Justin. Good morning, everybody. So yes, we're going to talk first about PUOs and then specifically about Kawasaki disease and a little bit at the end about HLH. So I'm going to start with a sort of case that will be, I think, pretty familiar to everybody in the audience. So here's a 3-month-old child who got admitted a few years ago with a fever for 3 days, was irritable, and so had a septic screen. The LP failed, so the child was started on ceftriaxone and amoxicillin. Probably we wouldn't start amoxicillin these days at 3 months, probably up to the first month is fine for that, but nonetheless started antibiotics, had a high CRP, and eventually got a CSF sample after 30 hours and had a few white cells in there. So was suspected to have meningitis with a slightly delayed LP, but carried on spiking fevers. So had normal brain imaging, and the culture from the CSF was negative, presumably because it was taken on antibiotics. So in our setting, we can do a broad range molecular test, a 16S PCR, to look for bacteria. But fevers continued, so the antibiotics were switched to meropenem. And now after 8 days in hospital or 11 days of fever, the child was still febrile, had a new rash and a CRP that was rising. And so this sort of context will be pretty familiar, and we'd often talk about a PUO, a pyrexia of unknown origin, which I guess in the old days used to have a much longer definition, that the fever had to be going on for 3 weeks. People would often say a week of investigations in hospital. This was the sort of classic dogma from back in the 60s. And really things have evolved since then with the advent of molecular diagnostics, more rapid point of care testing. The general consensus is that if you've got a fever for more than a week with a negative initial workup, that we would consider that to be a PUO. And so there's really four broad categories. We'll all recall: infections, inflammation, malignancy, and a bucket of other underlying causes. And of course, the distribution of those depends on the setting where you're working and the age group. And so on the left there, if we look in studies of pediatrics, infections still tend to be the bulk of those, around just over 50%. Compared to adults, slightly less likely to be inflammatory. But you'll see in every age group that grey bar at the top of unknown causes, that around 20 to 30% of PUOs, we just never find a cause despite much workup. And then if one looks in different settings, like the tropics, where there's fewer diagnostics, those stacked bars look a bit different. And if you look in a very specific population, like immunodeficient patients, then infections predominate. So we have these four groups. Infections are by far and away the biggest group. And I think PUO teaching is really difficult because if you look in textbooks, you end up with massive lists of organisms, which is not easy to remember or particularly intuitive. So the way I like to think about this is in five kind of types of infections. Why are we not finding the cause? Is it the infection is hidden away somewhere that we haven't looked? Is it hard to grow and diagnose? Is it just something we overlook because we maybe don't see it very often? Is it a persistent infection? Maybe you found it and it is the cause, but it is a persistent pathogen. Or is this actually more of a pseudo PUO? It's actually a recurrent infection that feels like it's been going on for a long time. So we'll look at each of these. And I think infections that are hidden away really come down to thinking about those sites, examining them, and potentially imaging them. So classic ones would be things like sinuses and mastoids, the eyes. So there's a reason why we ask ophthalmologists to review children with a true PUO. Don't forget teeth. So bad dentition is common in many places where we work and could be a source of infection. And then spine, bones, and joints are sort of classic hidden sites of pus. And spine can be things like a discitis, where a child may just be really reluctant to sit from lying or to stand up and walk, but really you won't find spinal tenderness. That can sometimes be a sign of something like a discitis. So the second group are just hard to diagnose. Despite modern laboratories, we've got bugs that are fastidious, meaning they've got complex nutritional requirements, they're fussy, they're hard to grow, although sometimes molecular techniques can help us these days. Or they do grow, but they're slow to grow. And the classic one is TB, which remember can take many weeks to grow in the right media. But other bugs are similar, like Brucella and Listeria. And sometimes that is a case of talking to your friendly microbiologist and asking for a prolonged culture. It's not something they will do without saying, I'm worried that there might be a pathogen that's slow or difficult to grow, and they can talk to you and help you and prolong the incubation of a regular blood culture. So the third group are really sort of overlooked things. So maybe they're rare fungal infections that we maybe don't see very often, or atypical mycobacteria. And the other group that's often overlooked is imported infections, either, again, because there's a long list and they're quite unfamiliar, or the travel may have been a long time ago, and so it doesn't necessarily occur to us that this might be an imported infection. And the three commonest diagnoses in children returning with a tropical infection are malaria, typhoid, and hepatitis A. And Benita's going to talk in the next talk in much more detail about some of those infections. But I would just make 3 or 4 points. The first is fever plus anything is malaria, if somebody has traveled to a malarial area. And very often it will look like a flu, like an urti, gastroenteritis. So test for malaria if somebody has a relevant travel history. The second thing is, again, incubation periods, difficult to remember. Just remember a lot of them are quite long with imported infections. So typhoid is 2 to 3 weeks. Hepatitis is 2 to 6 weeks, hepatitis A. And Hep B is 2 to 6 months. So we have these pretty long incubation periods that mean you really need to think back with the family about any travel that might have happened some time back. And then the third challenge is that imported diseases are pretty hard to distinguish clinically. They're often sort of undifferentiated fevers, maybe some rash, maybe some arthralgia, and they often coexist. So there's a few challenges to this, but what I would recommend is asking about travel at least over the past year. Remember things people forget: the airport they stopped over at, the places people just don't think of as travel. So places outside of their home setting in the UK or Europe. You only need to go to Malaga to pick up leishmaniasis. So there you go. People often don't think that Spain counts as travel. They're thinking somewhere in a different continent. Obviously, ask about pre-travel vaccinations and use of malaria prevention, as well as other people who maybe are unwell. Interestingly, things like rickettsial infections often break out in the whole family. So you may find somebody else had exactly the same exposure in that family. And the nice thing these days is we have these great geographic panels. So Ripple, the rare imported pathogens lab, will actually work out the diagnostics for you if you just give them a good travel history. And they'll do nice panels of tests to guide that diagnostic process. So the next group are infections that are persistent. So the classic ones would be EBV and CMV, herpes viruses that maybe you have picked them up, you've got recent serological evidence of EBV, and that may be the cause of this ongoing fever. And there's some others here. Parvovirus is another one, and we've mentioned bugs like Brucella just earlier. And then finally, we've got this group of infections that really comes down to the history, figuring out whether this is truly a daily PUO or whether there are maybe symptom-free days, but the child is felt to be always febrile. So a classic example would be the common urtes that are happening, once a month. They're lasting for 2 to 3 weeks. It feels like the child is constantly unwell, but actually, if you ask very carefully, there might be little breaks in between. Don't forget the cyclical presentations, so cyclical neutropenia and some of the periodic fever syndromes. So they may truly be, obviously they're inflammatory disorders, but they may truly have a periodicity to them with symptom-free days in between. So the second group after infections, we'll be thinking about inflammatory disorders. The mnemonic COVID can be helpful and reminds you that COVID had its own inflammatory disorder that we saw for the first time in 2020, which got labeled PIMS TS. It looks a bit like Kawasaki disease, but is quite distinct. So connective tissue disorders, other multi-system disorders like PIMS TS, the vasculitides that include Kawasaki and the broader range of small, medium, or large vessel disease. And then the idea is immune dysregulation. And these days, what we used to call primary immunodeficiency, which we now call inborn errors of immunity, there's an emerging group of diseases, and they don't only present with recurrent infections. In fact, the whole immune system is dysregulated and maybe inflammatory. So often, again, molecular panels can be helpful these days to pinpoint single gene defects. So think about immune dysregulation linked to inborn errors of immunity. Then malignancy is something we mustn't forget. We've probably all been sort of caught out at different times by a child with fever and a bit of maybe cervical lymphadenopathy who turns out to have a blood cancer. So thinking about a blood film, an LDH, and talking to your hematologist about whether this child needs a bone marrow aspirate. And then, of course, there's solid tumors, which at the minimum, we would usually do an abdominal ultrasound, thinking about things like Wilms tumor. And then we got this bucket of other factors. And of course, drug fevers are one of the things not to forget, partly because we often drive them with antibiotics. Beta-lactams and vancomycin are often the commonest causes, and people often forget that ibuprofen sitting on the drug chart that can be quite a common cause of DRESS. And so DRESS, will present with fever, a really polymorphous rash, and some kind of organ involvement. And although people remember the eosinophilia, that's quite a late sign. Early on, it may be a blood film that shows atypical lymphocytes. And in general, dermatologists will probably want to biopsy that rash. We would stop the drug and maybe start a low dose of steroids. So think about DRESS and other related drug fevers. Don't forget fecal calprotectin and thyroid function. Those are sort of two things that really probably form that second layer of investigations for PUO. And then other causes like DVTs, pulmonary embolus, etc. So I think really there's no one size fits all. It's a staged approach to PUO that does have to be guided by the presentation, not forgetting some of the factors listed here, including a sexual history in adolescence. And the reason I think kind of blanket investigations are unhelpful is that Sutton's law applies. So this is the fact that the diagnostic test most likely to establish a diagnosis should be the one you do early. So do be guided by that history and examination to try and triage your tests. So again, if possible, if the child is well, I would try and avoid starting blanket antibiotics. Of course, there's multiple exceptions, things like endocarditis. I wouldn't wait if the child is unwell or an abnormal host, then clearly that is different. But if possible, quite often in a child who's relatively well, trying to avoid antibiotics is helpful while finishing your workup. So in general, I think retaking the history and examining often is really the key. Culturing everything and doing it often, imaging everything that's relevant, and biopsying anything you can. I think it's often underutilized. I am a big fan of a brain biopsy, something we actually rarely do, but in a child with fever and encephalopathy, it really is the best test. So thinking about biopsies and eventually not just imaging everything that's relevant, but imaging everything is often an approach we have to resort to. So I think the minimum is to get a chest X-ray and an abdominal ultrasound, as we've mentioned. Getting an echo can be challenging in many settings, and often cardiologists will be reluctant if you haven't had positive blood cultures. But do remember the long list of culture negative endocarditis, where you may well have a negative blood cultures by definition, but actually an echo is still an important diagnostic test. Then when it comes to sort of broader imaging, there's really two modalities. So one is PET scanning, but it is fairly unavailable even in many teaching hospitals. It's expensive. It's got a lot of false positives because you get non-specific uptake of tracer. And of course, it involves radiation by CT. Probably it is useful for a large vessel vasculitis, but what we would tend to use more is a whole body MRI if we need to do just whole body imaging. It's clearly more available. There's no radiation, but we do still have a risk of false positives. So again, interpret with caution. So finally, the sort of pitfalls in PUO, I think one is the cognitive bias, and that case that I presented at the beginning, suspected meningitis, you find these days with electronic health records, the beginning of the entry on a ward round every day is copied across from the day before. So every day people start saying, this is the baby with suspected meningitis. And we often forget to go back and challenge that diagnosis. Don't forget the basics. Beware the false positives. A classic one that I always remember as a child who had a drug reaction, who had fever and a rash, but somebody decided they would send a rubella serology, a terrible test. It came back positive, but really the pretest probability of rubella in a vaccinated child is incredibly low. So think carefully about the tests you're sending, because there will be false positives if you send enough tests. Don't forget what we call the classic refuge sites for pus, known about for decades. It's the liver, bone, and heart that are the three sites where bacteria like to hide. Make sure the child's a normal host. It can be important to work up with a basic immune screen. And then remember things like TB, which you're going to hear about in the next talk, but all our tests can be negative in TB. So you still need to think about it. And then think early beyond infection into those other three buckets of diagnoses that we talked about. And particularly not missing Kawasaki disease, which turned out to be the cause in the 3-month-old child I mentioned. So after this 11 days of fever, when the child was still highly inflammatory, a widespread macular rash then appeared. The child was miserable, still had negative microbiology, and no response to antibiotics. And so this was a child with Kawasaki disease, but without the classic 4 out of 5 features that people often know well and rely upon. And so we do still often see that Kawasaki disease can be missed. And I think the reason is febrile mucocutaneous syndromes have a lot of underlying causes. It's a wide differential. Many of them are infections and may coexist with infections. And what often happens is that once people find an infection, they stop looking because we think that's the cause. But actually, just remember that Kawasaki disease is an inflammatory response to an infectious trigger in a genetically susceptible host, meaning there will often be an infection present as well as Kawasaki disease. And so I'm going to share with you my personal 10 cardinal rules of Kawasaki disease. These are not written down in a textbook. These are very personal. Do not quote me. But the 10 things that I find useful when I think about Kawasaki disease. Number one, as mentioned, there is often positive microbiology or virology that has triggered the exaggerated inflammatory response. So don't stop looking if things don't quite add up. If this rhinovirus or this cons in a blood culture doesn't quite seem to explain the presentation, then think carefully and keep thinking about Kawasaki disease. Number two, I'd avoid the very dogmatic 4, 5, 10 teaching. This idea you have to have 4 out of 5 signs, you have to have 5 days of fever, and you're okay giving IVIG by day 10. Actually, we try and spot Kawasaki disease as early as possible and treat as soon as possible. As we understand more and more about the pathology, particularly at the endothelial level, it makes complete sense to treat as early as you can before processes like fibrosis begin. Thirdly, the signs of Kawasaki disease are often all there, but they're sequential and transient. So-called incomplete cases, if you ask hard enough, may actually have had 4 out of 5 features, but the red eyes were transient, they happened at the weekend, the mucositis came and went, and now we're left with a child with a rash. So often, asking specifically and going back in time, you will find there are more features than you realized. Number 4, just remember the protein manifestations of Kawasaki disease. So yes, we've got the classic features and irritability is almost universal, but there are many other presentations from abdominal pain and diarrhea through to the aseptic meningitis that you saw in that case. And then remember that 5% of Kawasaki disease presents as Kawasaki shock syndrome. It looks identical to sepsis, but it is Kawasaki disease. Number 5, BCG reactivation is always Kawasaki disease. I don't know a single other cause. It is caused by T cells that cross-react between BCG and heat shock proteins. So you can pretty much say always, this is a highly specific sign. Think about Kawasaki disease. Number 6, if there's no inflammation, then it's not Kawasaki disease. A lot of viral causes will give you fever and a rash. Of course, terms and conditions apply. It's a self-limiting illness. Eventually, it will defervesce, but look for broad signs of inflammation. So going beyond the CRP, look at the blood count, the albumin, look at the liver function. And yes, we all remember thrombocytosis, but it's a late sign. You can actually get thrombocytopenia early on, and that's driven by inflammation as well. Number 7, I would say, if in doubt, treat. So if you're thinking about Kawasaki disease and you're agonizing, agonize no longer. Think about just giving IVIG because, it's a safe treatment. We use it a lot. You can start high dose aspirin. You can keep thinking about it, but it is better to get in early and treat and not rely on this day 10 rule, which can be quite misleading. Number 8, infants below 12 months should really worry you with Kawasaki disease. They're high risk, much more likely to have IVIG resistance, incomplete disease, and a high risk of coronary artery aneurysms. So again, this group I would treat early and hit them really hard. So I would give IVIG plus steroids in an infant and indeed in other children who have high risk features. So particularly infants, treat aggressively. And that is our general rule, is to aggressively switch off inflammation. It's the inflammation that's driving damage. The general rule is to chase the CRP down to normal. So you've got 0 fever and 0 CRP, and to escalate if necessary. So just because you give an IVIG, it doesn't mean it's job done. You need to keep chasing the bloods. And if you've still got persistent inflammation, think about second doses or steroids. And again, don't switch the aspirin down to a low dose until you have defavesced and settled all the inflammatory markers. Just remember the 3 rules of steroids: to give good gastric protection, to avoid live vaccines for 3 months, although in Kawasaki we tend to avoid all vaccines for 6 months anyway. But thirdly, the thing people often forget, warn about varicella. If this child has never had chickenpox for the next 3 months, they need to let you know if they come in contact with a case of chickenpox so we can give prophylaxis. And then finally, always get an inpatient echo. Now, I say that knowing it is very hard, even in many teaching hospitals, to get an echo, and in some settings, nigh on impossible. But push hard through your regional cardiology service in a child where you think this is Kawasaki disease to get an inpatient echo. We have been caught out before by children who don't appear clinically too unwell having evolving cardiac disease. And we would change treatment if you found there was signs of coronary artery disease. So it is important. The thing you can do in any setting is get an ECG, and that's something we often forget to do. Okay, so finally we got a child who's got Kawasaki disease. They've started treatment, but they're not getting better. They carry on spiking fevers. The inflammatory markers are rising. Somebody notes on a ward round hepatosplenomegaly and dropping full blood count. And this is a rare but possible complication of Kawasaki disease, which is HLH, which has this overlap with macrophage activation syndrome, and is not, of course, just caused by Kawasaki disease. We have genetic causes and a whole lot of secondary causes driven particularly by infections. But it's something to think about in a child who's got fever, dropping cell counts, and hepatosplenomegaly. And I think rather than talk you through the rest of this slide, I think, Jeremy, everything is more memorable as a song. So I'm going to hand to you, and I'm going to end my talk with a song to remind you of the features of HLH.
When fevers just won't go away and cell counts drop too low, the bloods are all inflammatory, the spleen and liver grow. Multi-system chaos, but it's often quite forgot. HLH is hard to say and harder yet to spot. It's hemophagocytic lymphohistiocytosis, even though the sound of it is something quite atrocious. Macrophages eating cells, yes, that's the diagnosis. Hemophagocytic lymphohistiocytosis. Some cases are genetic with mutations paving ways, or triggered by infections, drugs, or SOJIA. If you think of HLH, then 3 Fs are the best. Ferritin, fibrinogen, or fasting lipid test. It's hemophagocytic lymphohistiocytosis, even though the sound of it is something quite atrocious. Macrophages eating cells, yes, that's the diagnosis. Hemophagocytic lymphohistiocytosis. Hemophagocytic lymphohistiocytosis, even though the sound of it is something quite atrocious. Macrophages eating cells, yes, that's the diagnosis. Hemophagocytic lymphohistiocytosis.
I'm sorry, Justin. It just had to be done.
Go, Andy, go. Love it.
I have no way to respond to that. I can't even begin to think what to say. I think we'll take questions on PUOs and ID at the end of Benita's talk, if that's okay. Are you okay to hang on, Andy? And we'll do both sets of questions together. That was just fabulous and not something I will forget. Perhaps you should warn the chair before you start to sing in a lecture. But anyway, I'm going to hand over to Benita. It's a great pleasure to welcome her. And she's going to talk to us about fever in the returning traveller. And she and I have looked at this lots and seen lots of very complicated children. So I'm really grateful. Go for it, Benita.
Great. Thank you so much, Justin, and thank you, Andy, for introducing the topic brilliantly. So I work as a paediatrician at the Royal London, and I'm a general paediatrician with a special interest in ID. And I'm going to be approaching this much more from a kind of ED, DGH perspective, which is where Justin and I have seen lots of these cases. So we're going to talk about why is this topic important, a little bit about clinical assessment, what to ask, who to worry about, and what to look for on examination. We're going to think about who to investigate and what to investigate. And we're going to think a little bit about management, and we're going to do some clinical cases and cover some key updates, as well as think about sources of help and advice. Now, we're going to use Mentimeter, so if you don't mind scanning that QR code, then that will take you hopefully to the questions. Okay, so just before we start, be interesting to know what you think, and Andy might have given you a clue or may have misled you. What do you think is the most common infection in children and young people returning from travel in the UK? Give you a few more seconds to answer. Fantastic. So you are correct. Actually, although as ID physicians, we get very excited when we have a child come back from somewhere with a fever, actually 50% of them are either viral illnesses, which is the most common, or other cosmopolitan infections. So things like UTI and chest infections. But a significant proportion, around 20%, will have a tropical infection, and things such as malaria, if we don't pick them up and act quickly, can be life-threatening. Probably in about 30%, we actually never get a diagnosis too. Okay, next question is, some of you have answered it already. I'll give you a little bit longer. Which groups of children and young people are at highest risk of acquiring tropical infection? Okay, so actually, the group here that we would most worry about are those visiting friends and relatives. So they often stay for longer, they live in closer proximity to local populations, and they're less likely to take pre-travel advice or malaria prophylaxis. And they're something like, so those visiting friends and relatives are something like 7 times more likely to get typhoid and 4 to 8 times more likely to get malaria. Interestingly, usually sort of fetal hemoglobin is partially protective against malaria. So actually, usually infants in the first few months of life get it a little bit less severely. And again, you might remember that sickle cell disease massively increases your risk of malaria, but sickle cell trait is actually partially protective as well. So why is this topic important? So travel is common. There were nearly 100 million overseas visits last year by UK residents, and many of these to visit friends and relatives. You probably know yourself after you've got on a flight. It's not uncommon that you feel ill a few days later, and up to about a quarter of travellers to any destination experience ill health, and around 50% of those may be ill enough to seek medical attention. And although we know that the chance of tropical infections is small, only 20%, actually conditions such as malaria and typhoid can be life-threatening if there's a delay in diagnosis. And as Andy's talk highlighted, we're not always very good about asking about travel. And actually studies have shown that we only ask about it in 1 in 20, 1 in 5 patients where it is relevant. So what are some of the things that are helpful to think about? So I think when I'm assessing a child, it's good to think about the host first. Are there any factors which increase the risk of infection or severe disease? So are they immunocompromised? Are they on medications which might immunosuppress them? Are they visiting friends and relatives? Have they got sickle cell disease? Which countries have they visited, including stopovers, as Andy highlighted? And for some of our asylum-seeking children and young people, this may be multiple countries they've come through. What are the specific travel dates and return dates? And that might help you rule out some conditions. So, for example, dengue usually presents in the first couple of weeks. So if they came back from a dengue country 2 months ago, you don't need to worry about that. It's good to ask a bit about pre-travel preparation, so immunisations, malaria prophylaxis adherence, and any other measures they took. It's good to ask a little bit about activities and exposures, so street food, unwashed salad, unpasteurised dairy products, untreated water ice, insect bites, particularly things like mosquitoes and ticks, animal bites, things like dogs, cats, monkeys, swimming, bathing or washing in fresh water. You probably remember from medical school puts you at high risk of schistosomiasis in many countries. contact with people who are unwell. And in young people, it's really good to ask a sexual history, but also think a little bit about tattoos, drug use as well. And then we want to ask about presenting symptoms, but just be aware that many tropical infections can present with symptoms which may mimic an upper respiratory tract infection. So even if they have a cough and runny nose and a sore throat, but they've come back from Ghana last week or a couple of weeks ago, always think about and investigate for malaria. And then I think the other thing just to highlight is that many of the countries some of our children and young people have visited may have a slightly higher risk of resistant or multi-drug resistant organism. So if you are seeing a child with, say, sepsis or meningitis and they've travelled, I would always have a low threshold to speak to microbiology and think, do we need to broaden the antibiotic cover? Could they be at higher risk of resistant organisms? So in terms of examination, it's no different to any other child, A to E approach if they're unwell, and a kind of full head to toe exam. And I think what I would say is that many of the features we see are quite non-specific. The things I particularly look for are kind of, do they look pale? Are they anemic, jaundiced? Have they got an enlarged liver or spleen, which is common with typhoid and malaria? Have they got a rash, which again can be very non-specific in paediatrics? I've got a couple of pictures. So this is a kind of eschar, which you can get with lots of conditions, but also with scrub typhus. And this is the kind of typical rash of erythema migrans, which you can get with Lyme's disease. So good just to be aware of those two. And then I guess the next question is, do we need to do any investigations? And if so, what investigations do we need to do? And I would always think about, what are you trying to pick up when you're doing investigations? I would generally have a lower threshold to do bloods in a child who has returned from abroad than I would in another child. And as Andy highlighted, if they've been to a malarial area in the last 6 months and potentially even a year, I would always test for malaria. So these are the kind of tests that we would often do. So full blood count can be really helpful in terms of the differential clotting, a malaria rapid diagnostic test and a smear. So most of your laboratories will initially do an antigen test and then they'll confirm that later with a smear test. The traditional advice is that if it's negative, you repeat it until you've got 3 negative tests. I think that does depend a little bit on your kind of baseline pre-test probability. So, for example, at the Royal London, most of our children and young people come back from Bangladesh, which is very low risk for malaria. So we would probably just do 1 test unless there was a particular concern about malaria. However, if you've got a child coming back from Uganda, then I would do 3 tests. Using these LFT, CRP, glucose, blood gas. Blood culture is really helpful. And again, I'd have a much lower threshold to do than in other children, particularly for picking up conditions such as typhoid, that where blood culture gives you the best yield. Urine stool tests. It can be helpful just to save a bit of serum. So Andy mentioned the Ripple test, which we usually wouldn't do as a first line, but it can be helpful to do later down the line. So often I'll say take an extra full blood count and an extra safe serum, and we can store that for later. Always worth just thinking about common stuff. So viral throat swabs, MPA for respiratory viruses are really good, as well as just things like a urine culture, excluding a UTI, and a chest X-ray, excluding pneumonia. So how do we manage children? So I think what's key is to assess them early, and we're aiming to identify infections that are potentially life-threatening, treatable, or transmissible. Just a little note about infection control, because we're always very familiar with that after COVID. The vast majority of our children most of them can be managed with sort of standard infection control precautions. So that would just be, kind of mask, gloves, and so on. If they have come back from, if they've got a sort of sort of PUO, or they've got respiratory or GI symptoms, then again we would give the same advice that we would to any other children, apart from about putting them in a side room and so on. You'll probably see in the news occasionally we have outbreaks of what we call high consequence infectious diseases. So they are infectious diseases that have a high case mortality, like Ebola or Marburg, that are very transmissible. And if you have someone who is returning from an area which has that, and often you'll have heard about it through the news, or your microbiology team will have informed you, in that case they should always go in a side room, full PPE. And I think biggest advice would be just seek advice, speak to someone early, and get some advice. I think the other thing I'd highlight about management is that don't be afraid to call your local microbiologist or Paeds ID team. So there are many different differentials for these children, and these guys are very happy to offer advice. I would always, if you've got an unwell child, even if you've got another diagnosis, I would always consider treating empirically for serious bacterial infections, and thinking about the higher risk of resistant organisms. And then in terms of guidelines, there are local and national guidelines available for specific conditions. So we're going to jump into some cases. So we've got a 4-year-old girl who returned from Nigeria a week ago. She was in Lagos for a week and then a rural village for 3 weeks visiting friends that lived there. She took no prophylaxis and had several mosquito bites. She was well when she was in Nigeria, but 3 days ago developed fever, cough, and runny nose. She saw her GP, who thought it was probably an URTI, gave safety net advice, and arranged a review in 48 hours. But today she's still spiking fevers and is more drowsy and looks pale, so is referred by her GP urgently to A&E. When you see her, she's tachycardic, she's tachypneic, her oxygen sats are fine, but she's very febrile. She's quite drowsy, but does respond to voice. She looks pale and has got a soft systolic murmur, and you think she's probably got an enlarged liver and spleen. So, some of you have answered this already, but what do you think is the most likely diagnosis in this case? Give you a few more seconds to answer. Brilliant. So I would totally agree with you. I think I would go for severe malaria. And the reason I go for that is that she's come back from Africa, and we know that that's much more common in the African subcontinent. Typhoid is more common in Asia. And we know that she's pale and she's got an enlarged liver and spleen and is getting worse. And that would all fit with malaria. Okay, so next question is, we've got some results back. So she's quite anemic and she's also got low platelets. And low platelets is incredibly common in malaria. It nearly always occurs. So if you've forgotten to ask about a travel history and you get some results back on a child and it has low platelets, I'd always go, it may be that the platelets are clotted, but I'd always go back and re-ask about travel history. And she's got an elevated bilirubin, again, which we commonly see in malaria. And she's got a positive rapid diagnostic test and a parasite count of 5%. And her blood gas shows that she's got a slight metabolic acidosis. Okay, so next question is, what treatment would you start? Okay. Brilliant. So this is always a really tricky question, and I would probably go for the third option. And the reason I would go for that is that we know that IVR testinate is much more effective than quinine. It brings the parasite count down much better, and the mortality is much lower with it. The other reason is that we know that you might remember the FEAST trial from a few years ago, which looked at giving kind of fluid boluses to children who were unwell across many different settings. And what that trial found is that the children that did worst with fluid boluses were those with malaria. And although children with malaria often may have a metabolic acidosis, probably the underlying pathophysiology is not shock. And actually, we know that giving these children rapid fluid boluses in most circumstances actually makes them clinically worse. We also know that serious bacterial infection and sepsis often coexist with malaria. So up to about 12% of children will have severe sepsis. And those children have much higher mortality. So I would probably go for IVR testinate and the ceftriaxone. But this question always gets lots of debate. So malaria, you're probably really familiar with. It's Plasmodium species, which is spread by infected mosquitoes, which typically bite kind of overnight, so from dusk to dawn. Globally, malaria is a huge cause of kind of mortality in under 5 children. And in the UK, it's not an unfrequent cause of children being unwell who are returning from abroad. And probably about 10% of imported cases are in children. Most of these are from sub-Saharan Africa. And just to be aware that severe malaria, particularly in children that have never had it before, is a medical emergency and children can deteriorate really rapidly. So one of the questions we often get is, how long after someone's come back from a malarial area do I worry? And most cases of falciparum will present in the first 3 months, but I'd usually always test for it at least for the first 6 months. Vivax and kind of other forms of malaria can present for a lot longer, so up to a year, because you can get some kind of dormant forms that kind of reactivate. So if they've come back in the last year, particularly from somewhere, it's always worth checking. How do we manage it? So, what we would advocate in the UK, and those of you that have worked in sub-Saharan Africa probably managed it very differently, is to admit all children at least for 24 hours. And that's because of the risk of deterioration. First question to ask is, are there any features of severe malaria, or are they vomiting or not tolerating oral medications? And I've put in the box some of the features of severe malaria there, which is a high parasite count, anemia, acidosis, shock, which this child had some of. So if they've got severe malaria or they're vomiting or not tolerating oral medicines, then you want to manage them as severe malaria. And you would give IV artesunate. We normally advocate for sending a culture and giving antibiotics until we've excluded serious bacterial infection. Avoid rapid fluid boluses. If you do want to give fluid resuscitation, I'd probably give it over 60 minutes or so. Consider transfusion. Now, the threshold for this varies massively depending on where you are in the world. So in sub-Saharan Africa, you may not transfuse unless it's like 40 or below, or 60 or below with complications. But usually in the UK, we would transfuse if it's less than 80. Be aware that low platelets is really common and rarely associated with an increased risk of bleeding. So you very rarely need to do anything about the low platelets. If they do start bleeding, then it may be worth giving them some platelets, but that's very unusual. Think about referring to PICU if very unwell, or a very high parasite count or impending organ failure. And once children are clinically improved, then we can switch to our kind of non-severe arm, and we can treat with ACT and oral treatment for 3 days. Any children in this category, if they start vomiting again or getting worse, then we can put them back in the severe group. And just a couple of other things to be aware of is that malaria can make you quite hypoglycemic. So do check blood sugars, particularly if children have got reduced oral intake. And just be aware, if you have used artesunate, it can cause delayed hemolysis. So children need a repeat full blood count at about 2 weeks. Brilliant. Okay, on to the next case, which is a 6-year-old boy who returned from Bangladesh 10 days ago. So he was in Bangladesh for 3 weeks in a rural village visiting relatives. And he's had a 6-day history of fevers, cough, tummy pain, and a few episodes of watery diarrhea. He's vomited twice and he's not drinking. He's normally well, and he had no pre-travel immunisations. So when you go to assess him, he is febrile, heart rate's not particularly high, and otherwise examination's normal, but he has got diffuse mild tenderness and potentially an enlarged liver. So you get some bloods back. His malaria test is negative, full blood count's okay. He's got a slightly high ALT and a high CRP, and the rest of his investigations that are back are normal. Okay, so next question is, what do you do next? I'll give you a few seconds to answer. Fantastic. Okay, so I think I would agree with the majority actually. I think sending a blood culture, admitting and starting IV ceftriaxone would be a good shout. And I think the reason I'd do that would be that he's got a high CRP, he's got abdominal tenderness, he's already got 6 days of fevers, and I would be concerned about him. Okay, so he has typhoid. And typhoid is most common in children who are returning from Asia. It's less common in Africa. It usually presents in the first month after return. And just be aware that the typhoid vaccine is good, but it's only 70% protective against Salmonella typhi and none at all against paratyphi. So don't be too put off if they have been vaccinated against typhoid. Like many tropical infections in children, it's very non-specific, so you can present with fever, kind of cough, diarrhea, constipation, tummy pain, headache. So it's very easy to kind of put down to a viral illness or something else, or gastroenteritis. Just be aware that examination can be normal. And what often happens with typhoid is for the first week, the sort of temperature is kind of high and going down, and then in the second week, it just becomes sustained. You can not infrequently get a slight relative bradycardia, although that's a little bit less common in children than adults. Abdominal tenderness, I think, is quite common, enlarged liver or spleen, and also children that are a bit confused or drowsy, again, is something that we see quite commonly. So how do we investigate it for if we're worried about it? So I would always send a blood culture, and that's positive in up to about 90% of cases in the first week. In the second week, stool and urine cultures become positive, so it's always worth sending those too. Full blood counts are usually normal, but often the CRP and often the ALT are raised, so they're quite helpful for picking up typhoid. And you might have been working overseas or had people talk about the Vidal test, and it gets done lots in lots of settings globally, but unfortunately isn't sensitive or specific. So I would kind of ignore that result. So if you're worried about typhoid and have a high index of suspicion, I would always start antibiotics. And normally my first line would be IV ceftriaxone. If they have come back from Pakistan, there is a slight risk of resistance, so I would have a chat with Micro about using IV meropenem. And for the kind of very uncomplicated cases or when children are improving, then we can switch to an oral macrolide, which works really well. I think one of the things to bear in mind about treating typhoid is that even if you've got the correct diagnosis, often they'll start feeling better, but the fevers might persist for even 5 days on the correct treatment. So you just have to hold your nerve and just wait if you think clinically they're getting better. Right, so over to the last case, which is a 7-year-old girl. It's a real life case, and she moved to the UK from Mumbai 5 weeks ago as her dad had work in the UK. She was previously well and fully immunised, including the BCG. Her grandmother had TB 10 years ago, but that was before she was born. And for the last year, she'd complained of a poor appetite, felt weak, and lost weight. She's had on and off fevers for the last 6 months and every day for the last 4 weeks, and also had night sweats. And just a word about night sweats, I think it's a very common presenting symptom. Lots of families will say the head of their child sweats at night. As kind of in terms of thinking about TB, we worry if the whole kind of body sweats, and if you're having to kind of change bedclothes or change pajamas, that would concern us for night sweats. They're kind of head sweating a little bit or feeling a bit hot, and we wouldn't worry about too much. So examining her, her weight's a little bit on the low side, and she's a bit febrile, and she's got slightly reduced air entry at the left base. So you go on to kind of investigate, thinking about possible causes, and she's a bit anemic. Her CRP and ESR is a little bit up. And when you do an X-ray, you can see that she's got a left-sided pleural effusion with some associated consolidation. She goes on to have an ultrasound, which confirms a pleural effusion and also sees a kind of calcified lesion in the right hepatic lobe of the liver, which they worry if it's a granuloma. Okay, next question is, what investigation would you do next for her? Brilliant. Okay, so I would agree with you guys. She's not coughing, and we know that children under the age of 12 rarely expectorate sputum. So actually, it's unlikely we're going to get a good quality sputum sample. If you work somewhere where you've got physios that are able to give you induced sputum, that might be helpful, but that's rarely available, and we often struggle to get that. So what's often the most helpful to do in a district general hospital is an early morning gastric aspirate. So when children cough things up, they swallow it. So actually what you're picking up there is their kind of sputum. We would often try and do 3 mornings in a row, pick that up. And we would do it for TB microscopy and culture. But as Andy said, the culture can take up to 12 weeks to come back. And if you have a high index of suspicion, and you're quite worried about a child, then I would always recommend doing a PCR test as well. And you can often get a result back of that in about 1 to 2 days. And you can access that through your local microbiologist. If you give them a call, they should be able to add that on for you and do that. She was treated initially with IV antibiotics, discussed with paediatric respiratory team. She also had an IGRA test and a MAN2 test, which are both tests that can be helpful as part of the TB picture. So they tell you whether you've been exposed to the TB bacteria or the mycobacterium bacteria, so more generally at some point in your life. But there are lots of false negatives and false positives. So they're helpful, but even if they're negative, if you have a high index of suspicion, then I would always investigate and treat for TB. And her PCR was positive for Mycobacterium TB, and her culture was positive too. And she was started on anti-TB treatment and made a full recovery. So TB in children, around 1.1 million children become unwell with TB each year, and the majority of these are under the age of 5. One of the challenges about TB is that it's very hard to diagnose and to treat. And sadly, that means globally, many children who have TB never get diagnosed or treated with it and receive the treatment that they could. Even in kind of higher resource settings, I would say TB is challenging to diagnose. And that's because symptoms are often non-specific. Children might have minimal clinical signs. Children don't cough up sputum. And children are also passive bacillary, so they produce much less bacteria than adults. So actually, it's much harder to get a microbiological confirmation. As Andy alluded to, the immune-based tests are good to do, but they don't differentiate between infection or latent TB, so sleeping TB, versus active disease. And even if you've got TB, they can be negative. The other challenge about treating TB is that you often need treatment for quite a long period, and TB medications don't taste very nice. And those of you that have got young kids will know how hard it is to get children to take medicines every day, particularly if they don't taste nice. So just a few kind of pointers about TB, and just to advocate, the BAPT guidelines are fantastic. So I'd really recommend, if you do have a suspected case, having a look at those. And I put a QR code into those there. So I would always think about TB, particularly if you've got children who've got persistent fevers, weight loss, prolonged cough, weakness, night sweats, meningitis, particularly if you've got a high protein level, high lymphocyte count. Be aware that the group that we really worry about are the under twos. So that's why we offer the BCG to kind of younger kids if they're eligible. And if you're under 2 and you have a significant TB exposure, your chance of going on to get active TB disease is up to about 50%. And your chance of going on to get sort of TB meningitis is much higher. So those are the groups that we would really worry about. Your local TB service will screen children who are contacts of a family with pulmonary or laryngeal TB, and people who are positive or under 2 should be offered TB preventative therapy. So for TB preventative therapy, we'd give a shorter course of just 2 drugs, usually 3 months of 2 drugs, rifampicin and isoniazid. BCG is not given routinely now, so just a couple of areas in the UK, I think Leicester and Newham, get it routinely. And then in other cases, it's given if you've got a parent or grandparent from a high incidence area. The other group to always think about TB in is high-risk individuals who might be starting kind of biologics or immunosuppressants are on them, and also particularly asylum-seeking or migrant children and young people from high-incidence countries. So the risks, particularly in unaccompanied asylum-seeking young people who have a very difficult journey to get to the UK and lots of exposure, can be quite high. So what to do if you're thinking about TB? So I think, as Andy alluded to, sending appropriate samples is really helpful. And don't be afraid to speak to Micro to get their advice with this. So early morning aspirates are great, induced sputum, trying to biopsy anything you can. Doing a chest x-ray is really helpful. And sometimes you can get a normal x-ray. So again, if you've got a high index of suspicion, then you might think about going on to do a CT thorax as well. How do we manage TB? So we previously would give everyone at least 6 months. Now there's been some data that shows that for non-severe TB, so the less complicated pulmonary TB and lymph node TB, we can just give 4 months of drugs, which is very good news for our children and families. For the more severe cases, or for TB meningitis or bone and joint TB, we still need to give a longer course. And we do sometimes add in steroids. So sometimes when you start treating TB and you get breakdown of bacteria, you can get a paradoxical inflammatory reaction where everything gets worse. And particularly if you might have a big lymph node that's pressing on an airway, and you get some more swelling around that, that can cause airway obstruction. So we may add steroids in those situations. And we usually monitor LFTs about 2 weeks after starting treatment. Brilliant. So just a few sort of good sources of help and advice. So I find Fit for Travel and NathNet really helpful for looking and finding out which children are high risk, what conditions to be aware of or be concerned about with children. Just to highlight, your local micro and Paeds ID team are really happy to provide advice. And there's also a 24-hour-a-day imported fever service, which is brilliant for providing expert advice, but they always recommend speaking to your local micro team first. Excellent. Thank you guys very much. And we're happy to take any questions.
Thank you. That was a fabulous talk, Anita. Thank you so much. It was really brilliant. And absolutely, if you need help, then the fever service is really helpful. There's also a rabies service, which I discovered recently on a Sunday, which is incredibly helpful. There's one question in the questions about, and I guess it's almost more of a comment about fluids in potential malaria. And the comment really is about the fact that you might end up giving fluids before you think of malaria. And is there a downside to this?
Yeah, I mean, I think that's a really apologies. That's a really great question. And I think the rule would be to do your A to E assessment. And if as part of your C, the child has got signs of circulatory compromise, I think you can definitely give steroids if you haven't got the malaria test back. I think the other caveat of that is that the FEAST trial was done in resource poor settings where most of them didn't have access to paediatric intensive care units. So I think that slightly alters things. However, anecdotally, many Peds ID doctors would say that they have seen children worsen kind of biochemically and clinically with fluid boluses. But great question.
There's another question that says, what is the T-test in suspicious TB cases?
Oh, yeah. So the T-test gets called lots and lots of different things. So there are a number of kind of immune based tests, basically, which are kind of looking basically for a sort of an immune reaction to TB. So they get called different things in different places. So IGRA, TB test, TB ELISpot, and they're all very similar. And they're basically looking to see if your body has basically come across the TB antigen in the past. Now, BCG works similarly, but BCG isn't quite as specific to TB, so may become positive with, for example, environmental mycobacteria as well. So great question.
And if you're okay, there are just a couple of others I can see. There's an awful lot of mention of the song, and perhaps it should be for the Eurovision or Britain's Got Talent, but the sort of medical questions. There's one about the role of steroids in non-CNS TB.
Great question, Mavi. Thank you. So I think, yeah, great discussion. And we would often sort of make that decision as part of a multidisciplinary team. And as pediatricians, we'll often involve our adult colleagues as well if we need to. So I think generally, if the TB is in an area where if there's more swelling, it might adversely impact the child, then we would give it. So airway compromise would be the typical example. I've occasionally seen children with abdominal TB where we've started TB treatment and they've developed abdominal obstruction and started vomiting. And in those situations, again, I've started steroids. But it's a difficult situation. And I think in those situations, I would definitely phone a friend. So don't be afraid to do that.
Okay. And perhaps the last question we'll take. If the TB PCR is only positive in the CSF, would you diagnose TB?
Rola, great question. So I think that the CSF PCR doesn't usually have such a high yield as other PCRs, but yes, provided the rest of the CSF findings fitted with TB. So if you had a high protein, high white cell count, other things fitted, definitely. If you just had a PCR and a well child and no CNS things, I would have a chat with your lab about whether there could possibly be an error. And we would often, if we do an LP, we'd often do an MRI at the same time. And sometimes if you're seeing a child with disseminated TB, so miliary TB, or you've got a very young child, it's often a good idea to do an MRI brain because actually TB tuberculomas might be, we've had some gastro children who've been on immunosuppressants and they've been difficult to treat. We've just done an MRI and we wouldn't have picked it up clinically, but we've seen tuberculomas and that does alter your treatment slightly. Great question.
Fabulous. Thank you so much, Benita. And thank you to Andy, who's been assiduously going through the questions and answering them as we've been going. So brilliant session on infectious diseases. And that moves us on to something completely different. And I'm really pleased to welcome Kate to the next session. I have to say, the first time I met ARFID was in outpatients in my clinic, and a mum bringing her child along and said, "I've arrived so that you can diagnose my child with ARFID," which was a bit of a shock because I didn't really know what it was. So I'm very grateful that you're going to enlighten us. So over to you.
Thank you, Justin. Just to say that I am briefly speaking about a couple of other things, because the remit was to talk about common referrals to child psychology, but I have included quite a large section on ARFID. The other thing just to say is that quite a few of these slides I've really designed so that they may well be useful to you in clinic as a way of explaining or talking about what's being presented to you. So while they might feel simplistic for some of you, I think actually as a way of explaining things to parents, they're quite helpful. So just let's do that and share. We will. Okay. So as the slide says, I'm a consultant paediatric clinical psychologist. I worked for a very long time at the Royal London Children's Hospital with many of the presenters that are speaking to you today. And I'm going to speak to you about a few common presentations that I'm sure increasingly you come across in your clinics, and hopefully some ideas about how to be helpful to the parents and the children that are coming to you. I very briefly wanted to just start with just some comments and some maybe helpful hints about what's often called, from my point of view, the relationship to help. And really, it's about how the parents and the child sitting in front of you have come to you, and some of the challenges that I'm sure you will recognise being presented when you're trying to maybe ask questions or to actually give advice or refer to resources. And just things like parents who just come back and they're repeating the same questions all the time, really not listening seemingly to what you're saying or taking on board the information that you're saying because they have a particular remit that they've come with. On review, unable to really see any positives or small improvements in what's happening with their child, often being quite defensive or putting up barriers to suggestions you might have or strategies you might be suggesting, saying they've got difficulty in implementing any of those strategies, being very negative about what's happening and really just wanting you to fix whatever the problem is they're presenting to you. And just to say that this is something that I and most other mental health professionals who work in a paediatric setting also come across. Sometimes there are some useful questions that can diffuse it or can even preempt some of these things. Just whose idea was it for you to come and see me? Sometimes I'm sure you feel like you're being offloaded with referrals because actually they can't get to services in the community that have been reduced or been removed. How they felt about that suggestion, what they're hoping for from you. And I think sometimes that can really preempt difficulties in offering advice and information that they're just not willing to hear. If they've seen anybody else about the problem and how that's gone, if something has been helpful and somebody hasn't. And also sometimes saying, sometimes this advice works, but if it hasn't made a difference, we need to understand why it hasn't made a difference. And I would say a comment that was made to me by one of the gastroenterologists when I started working with them a long time ago at the Royal London. He would say to me, he said, "Kate, that's all very well, but that just makes the consultation take much, much longer." I'm sorry, but that's what the case is. So these are the three things I'm going to talk about. I understand from actually that ARFID is very hot topic at the moment, so I'll try and make sure I leave enough for that at the end and for any questions. I'm not going to talk through these very wordy slides. I thought I'd include them for completeness, but also actually they're quite good reference, and also sometimes they can be useful actually as a printout for resources for parents or for older children. But just to sort of divide out these sort of presentations of anxiety are the kind of fears and phobias, a more general anxiety, which is often much more difficult to manage, separation anxiety, which I think often needs a bit of drilling down to, particularly when school might be an issue, and also social anxiety, which might be shyness or also might be actually much more overwhelming for the child in a particular school setting or a family setting. I'm breaking down some of those things as specific questions sometimes if parents are finding it difficult to be specific about what's going on. The school anxiety is very specifically related to school. I saw a young man recently who had really quite severe abdominal pain, and literally a switch went off when school was supposed to start and when school finished, even when he was at home. And we had enormous difficulty trying to find out what the issue was. Actually having parental anxiety or another sibling who's very anxiety. So actually it's something around another person's anxiety. Change, like separations or changing schools. Death or severe illness around the family. Sometimes caring responsibilities, which often a parent is struggling to disclose. Difficult questions to ask around family stress, which might be around housing or money or debt. But also some of the things we often think about with children's bullying, abuse around racism, homophobia or transphobia, and much more personal things to the child that they again may be finding difficult to disclose. But also around neurodiversity with autism or ADHD, and sometimes anxiety and neurodiversity can actually have a big crossover. Signs of anxiety, and again, this is helpful maybe to address with the parents or the child about what specifically they're experiencing. Feeling fearful or panicky can sometimes be difficult to verbalize or to articulate. So the breathlessness, a bit sweaty, butterflies or pains in the chest, or just funny feelings in the tummy or the chest. Being tense and a bit fidgety, wanting to go to the toilet quite often, often a big difficulty at school, but is that also maybe related to urination problems or sometimes constipation and those sorts of things? And also if symptoms come and go, or if they're much more consistent. And also, are they linked with anything else that might be about their sleeping, or are they having very physical symptoms that might be presenting because of anxiety? And this, again, as I say, I'm including this as sometimes it's useful to kind of include in a clinic situation as a way of identifying different areas of anxiety and helping to be more specific about what's happening for the child. There are some particular strategies or advice that you can give around these things, which parents and teachers can often help by collaborating around. Preparation, explaining what's going to happen and why. Sometimes using a diary, a visual diary, can be quite helpful as a way of doing these things. Keeping routines for some families where there's a lot going on. Routines can really get lost, and that can make children quite anxiety and feel a bit overwhelmed. There are lots and lots of books and games, particularly online. I find putting searches into Amazon really helpful. And actually, there are all sorts of books and things that need to be age appropriate and around specific things like illness and separation and bereavement. And sometimes is there someone outside the family who's supportive and helpful, particularly if there are difficulties going on in the family, and someone who's supportive and helpful. And they may need comfort and reassurance with how to cope and can be directed to useful resources. And this is just one particular strategy. It's quite linked with mindfulness, and it's actually just about helping children to breathe and pacing their breathing and getting their breathing under control. And actually just doing these things about, they call finding your calm, 5 things you can see, 4 things you can hear, 3 things you can touch. And it's about being focused down on small things and slowing things down and pacing things down. And I just included some helpful links with Young Minds and the Royal College of Psychiatry, which are both for parents and for young people, which have really helpful leaflets that they can use to read through and find more resources and strategies. Moving on to behavioural problems. Again, I've just tried to break these down into different ways that children can present with behaviour problems. Parents can sometimes be quite generic in how they describe these things. So just going through what kind of things are happening, whether it's to do with sort of angry outbursts, whether there's actual physical components to it, so hitting or biting or kicking, and obviously to a degree, this will depend on the age of the child. Is there actual damage that's happening in the home or at school? Really, really resisting boundaries and routines, and not being responsive or getting very angry about what the parent feels is a reasonable request, although sometimes it can be useful also to drill down a little bit about the child's age and their developmental stages, and what the parent might see as reasonable requests might sometimes be actually too much for younger children. Being quite impulsive and taking physical risks, although that can also be linked with things like diversity, neurodiversity, really blaming others for their behavior. So not being willing to accept that it's them that's being the cause of the problem, although there may be many things underlying why that is. If they're the bully or being unkind towards children at school or towards siblings, lots of trouble at school, although that may also be related to difficulties around education or focus or attention, and really not being able to engage in conversations about what's going on for them. And again, this is just something I think that's a useful visual slide to be used, just to maybe take it away from being very wordy and just looking at actually what might be underlying the aggressive and angry feelings for the child in question. There are some helpful strategies that maybe you feel that you could use in clinic, or if parents are accepting of it, they can try and use a way of changing their language without using very negative words and labels like they're naughty, they're bad behavior, or they're horrible. Just noticing, saying, I noticed there's a lot of this going on, especially if it's happening in clinic, you can kind of model what the language might be. I think that maybe there might be something that's upsetting you, and maybe this is why this is happening and why the anger or the shouting is happening. Maybe you're not happy. I feel worried that you're not happy, and maybe that's what it's to do with. And actually, I need you to know you can talk to me about what's going on. I think often the difficulty is when parents are very angry and frustrated, that then means that it's very difficult to find a calm way for them to talk to children about what's happening. And also having a bit of an explanation about why the behaviour has an impact on other people. And actually, while it's normal to feel angry, it actually has an impact on other people when they're angry or hit or shout. Again, some links with Young Minds and the Royal College of Psychiatry. I've also included one around ADHD and hyperkinetic disorder, which is also quite useful, and also a school link as well. And now moving on to the hot topic, I have to say, of the day, ARFID. I'm not going to read through all of this. Again, it's just for reference. It is a formal diagnostic category for the ICD-10. I think the important thing really to take away is that there really needs to be a significant physical or social impact on the child and the family for it to be formally diagnosed as ARFID. And actually that there isn't an underlying medical condition or mental disorder that's causing it. Having said that, I have to say, I think it's overdiagnosed, but obviously there is a continuum between children who are picky eaters, which is a normal developmental stage of children's feeding development, children who are very picky, and those who would be diagnosed as ARFID. And I think parents are often looking for an answer as to why their child is difficult to feed and they're refusing foods, and the parent is having a struggle in feeding them, particularly maybe with other children in social situations, or getting them into school, or schools have lots of different rules now about feeding and what foods are allowed. So as I say, that's really for a formal diagnosis that you have as a slide. There are three main categories for ARFID. It's not like a one thing. And actually, it's quite helpful to break things down if you're in clinic and having somebody who's saying they want a diagnosis. It may be very strong reactions to smells, to tastes, to textures, to colours of foods. They might be very fearful of new foods or scared of negative experiences related to unfamiliar foods. Obviously, this is not possible to have a conversation about with the child when they're very young, and children often who've had very early experiences of aversive feeding find it very, very difficult to verbalize or articulate what's going on for them. Some children have an overall lack of interest in eating, have a very low appetite, don't really find eating rewarding at all, and often deny feeling hungry or often don't seem to be hungry. I would say this is often very difficult when families where food is very important to them, if food's a big part of their culture or a part of their family's social interactions. And I've got quite a few families I've seen over the years where one of the parents has been a chef. Other children might be afraid of what might happen when they eat. They might experience pain or choking or vomiting. And sometimes these things have come about as a result of a choking episode or something like a nasty gastroenteritis or a viral illness, and they just haven't recovered from it. And this is, I would say, more true of younger children where they can't rationalize what's happened to them with a period of illness. And some children with ARFID fall within just one of these categories, while actually sometimes there can be more than one. There are a number of risk factors for children developing or much more likely to develop ARFID. So autistic spectrum conditions, much more likely to develop ARFID. They're much more rigid in their approach to things and their approach to foods. And children with ADHD and some kind of intellectual disability and delay. Children who have sensory processing disorder, and again, there's quite a big crossover with ADHD. There are children who don't seem to outgrow normal kind of selective eating or where it's very severe and appear to be more likely to develop ARFID, which I think is not surprising. And many children with ARFID also have a co-occurring anxiety disorder and are at higher risk for other psychiatric disorders. I wanted to try and include some slides which might help you drill down into this. I have to say, having worked for a long time in a multidisciplinary feeding clinic where we managed ARFID before ARFID was invented, if I'm really honest, just to look at the number of factors that can impact on a child's feeding problems. So there are the child factors on the one side and the parental management on the other side. The child factors, I think, in a way are easier to have a conversation about in clinic. I think some of the parental management issues are much harder to get to, and particularly in a short time that you have in a paediatric outpatient clinic. What I would say, if you've got someone who is, I say, asking for a diagnosis of ARFID, although why they're asking for the diagnosis, I think is a useful question to ask, whether they're wanting referral on to a feeding clinic or whether it's more about getting extra support at school. Often the real clue can be in particularly the feeding history around weaning. And you do need, you need to exclude things like reflux and allergies and all sorts of other things that would contribute to a child's having difficulty around feeding. But particularly around weaning, the process from starting on the smooth purees, do they wean onto a full range of family foods and then became more aversive? Or actually were there indicators during weaning of difficulties with textures of foods, of range of food, or with volumes of food? Any problems with coughing or choking or gagging? Some children really don't like the mixed puree lumps and start to have difficulty with those, and that can be quite distressing. Any difficulties with vomiting or regurgitation? Do they only take small volumes and need to be fed much more little and often? Are there any triggers or red flags with their drinking pattern? Things like if they're drinking with every mouthful, it might indicate that they have a level of dysphagia. Or actually, has there been force or pressure feeding, which is massively common when parents get frustrated with children's feeding and need to, they feel, get the food into the child. And even, to be honest, a lot of parents don't realize the amount of emotional pressure they put on children around feeding, and that I would count as being pressure as well. So I think the key questions really around the sort of feeding history, or actually with the ARFID, what are the restrictions and the aversions? Is it about the child not being willing to take what the parent sees as being an appropriate volume of food? Is it about the range of foods that they're taking, and is that range of foods appropriate? I know some parents who are very, very keen on a very healthy diet, can often get very frustrated and see it as restrictive if the children aren't willing to eat broccoli or lentils or, you know, some kind of green vegetable that they feel is important. But also texture. Is there an issue about texture for the child? Are they only willing to eat the very soft textures, the sort of bite and dissolves, and do they have real issues with chewing and swallowing? I guess the other thing, going back to the range, is actually some children are very focused on having very bland looking foods. So things like bread and pasta, nothing that has a strong color. And is that also something that is an indicator of there's something underlying the difficulty? I think this is really difficult. I think ARFID is best treated by an MDT. Having said that, I appreciate there aren't a lot of them around to actually do it. And ideally, it should include a doctor, a dietitian, and some kind of therapist who specializes in eating or feeding disorders. You need a speech and language therapist if there's problems with texture, as far as swallowing and feeding evaluation is concerned. There needs to be nutritional input as far as actually is their diet adequate, is it safe, and also some kind of psychological input, often regarding working with the parents and actually how they're managing the child's eating and any underlying background difficulties that they have. The main goals of the treatment generally would be, but I think that is best addressed by the MDT, is healthy weight and balanced nutrition, which is the first goal, increasing the range of foods eaten, whether that be by range or by texture, and then reducing pain, fear of pain or choking. I've included some helpful links, particularly around ARFID. There are some stuff for parents, but also information, which I think is helpful for parents as well. Although, given how many of them do a lot of their own research, they may already have these, in which case my apologies. And just generally, again, I really appreciate that the availability of children's mental health services is getting increasingly difficult. I know that in a lot of places, CAMHS thresholds are just getting higher and higher. So I've included some information that provides, I think, very good and very safe support for children and young people and parents. Youth Access actually gives local advice about what there is in the area. Young Minds has phenomenal online resources for young people and for parents, and also can give telephone support. And also there's some stuff about ADD information support services, which I think is also helpful as well. And bearing in mind, actually, I said there might be a lot of questions about the ARFID. I'm going to stop there and go to the questions, if that's all right.
Hey, that was a really lovely talk. Thank you so much for covering so many things so well. I always remember one of my early mentors in pediatrics telling me that food was love, and trying to work out what to make of that. Somebody's asked a question, Anurada's asked a question about at what age should we start thinking of ARFID? And I'm really interested in this because I think an awful lot of very small children, certain toddlers, go through quite a restrictive stage of eating. And my view as a general paediatrician, for what it's worth, is that that's normal. So when do we think of ARFID?
I would say, I actually think the ICD-10 guidelines are really helpful. I would say, particularly in young children, where obviously it's more difficult. If it's having an effect on their nutrition or their growth, which obviously as paediatricians, that would be something that you would be looking at anyway. I suppose the only other thing would be, I suppose particularly the textural side of things. If children are having struggles with textures, which is then affecting their progression with foods, I think for me, that's a real red flag. But I suppose actually, if they're eating enough of what they're eating to cover their nutrition and their growth, then I think, you know, it buys you some time to see where they're moving on to. And I think a bit of supportive advice to parents who get very stressed and very frustrated, actually to try and step back a little bit, take the pressure off, you know, let them develop a bit, you know, sometimes they just need a little bit of time. And if I'm really honest, I think often if we're talking children who are maybe going into nursery or going into school, often they will start to make progress when they're sitting in groups of children, peer groups of children, where there's less pressure, there's quite a lot of mess going on, it's just a bit more chilled. And sometimes they start to make progress in nursery or at school. And then that can start to be fed back to home. So that can be quite useful as well, if that helps.
Yeah, no, it really does help. And certainly I've seen kids who start to eat when they go to school and they sit and they eat with other children.
Absolutely. And the other thing, actually, I would just say, I used to do nursery and school visits when I was working with the feeding clinic. And actually, I think parents' perceptions of what children's normal young children's, attention around fooding, eating is quite high. And when you go and watch a group of them picking at things and chatting and, it kind of normalizes, what's usual behavior.
There are a number of different questions in there. One of the questions coming through is who can diagnose ARFID? And I certainly know I wasn't the person to do it when the mum turned up in my clinic demanding a diagnosis. Does it have to be an MDT to get a diagnosis? Can it be a single person?
Do you know, I think that's a really interesting question. And I don't think there's any clear guidelines around who gets to diagnose ARFID. I would say, and I think this, again, I appreciate this is difficult. I would say you probably need at least two professionals, and preferably one would be a pediatrician, because obviously you're screening for any kind of underlying kind of medical problems. And the other would either be a dietitian, because they're obviously looking at the nutritional content of the child's diet and can look at that, or a speech and language therapist if actually there's problems with textures and there may well be oromotor or swallowing difficulties. So I would say probably you do need two people to do it. My experience of referring into the MDTs is often they do want at least two health professionals to have seen the child. And actually, like a lot of these sort of tertiary level MDTs, they want to know what's been done locally as far as inputs being done to actually then to go on and to accept the referral and see the child.
I'm going to move away from ARFID for the last question, if that's okay. Ravi's put a really lovely question about anxiety. And he feels that it's anxiety that's being caused by the parent. And how on earth do you deal with that? Can you send the parents on a parenting course? And I read this and I smiled as I read it, but it'd be good to hear your views.
I wouldn't say unanimously that's the case. I think there are some children who have reasons for anxiety that are not related to the parents, but obviously it does depend on how the parents respond to it. And it's not unusual if you have a particularly anxious parent to also have a child who's anxious. I suppose I would say the difficulty is, are you able to have a conversation with the parent about their anxiety, maybe having some influence on the child? One of my sort of tactics sometimes would be to say, is there anybody else in the family who maybe struggles with anxiety? Because actually the parent might say, oh, yes, my, dad's mum or auntie or somebody else. And it gives you an opening as to how to have a conversation about anxiety in the family. Have they ever had any help for it? Sometimes, there are resources, where you can go and get some help about how to manage the child's anxiety. And what I would say is often the person who's offering the anxiety support, you can address it to say there are courses you can go to about how to manage your child's anxiety. But in fact, what they will also do is manage the parent's anxiety as well. So I think you don't want to get the parent defensive about you're saying this is my fault, but there's a way in to start having a conversation about anxiety. And most professionals, when they're talking about children's anxiety from a mental health point of view, will also be asking about a parent's anxiety.
Thank you so much. That was a really, really lovely summary. I think it's time to hand back to Akshay, who's going to hand deliver all our lunch now.
Thank you, Justin. Maybe, I don't know, we have a couple of minutes. We could go through some more. Like there was a question about weight-related things, Kate,
Okay.
Weight loss and ARFID and that sort of, before you go to lunch. Just
okay. Yeah, go on.
Let me just pop up the questions again. There were a couple about can you exclude ARFID in a child who's not losing weight? And I think you said in your list of things that you had to be losing weight.
It has to be either concerns about weight loss or about significant social impact. So actually, if the child is in social situations because of their aversion, then that would also be a reason.
The other one that really interests me is what happens to these children. So Saeed's asked, what's the prognosis for children with ARFID, especially if there's not another comorbidity?
To a degree, it depends on when it started to show itself. And this is if you really excluded anything medically that's underlying it. We used to see a lot of children with things like reflux and allergies, undiagnosed allergies and those sorts of things. So if there's nothing underlying it, they are difficult to work with. And particularly, as I say, there's a big cohort who have ASD, ADHD, neurodiversity. They're very, very difficult to manage. What I would say with the slightly older children, one of my questions to parents in clinic would be, who's the person who's most concerned about this? And I would say to the child, are you worried about the range of what you're eating, or are you happy with what you're eating? And is it mum and dad who are more worried about it? And sometimes I would say, no, I want to be able to join my friends and go to parties and not have to worry about it. But often the younger ones, certainly kind of under 7, 8, they would say, no, absolutely happy. It's all their problem. And until children have got some kind of interest or motivation to do what you're asking them to do and change their eating, you're going to get nowhere, because there's just more and more pressure and they just shut down and just refuse. You need to have the child engaged in the conversation about it, and particularly if they're not bothered about it, and if they're on some, has some kind of level of neurodiversity, and actually all of the social pressures and things that will often come into play for sort of the slightly older children once they realize they're different and they're missing out on things, it's much, much harder to work with them. So sorry, that doesn't really answer your question, but that, there's a real range. But neurodiversity, lack of engagement in there being any kind of an issue, and no motivation and actually engaging any kind of strategies, you're not going to get anywhere, because it will just get more and more pressure. And as long as they're healthy nutritionally and they're growing, actually they have time to change it later on. And sometimes it's not until they're teenagers that they actually start to think, this is really starting to restrict my social life and I want to be able to, change what I'm eating.
And probably now the final question, does ARFID exist in adults, somebody's asking, or is there a maximum age for diagnosing it?
It does exist in adults. I think there are a lot of adults. I mean, we used to treat ARFID in the MDT before it was called ARFID. There are a lot of adults who have significant aversive eating and exist on a very, very restricted range of foods. Some of them, again, if they're not bothered about it and they're healthy because they're managing it within a restricted range of foods, then obviously that's their choice as an adult. But equally, if they want to do something about it, I think the areas where they can get help are very, very few and far between.
Thank you. That was really, really helpful. And now we'll hand back to Akshay, who's hand delivering all our lunches.
Welcome back to the afternoon part of the day. I am introducing two paediatric consultant endocrinologists from the Royal London. First up, Dr. Shah, who's going to talk to us about short stature, which is a mind-bending presentation in our general paediatric clinic. So we're all welcoming some insight.
So thank you very much. Hello, everyone. So today I'm going to talk about management of short stature in children. So just a quick overview, what I'm going to try and do in the next 20 minutes or so about talking about physiology and normal growth. And then I'll kind of go through how we define short stature, how we recognize causes of short stature, how we approach and undertake investigations. And then when would we refer to specialist teams, and especially identifying the red flags, which will be very important. And then I've got some questions just to do a little bit of interaction. So could you please download this Slido app? This is a QR code. So if you can please download the Slido app. This the QR code will come up on the questions as well. So don't worry if you can't download now. So when we talk about the ICP model of growth in children, which is infancy, childhood, and puberty, it's really important for us to understand what is a normal growth pattern in children. And it's important to understand what is a normal height velocity. So when we talk about infancy, nutrition plays the most important role, and the height velocity is about 25 centimeters a year. During childhood, it's the growth hormone and the thyroxine, which are the primary hormones that helps in growth. And the height velocity is about 4 to 8 centimeters per year. And then during puberty, along with growth hormone and thyroxine, there's also role of sex steroids, which is puberty hormones, and the growth velocity is about 8 to 10 centimeters per year. When we talk about pubertal growth spurt, it's really important to understand because it determines when the growth will stop in girls and boys, and it differs in both girls and boys. So when we talk about females, especially in the pubertal stage, which is breast stage 2, which is about average of 10.5 years, which is when they have peak height velocity. So you can see in the graph here where they would be having a peak height velocity around breast stage 2. And then they will finally stop growing after 1 to 2 years of menarche. Whereas in boys, it is slightly delayed, as you can see in the graph, where they have a peak height velocity around when they reach about 10 mLs of testes, which is about average of around 13 years. And then their peak height velocity average is about 10 centimeters a year compared to the girls, which is about 8 centimeters a year. And then eventually, 2 years sort of after the peak height velocity, they gradually slow down. So this is a cartoon model, and this is something that we've learned in our medical school, that how growth hormone actually is produced. So we know that growth hormone is primarily produced by anterior pituitary gland. So it is primarily controlled by hypothalamus, which secretes GHRH, growth hormone releasing hormone, and somatostatin. That growth hormone stimulates liver to produce IGF-1, and both growth hormone and IGF-1 will then act on growth plate chondrocytes as well as other target tissues in terms of growth, helping in growth. So in terms of defining short stature, which is obviously very important when GPs or primary care practitioners would refer children to clinic, where we would say height, which is less than 2 standard deviation score, which is all below the second centile for age and sex, or height significantly below the genetic potential, which is more than 2 centile spaces below mid-parental height target range. Or if children have growth failure, which means that they have crossed down the 2 centile spaces in terms of their height, or they have poor growth velocity for their age and pubertal stage. And that's why the growth velocity or height velocity is really important to understand what is a normal growth velocity before we obviously determine what is abnormal. And always use this, or always make sure we plot on UK WHO or Royal College growth charts and monitoring the growth pattern over time. So when we talk about causes of short stature, I would like to first of all say that most of the children would either be normal variant or physiological. So it's really important that majority of the children, when they get referred, yes, they are likely to be normal variant and physiological, but very importantly is to measure parents' height and plotting them on the growth chart, which I'll come in the next slide. However, when we talk about then other causes for short stature, then we know this chronic diseases like renal failure or bowel disease, inflammatory bowel disease, short stature due to small for gestational age or failure to catch up. There is a familial or genetic form of short stature, constitutional delay of growth and puberty, which is a common cause, and it's again important to understand the physiology of the growth and puberty that helps us to determine that. Then there are endocrine causes, which we come across as growth hormone deficiency or resistance, hypothyroidism, hypogonadism, hypopituitarism, Cushing syndrome, rickets. There are various forms of skeletal dysplasia that causes short stature, syndromic forms, and typical the common ones are Turner, Noonan's, and Silver-Russell syndrome. There are non-dysmorphic causes of short stature, which is typical of monogenic and polygenic cause, and SHOX deficiency is one of them. And growth hormone is licensed in SHOX deficiency. And then one of the other important factors that we need to consider is psychosocial deprivation, which is again, it's very important for us to take clinical history and ruling out psychological causes. There are short stature syndromic causes, which is non-endocrine. So if they are with disproportion, then we typically think about achondroplasia and various bone disorders. Without disproportion, then I typically think about Kabuki syndrome, Russell-Silver syndrome, and SHOX deficiency. And then with microcephaly, always think about ruling out DNA repair syndromes. And the reason why I mention this is because growth hormone is generally contraindicated in children with DNA repair syndromes. So coming to the measurement, so once we do kind of obviously look at the history, which I'll come in the next slide, but very importantly, when how we measure the children, important thing is to use calibrated stadiometer, which is standing height, but in infants, we measure them as supine and plot them onto UK, WHO, or the Royal College Pediatrics growth charts, and we have a digital growth chart on the Royal College website, and then monitoring the height velocity or growth velocity over time. So how do we calculate midparental height and target centile range? So this is for boys. And I've put here always measure parents' height rather than guesstimating. And that's something that we sort of time to time we see that because the parents' height has not been measured accurately, they get referred to our clinic with short stature. And then when we really plot their height, it comes out completely normal. So please try and take mother and father's height if possible, accurately. So when we do for boys, how do we calculate the midparental height? So you take father's height plus mother's height plus 13 centimeters divided by 2. So if the father's height is 178 centimeters and mother's height is 164 centimeters, you then divide by 2, then the midparental height will come back as 177.5 centimeters. And then you do the target centile range, so which typically is plus and minus 8.5 centimeters from midparental height. So you can see in this graph that the red zone is the target centile range and the dot here is the midparental height. And similarly in girls, the difference is that you minus 13. So father's height plus mother's height minus 13 divided by 2. So the same with the same father and mother height, you can see the midparental height is 164.5 centimeters. So you can see the midpoint here, and then you do plus and minus 8.5 centimeters to determine the target centile range. So you can see that this is the target centile range with this red zone, the red color bar, and this is the midparental height. So every time when you plot on the growth chart, just remember to do the target centile range, which is really important to see whether they are actually following the target range. And anything below, and that's where we were talking about that anything below 2 centiles, it generally works out around 2 centiles. But anything below 2 centiles, that is when you determine, to refer to pediatric endocrinologists. So generally it comes out that if they are below the target centile range for the family. So in terms of clinical evaluation, we all know it's really important to take good clinical history, especially with the birth weight, length, looking at the past medical history, family history, review of various symptoms, especially with the chronic illnesses like ruling out inflammatory bowel disease or renal insufficiency, looking at the family history, especially we took to talk about family history of short stature, delayed puberty, and and if there is any consanguinity. And most importantly, looking at the height velocity. So having a red book really helps to just kind of see what is the height velocity. And then looking at the physical examination, especially looking at the body proportions and if they have any brachydactyly or scoliosis, looking at any evidence of hypopituitarism, especially if they've got micropenis. And then looking at in older children, looking at the pubertal staging. So when we think about that, this children or this group of children may have underlying pathological cause, then you think about doing initial growth investigation. So yes, after doing the auxology and plotting them on the growth chart, you then undertake basic general investigation, which is typically full blood count, liver, kidney function, bone profile, celiac screen, and ESR. And then you also have to think about do baseline pituitary function, which is thyroid function test, IGF-1, BP3, prolactin, cortisol, and ACTH, and also do gonadotrophins and pubertal hormones like testosterone, estradiol if they are in pubertal age. Please remember to do karyotype in girls presenting with short stature, which is really, really important to rule out Turner syndrome, including mosaicism. Also do microarray, especially if they have delayed development or learning disability, or if there are multiple congenital abnormalities. And then you can do X-ray for bone age. We primarily consider doing X-ray for bone age in sort of older children, especially after 5 years of age. It's a bit more helpful in older children. And young children, it's very difficult to determine the bone age. So when we have the results, we obviously have to think about how we diagnose this condition. So if you have got positive celiac screen or renal failure, Turner syndrome, hypothyroidism, you treat them. If there is raised ESR, you would consider underlying inflammatory bowel disease, thinking about gastroreferral. Think about low IGF-1, low TSH or delayed puberty, then you think about hypopituitarism, especially where they can have multiple hormone deficiencies. Low phosphate or bowed legs, which is typical of rickets. Delayed bone age, again, it's very common and is a sign of delayed growth, which we would normally see in constitutional delay in growth and puberty, and that allows for the growth to catch up over time. Very rarely they may have advanced bone age, and you think about rare bone conditions like ACAN mutations. And then you think about short metacarpals, mainly in Turner syndrome, SHOX deficiency or pseudo-hypoparathyroidism. And also then consider genetic testing for SHOX deficiency, as growth hormone is now licensed in children with SHOX deficiency. So what are the principles of management? And the first thing I would always kind of think about is reassurance and observation, because most children do not really need treatment. And when we plot their growth, including parents' height on the growth chart, it actually comes out as that they generally are growing within the normal sort of height velocity or within the target centile range for the family. However, yes, if you think that there might be underlying pathological cause, then you have to rule out what is the underlying cause by doing the primary investigation and confirming the diagnosis first. But primarily what is more important is looking at the growth velocity, bone age, and accurately plotting on the growth chart, because that is the most important thing for us to determine whether this is pathological or physiological. And then you look at the target centile range as well. Think of SDS score, because the SDS score also helps with standard deviation score, also helps us to determine when to refer and whether they are within the range for the family, especially if they have short parents. And early referral improves outcomes, especially if they have underlying systemic involvement. So this is just a couple of growth charts, which I'm just showing you about constitutional delay in growth and how it looks like. So you can see that the height velocity seems reasonable, where the child is growing sort of on the lower centile between 0.4th and 2nd centile, but has got delayed bone age about 1.5 years. So this is about a 5.5-year-old who has got delayed bone age about 1.5 years. And you can clearly see that actually that height based on the bone age is corresponding into the midparental height. So when you look at the height, it actually falls into the midparental height. And this is a growth chart for constitutional delay in growth and puberty, where you can see there's an older child who actually has got delayed bone age by nearly 2.5 years. And you can see that the growth is sort of under the 0.4 centile, but because of the delayed bone age, the height actually corresponds with the bone age around with the midparental height. Now, if you would do the target centile range for the family, you could clearly see the target centile, the lower end of target centile range will be just below 0.4 centile. So this height actually falls at the lower end of target centile range for the family. So what are the treatment indications of growth hormone in the UK? So obviously they get referred to pediatric endocrine team, but primarily growth hormone is licensed in children with growth hormone deficiency, Turner syndrome, Prader-Willi syndrome, chronic renal insufficiency. Those children who are born SGA but have growth failure at 4 years of age, and the height SDS is less than -2.5. So anything less than -2.5, they will be eligible for growth hormone treatment. Those children with SHOX deficiency, we also use in children with Noonan syndrome, but it's not licensed, or it's not in NICE guidance. So the British Society of Pediatric Endocrinology and Diabetes had put out some recommendations as when would you refer to specialists, or especially the pediatric endocrinologist. So those children whose height is less than 0.4 centile, which is less than minus 2.7 SDS, or if children height is less than second centile or less than minus 2 SDS if they are more than 3 years of age. So if you think about if they're more than 3 years of age, then if they're below second centile or minus 2 standard deviation score, then think about referring. And if they are especially shorter or outside the target centile range for the family, which is what I had mentioned, outside the 2 centile lines for the family. And also consider referral to those with red flags present, which I'll just come to the next slide. And also, please try to record parents' height and not estimate them. Now, if you have normal primary investigations and the bone age, then you consider stopping that investigations or review if there are no red flags present. However, if there is significant short stature or significant short stature for mid-parental height and abnormal growth velocity persists, then please consider for genetic testing. So what are the red flags for the genetic origin of short stature? So in history, especially, you think about SGA with no catch-up of growth, severe short stature, which is less than 3 standard deviation score, consanguinity or short parent, which is typical of autosomal dominant defect, or family history of short stature. And in examination, typically we have dysmorphic features, microcephaly or relative macrocephaly, disproportionate limbs, or features of growth hormone insensitivity or resistance. So, and to summarize, when we think about or when we see children with growth short stature, it's really important for us to look at the red book and make sure that they are plotted appropriately on the growth chart, especially looking at the growth velocity, thorough history and clinical examination, which is really very important, but also make sure we plot parents' height as well as plot the target centile range. The constitutional delay of growth and puberty is the most common cause of short stature. Height velocity with bone age, as well as the mid-parental height, they are crucial parameters, especially when seeing children with short stature. You consider referral to specialist, pediatric endocrine team, especially if the height SDS is minus less than 2.7 SDS or minus 2 SDS if they are more than 3 years of age, as well as they are short for mid-parental height. And then you look out for red flags, especially if you're suspecting a genetic cause, and it will be useful to refer to geneticists as well. So I'm just going to Q&A. I got about 6 questions. I think we can do it the next couple of minutes. So if you can download this app, this is the code. So a 13-year-old boy is referred for short stature. The height is on second centile. Height velocity is 6 centimeters per year in the last 2 years. The puberty tenor stage is 1, so it's prepubertal. Father recalls that he started puberty around 15 years of age. So there is a history of delayed puberty in the family. Normal examination, normal screening bloods, and the mid-parental height is on the 9th and 25th centile. What's the most likely diagnosis? I think sorry, Anna, I think I can see it here. So
I think someone was saying that if you go into it and you right click and you say next slide instead of clicking on, that might work.
okay. So I think I'm able to see the answer. So the answer here is so you've got growth hormone deficiency, familial short stature, constitutional delay in growth and puberty, hypothyroidism, and Turner syndrome. So 85% of them have answered as constitutional delay, which is the right answer. When I so what generally it used to come as all the options as well. So sorry, I'm just. So case 2 is a 6-year-old boy present with poor growth, which height is less than 0.4 centile. So height SDS is minus 2.9 SDS. Height velocity is 3 centimeters here. Weight is on 25th centile. So weight is preserved. Immature facial features, normal birth history, so not SGA, no chronic illness symptoms, and the midparental height is between 9th and 25th centile. So which is the initial investigation that is most appropriate next? So you got MRI brain, bone age or X-ray, IGF-1 BP3, growth hormone stimulation test, and celiac screen. Which one would you consider next?
And I think if people are having struggling with the Slido app, maybe put it in the chat and then we can say it instead.
So the answer is IGF-1 BP3. So that will be the answers. Going to case 3. So a 7-year-old girl is referred for short stature. The height is 0.4 to second centile, which is minus 2.8 SDS. Birth weight is 2.7 kilos, which is minus 1.9 SDS. The height velocity is 3.5 centimeters per year. Has got broad chest and cubitus valgus, recurrent otitis media, no chronic GI symptoms, and normal development. What investigation should be performed next? So you've got bone age, IGF-1, karyotype, MRI pituitary, and DEXA scan.
And again, if your Slido app is not working, pop it in the chat. Yeah. So we've got lots of C, karyotype, karyotype, karyotype.
So karyotype is the right answer. So you rule out Turner syndrome. The next one we have is 9-year-old girl present with faltering growth, who present and has got history of tiredness, height dropped from 25th centile to 2nd centile over the last 2 years. Weight was 0.4 to 2nd centile. Mid-parental height is 25th centile. So you got weight and height both affected. There were concerns about weight gain, a poor weight gain, occasional complaint of abdominal pain, and has got iron deficiency anemia. What is the most appropriate initial test? So you've got ESR, X-ray bone age, ultrasound abdomen, celiac screen, or IGF-1 BP3.
So most people in the chat saying celiac screen there.
Yeah, thanks. And then we have is the 5-year-old boy who is referred for short stature. Born at term, the birth weight is 2.4 kilos, which is small for gestational age, minus 2.2 SDS. The current height is between 0.4 and 2nd centile, which is minus 2.5 SDS. Weight is on 2nd centile. Height velocity is 4 centimeters per year, with a mid-parental height of 9 to 25th centile. There is history of slight delayed development, no other chronic illness on and normal examination. What's the next most appropriate next step? So you've got reassure and discharge, X-ray bone age, request MRI, refer to pediatric endocrinology, or monitor as likely familial short stature.
Mixture of endocrine and reassure.
So here, what you have to think about, this is an SGA, small for gestational age baby with minus 2.5 standard deviation score. And remember, I was talking to you about anything above minus 2.5, think about failure to catch up. Obviously, this child is short for the family or at the lower end of target centile with poor height velocity. So again, the height velocity as well is, remember that 4 centimeters is the lower end of normal. So this child is likely to need or will be able to fulfill the criteria for growth hormone therapy. So you can refer this child to pediatric endocrinology. So you've got a 3-year-old girl with presenting with faltering growth, height is less than 0.4 centile, weight is less than 0.4 centile, poor oral intake and abdominal pain, with normal birth weight, limited eye contact and speech delay, normal initial blood test, and weight improves during hospital admission. What do you think is the cause? I'm not sure whether you can see the options. But you've got growth hormone deficiency, celiac disease, constitutional delay, psychosocial growth failure, and skeletal dysplasia.
So yeah, most people saying psychosocial.
Yeah. So I'm sorry the slider didn't work. It was working earlier. But yeah, thank you very much. And yeah, any questions?
Thank you, Dr. Shah. That was brilliant. Thank you so much. And sorry about the Slido, but I think most people managed to get all of the answers and questions up on the chat. There were a couple of questions. There was one about how many height measurements and over what time. So over what time period we would be following up these children and measuring their height to assess their growth velocity.
So growth velocity is always assessed at least over 4 monthly. So we usually see 4 to 6 monthly. So you will need to have a couple of serial measurements to see the height velocity. But when we see children, I would say 4 to 6 monthly.
Okay. And just we're running out of time, so just one more question. One about, can you comment on tall parents but short grandparents on one or both sides? So like a tall parent who's out of the normal for their family.
So yeah, we do see sometimes that you've got one parent who is really tall, or but their family members are really short. And I think more importantly is you have to think about investigating that, because if you look at the mid-parental height, and if they're still outside the target centile range for the family, it is always useful to investigate. However, if they then have over a period of time, they have a normal height velocity and they're continue to follow the same centile line, then we generally kind of say this is likely to be familial and and unlikely to be pathological. But yes, it's always good to follow them up because they could have underlying growth hormone deficiency.
And one more question from me regarding growth hormone deficiency and growth and testing growth hormone. Timing for that, or when you
Yeah, so we sometimes get patients referred and say there's low random growth hormone, and growth hormone is not a very good test. So please do not really do just the random growth hormone levels, because that's not really good test. But IGF-1 is a useful marker. However, in the first 2 or 3 years of age, the IGF-1 is also very much dependent on the nutritional status of the child. So again, you may have low IGF-1 if the nutrition is not good. So, it's not a very accurate test in the first couple of years of life. So we have to see the child as a whole, and obviously, if you suspect nutritional issues, then I would address that first before we obviously look into that. So sometimes we end up following up these children in clinic and just monitoring them, and mostly it turns out that it's a nutritional cause rather than anything else.
Thank you so much. We're going to move on now to Dr. Sasha Howard, who is going to talk to us about precocious puberty. Thank you.
Thanks, Anna. Thanks. Great to follow Pratik's brilliant talk. I'm just going to share my screen. And then put this in full slide mode, which hopefully you'll be able to see. There it is. So kind of going hand in hand with growth in childhood is puberty. And so this talk is in some ways complementing the previous talk, because here we're talking about precocious puberty. So these children tend to be physiologically a bit advanced compared to what you would expect for their age. They're often taller, and we'll talk about why that is, what's the underlying endocrinology going on, and how we might approach differentiating of something which is really abnormal or pathological from something which is a variation of normal. And that's a lot of what this talk is about, and it's a lot of what we do in pediatric endocrinology, because there's a big spectrum of normal and normal timing of puberty particularly. So it can be really tricky to work out what needs investigating, what needs referring, and when we need to get worried. But just to set the scene, because it's important to think about what the underlying hormones and hormonal profiles are, I'll just show you these pictures. So we often think about puberty as the first time that a child will have any kind of reproductive hormones. But actually, that's not true, because don't forget that the whole hypothalamic pituitary gonadal axis is very active in fetal life. That's how you get sex determination between male and female. And also this critical time, don't know where my pointer's gone. Let's do a right click and get a proper pointer if I can. And this is a critical time called mini puberty, when babies in the first 6 months of life have, again, a really pronounced activation of the whole endocrine, in terms of reproductive endocrine axis. So if you can measure hormones in, for example, a 2 or 3 month old baby, they'll have LH and FSH and sex steroids, say testosterone or estrogen, in a detectable range that can be very useful for telling you about whether those hormones are functioning properly. And we'll come back to mini puberty and its importance for precocious puberty a little bit later. But what happens at puberty is that the brain turns on. So these are particular specialized neurons in the hypothalamus called gonadotrophin releasing hormones, and they secrete pulses of GnRH, which then stimulates the pituitary to produce the key gonadotrophins LH, luteinizing hormone, and FSH, and they act on the gonads. So generally speaking, at the beginning of puberty, a child will have small, immature ovaries or testicles, and these will gradually increase in size and then start to produce testosterone or estrogen, which will then give you the secondary sexual characteristics that we associate with puberty. And as I said, there is a real range of normal timing in healthy children, but it's true to say that it tends to follow a pretty similar pattern. And that can give us a real clue if something is happening in an unusual timing pattern, that might be a red flag. So the majority of girls will develop the first breast buds, which is Tanner stage B2, not before age 7.5, and not after age sort of nearly 13. So that's the normal range, with the majority not developing breast buds till about 10 years of age. And then most children will develop a little bit of pubic hair shortly after that, and they'll be growing relatively steadily until they get to mid-puberty, when they'll have what's called peak height velocity, so that maximum growth spurt. And this is girls, so girls don't get their menarche until they've got quite good breast development. They've gone quite a long way through puberty. So if, for example, you get a girl with PV bleeding, which we might think is menarche, but she hasn't got much breast development or any breast development at all, then of course that would be out of the normal order and a red flag that there might be something pathological going on. And similarly for boys, there is a range of normal for entering puberty and having some testicular development, and that tends to happen around the same time or just before they develop pubic hair. And again, their time of maximum growth, of the maximum puberty growth spurt, won't be until they're sort of midway through puberty. But of course, there is variation, and some of that is due to the genes that you inherit from your parents. And in endocrinology, we will always ask the question to the mum and dad, when did you go through puberty? And often women, mums, remember the age that they first had their first period, because that's quite a kind of pivotal moment in a girl's life. And the dads tend to go, I don't know, and don't remember. The dads that do remember tend to be the ones that are either very early or very late. And especially for, as Pratik talked about, constitutional delay in puberty, sometimes you'll get a dad who will say, well, actually, I was really late. I didn't shave till I left uni, or I was still growing until I left school, or I was still growing at university. And that can be a clue. But of course, there's also gene-environment interaction, and we know that there are lots of things that have happened over the last few decades that have influenced the timing of puberty. A lot of that is about BMI and the obesity epidemic, and we know that increase in weight leads to an increased predisposition to having early puberty. There's also potentially quite a lot of other factors, such as screen time or stress, possibly also endocrine disrupting chemicals such as plastics and bisphenols in the water that is a bit more difficult to unpick. But there's a lot going on that might also be affecting in the developed world what the timing of puberty is for the current generation. Just to give you some data on weight, so it's really about how overweight a child is in quite early childhood. And for every increase in BMI unit at this early age, that will bring forward the timing of puberty by about a month. So that's not a huge amount per child, but if you think on a population basis, that's a big shift to earlier puberty. So to give you some specifics, when we define precocious puberty, that's in girls of puberty starting earlier than 8 years of age and in boys starting earlier than 9 years of age. And you could rightly ask, if everybody's getting earlier, shouldn't we be reducing those thresholds? And the decision internationally was not to do so, was to keep it at 8 years in girls. But I think as clinicians, we recognise that a slightly overweight little girl aged 7.5 who's starting to develop breast buds may be within this normal range if we can slightly extend it. The definitions we give are for girls, any development of a breast bud, so that doesn't have to be both sides, that can be unilateral, and that's that first little lump that you feel behind the nipple. And in boys, it's all about testicular volume, so that can be difficult in clinic. But what we do as endocrinologists is we get out our orchidometer or our special measuring beads, and it's 4 mils. And again, it can be unilateral. But once a boy has a testicle that is 4 mils or more, then he has reached Tanner stage G2 and he has entered puberty. It's relatively rare and it's definitely more common in girls. And we see that in clinic with way more girls being referred than boys. And generally, they're otherwise progressing through puberty in a pretty standard way. So it's just about a timing difference. And it's rare that you'll find an underlying abnormality on MRI or a genetic cause or any kind of tumor, but it is important to have that in the back of your mind, especially if there are other red flags. So as I've said, there's a real spectrum of the healthy population, and it's only when we get down to this very, very early age that we start to think about defining precocious puberty. But of course, we're going to see kids that are in this sort of overlapping grey area sitting just either side of this border. And it's important because it does have implications for future health. We know that endocrine cancers are more at risk in children that have very early puberty. Also, metabolic dysfunction with type 2 diabetes, obesity, high cholesterol, etc. And there are also associations with risky behavior, early sexualization of children that have precocious puberty. But we need to distinguish that between these kind of benign variants of puberty that we see in healthy children. And we talk about those as premature thelarchy. So that's early breast development without true puberty, which is a tricky thing to distinguish and often needs a period of monitoring. And there's also this sort of in-between category called slowly progressing early puberty. And I think it's not unreasonable to just refer those to pediatric endocrinology and let us do the monitoring. But there are some children who clearly start early, but then progress slowly and may not need any treatment. And we'll talk about andronarchy in a minute. So what do we mean about premature thelarchy? Well, that's why I really stressed about mini puberty, because in mini puberty, little baby girls often do get a bit of breast development. You get a lot of FSH stimulation. And what we think is that some girls, they just sort of have this lag of ongoing FSH stimulation with this ongoing little bit of breast development into mid-childhood. It's often the younger girls, it can be before 2, but often the younger girls, and it's not progressive. So if you monitor them, the breasts will stay pretty much around B2 and they won't move forward to more developed breasts. You often don't have to do any bloods, but if you did, you'd see this high FSH with a normal or low undetectable LH. And again, you may not do any investigations, but if you did, you'd see that the bones were not becoming more mature. We talked about bone age in the last talk. Children that just have isolated or premature thelarchy will have a pretty normal bone age. And if you were to progress to a pelvic ultrasound, that would be pre-pubertal and not worryingly developing into a larger, more pubertal sized uterus, and no treatments required. And that's in contrast to true central precocious puberty, which is a developing progressive course with a higher LH than FSH, and it's really LH that's driving that true puberty, advanced bone age, and the uterus does start to become larger and a more pubertal shape, and you may think about treating there. So just to summarize that, sometimes if all you've got is a little bit of breast development in a younger girl, you may not need to do anything other than monitor. It's important to track their growth and particularly their height velocity. And if they're crossing centile lines, that is a reason for concern. If you do a bone age, it shouldn't be more than 1.5 to 2 years advanced. And if it is, then that may be a reason for concern and referral. And if they've got other red flags, maybe other syndromic features or associated neurological problem, that may be worth investigating. And if you do baseline bloods, then you shouldn't really have detectable LH or estradiol in a girl or testosterone in a boy. So if you do, then again, that's a bit more of a worry. This is a big chart. Please don't worry about it. It's really just summarizing all the different causes and saying that the things we look at are the different signs of puberty, so breast stage in a girl, but also pubic hair and axillary hair, their bone age and maturation, and their height velocity. And then we follow this flow chart down. And these children that we've been talking about with premature thelarchy, we just be monitoring and not be worrying about too much. But of course, there is a big spread. And the vast majority of children that have true precocious puberty will have central precocious puberty that we used to call idiopathic, but we often now call familial or genetic because we're understanding more and more about the genetics. And we'll talk in a minute about GnRH analog therapy that we often treat these children with. We think about MRI scanning in these children, although there is some suggestion that maybe if a girl is over 6 years of age when she first develops breasts, so not as extremely early and has no other red flags, then she might not need an MRI brain because the vast majority of those children will not find anything on an MRI brain. And a pelvic ultrasound will tend to be showing pubertal changes, and that can be monitored. Very, very rarely we find an organic cause in a girl. So, that might be an underlying tumor or other syndromic cause, and then we would treat the cause that we find. And extremely rarely we get a diagnosis of peripheral precocious puberty. So that's not driven by LH and FSH from the pituitary, but that's another exogenous or endogenous but non-central cause. So that might be an ovarian cyst or an adrenal pathology. It might be exogenous steroids or exogenous estrogens, or there is McCune-Albright, which I'll talk about in a moment, which again is very rare, but important to think about. So GnRH analog therapy is something that we do offer in a lot of cases, but it is very much case by case dependent, and it's a conversation with family about whether that's appropriate. What we're really seeking to do is to preserve adult height, because what happens in children that have very early central precocious puberty is they grow fast, they're tall compared to their peers, but all of that circulating estrogen fuses their bone ends far too early and they end up short. And if you give GnRH analogs, you can pause their hormones, you bring down the estrogen levels back to undetectable or testosterone in a boy. They'll continue to grow, but at a steady rate, and you'll enable them to preserve their adult height and end up not significantly short in the majority. But it does depend where you catch these children. And in ones that already have a bone age of 12 years or more, the evidence is that you've probably already lost the opportunity to preserve their adult height. And it may not be beneficial to height to give these kind of treatments. But we still have families where it would be of significant psychological distress to that a 7, 8, or 9-year-old girl to have periods, and it's difficult, especially in key stage 1, to deal with monthly menstrual cycles. So sometimes there are other reasons to continue with the treatment, and that may be also true for children that have learning difficulties or already incontinent of feces and urine, and the parents would really struggle also to deal with menstruation. It's generally well tolerated. We've now moved at Barts to giving it every 24 weeks, so that's just twice a year. So it's not such a burden on missing school and those kind of things. It is a slightly painful injection, but most of our kids tolerate it quite well. Okay, and then I've spoken already about etiological therapy for organic CPP, and then for McCune-Albright, which is a very rare condition that would need specialist tertiary or even quaternary treatment, or in a treatment centre with either blockage of estrogens or aromatase inhibitors. And for those particularly rare ovarian or adrenal tumours, that may need medical or surgical therapy. Just very quickly touch on genetics, because we do lots of genetic diagnosis in paediatric endocrinology. There isn't an NHS panel yet for precocious puberty because there's still not that many genes known, but it's becoming a more understood area. And actually, many of those families with inherited precocious puberty, we can find an underlying condition. And most of these genes are related to the kind of upstream break on this hormonal axis, that if you get a mutation in one of those genes, then you release the brake and the child goes into puberty. McCune-Albright, as I'm sure you all know, is a rare mosaic syndrome where you get a post-zygotic mutation in this GNAS1 gene, so that you get this hyper stimulation of the receptor for the gonadotrophins on the ovarian cells. So there is activation of the receptor, often very early at the age of 2 or 3, and these children will go into precocious puberty. And you may also find other parts of the syndrome are visible, like you can see here, the big cafe au lait spot patches or fibrous dysplasia in these children, but it's extremely rare. Okay, the main point about precocious testicular enlargement in a boy is that it needs investigation. Girls, it's often idiopathic and may not need MRI. Boys with precocious puberty will always need referral and an MRI because it is much more common to find an organic cause and sometimes an underlying tumor or other genetic cause such as testotoxicosis, which I can never say. So, you know, you don't need to know all the things that are on this graph, but just remember that if you've got under the age of 9, testicular enlargement or virilization, so development of the penis, then please do refer so we can investigate. The other really important distinction I want to make is about pubic or axillary hair. And the point is that is driven in many, many little children, not by puberty. So that's not by testosterone from the testes or estrogen from the ovaries. That's often because of adrenal androgens, things like androstenedione, and that's very, very often a benign variant that we would do nothing about. So a little bit of pubic or axillary hair in a child who's a girl under 8 or a boy under 9 is not normally a sign for concern. What we do understand is that there may be underlying causes that we need to think about. And so if there is, again, a real acceleration in height velocity, a very advanced bone age, or a lot of virilization, then that's a different picture and we should be concerned. But those are the two things to distinguish. Adrenarche, of course, is associated with all those other lovely, moody teenage type things. And in the little children that get premature adrenarche, sometimes the parents do say they're a bit more grumpy, they're a bit more emotional. Sometimes they do get body odor, but they shouldn't be having significant acne. So as I've said, if a boy is virilizing, of course, if a girl is virilizing, it's always a sign of concern. But if a boy under 9 has got a significant increased size of his penis, or if their height velocity is accelerating, again, if they're crossing centiles on the growth chart, bone age more than 1.5 to 2 years advanced, or if they have baseline biochemistry, if you've done that, that's concerning. So one of the most important underlying diagnoses is congenital adrenal hyperplasia, and your most useful baseline test for that is 17-hydroxyprogesterone. But we're happy to discuss that on a case-by-case basis. And as I said, the vast majority of patients will have premature adrenarche, which is benign and just needs monitoring and it wouldn't be treated. It can be associated with intrauterine growth retardation. But occasionally we will pick up patients that have particularly non-classical congenital adrenal hyperplasia, so not with salt wasting, but that present later, and we may need to do some testing there. And on this side, it's very, very rare. And again, if you've got concerns, please do speak to us or refer. In summary, puberty is a combination of sex steroids from the gonads, driven by the hypothalamus and pituitary, with these adrenal androgens that, especially in younger children, are what give you primarily the pubic hair and the axillary hair, but also growth spurt that Pratik talked about in the previous talk. So it's really a combination of these 3 hormonal systems. Just to summarize, the reason to refer a girl under 8, if they've got some breast development, if it's progressive, especially rapidly progressive, if they're crossing height centiles, significantly advanced bone age, or the other features I've said, then that would be a worry. And in a girl under 8 who's got a little bit of pubic or axillary hair, absolutely, if they're virilizing, that's a big red flag. Or if they've got raised testosterone of 17-OHP, or again, crossing centiles or advanced bone age. And in a boy under 9, just refer if they've got enlarged testes volumes, or if they've got virilization with increasing size of the penis, with pubic or axillary hair. And again, same again, height velocity is running away, or of really advanced bone age. Okay, so hopefully I've explained that there's a real variety in the healthy population, and our job is to try and untangle what's just healthy variation from what's pathological. We do a lot of monitoring. We don't necessarily jump on everyone that's referred with investigations or treatment. And often time really does tell us what's going to happen, but there are certain red flags that we would definitely want to pick up. Virilization, very advanced bone age, very significant height velocity increase, or PV bleeding in a girl that is not appropriate for her pubertal stage. I'm happy to take any questions.
Thank you so much, Sasha. That was brilliant. And as someone who's seen quite a few query precocious puberties in rapid access recently, it was very informative. We've got a few questions. The first one is about boys with earlier puberty that's not actually precocious, and whether or not to try and increase their final height, there is a role of medications like testosterone in that group of people.
Yeah, so I think that's a really important point, because obviously in a perfect world, we'd meet all these children, boys, before they were 9, but sometimes you do, and it's the same true for girls. Sometimes you'll get a girl who the first time anyone's seen her is over 8, but actually she's quite a long way through puberty. And we do, so for girls, sometimes we don't meet girls till they've had their first menstrual period, and that definition is age 10. So sometimes we still call them central precocious puberty and consider treatment. In boys, you'd have to do it on a case-by-case basis. So if you met, for example, a 10-year-old that was really quite advanced through puberty, you'd have to think about whether there'd be any benefit. And again, it's about that sort of bone age of 12, 12 and a half. Once you've reached that, you're not really going to do anything for their final height by blocking. And blocking is quite a significant thing to do. You know, it's a real hammer to crack a nut in that case. And, you know, I think we should be cautious that unfortunately sometimes we've missed the boat and there's not a lot we can do, but parents are often very enthusiastic to have growth hormone or aromatase inhibitors, and we often end up just trying to calm everybody down and saying this is what it is. But yeah, worth referring if you're concerned.
I'm gonna let you answer the rest of the questions.
Yeah, sure.
I think if that's okay, and we're gonna move on to the next presenter, who is George, who is a consultant pediatrician at the Royal London Hospital and has an interest in rheumatology and dermatology, and is going to be giving us 3 talks today: MSK, rheumatology, and dermatological manifestations. Thank you, George.
So thanks, Anna. I'm Yorgos Eleftheriou. I'm a pediatric consultant at the Royal London, as Anna said, and I'm going to be doing 3 talks. Just bear in mind, I'm giving you a lot of resources and I'm brushing over some topics that could probably have talks on their own. So do take time to look at the presentations and look at the resources I give you. So the first talk is on common MSK presentations in Paeds. I want to really focus on your history and examination and maybe some of the more common diagnoses you can encounter, and also trying to distinguish between non-inflammatory pain and inflammatory pain, and then talk a little bit about referral pathways and further resources that you can have. So in clinic, when you see someone with a limp or joint pain, the main things that you want to do is to rule out something that needs urgent treatment or that's really bad. And the main things for me is ruling out an infection, ruling out malignancy. So particularly ALL can present with joint pain, swelling, and even effusions, and it can be bilateral and lots of joints. And other things like non-accidental injury or other types of tumors. So ask about systemic red flag symptoms and systemic symptoms. Ask about duration of symptoms, whether there's any morning stiffness, and particularly the effects of activity on pain can help distinguish between inflammatory and non-inflammatory pain. And this is something that's not done very well. So a baseline of their activity and their functioning, because I use the barometer of whether they're going to school or not, and whether their school attendance is impacted by their symptoms, as to whether I need to get really involved, even if it's non-inflammatory or not. And it's important to look at what support's available for the family. And with your examination, the thing to look at is you can do it 2 ways. The thing that I tend to do is I do a PGALS exam, so a pediatric gait, arms, legs, and spine exam. And I've given you at the end of the talk a slideshow on how to do that and what that means. I always tend to do a Baton score while I'm doing a PGALS, and that's the hypermobility score for people who don't know how to do it. But I think it's an easy thing to do, and it can be useful. And if you're focused on a specific joint, like my knee hurts, I would always, as a minimum, do the joint above and below. So do the looking, the feeling, the moving, actively and passively. Measuring, you might want to measure true and apparent leg length, and also something about function, how they're functionally impaired. Don't forget to look more systemically at the skin, the eyes, the lymph nodes, and a brief systems review. And don't forget referred pain. So we had a case of a child who had a history of JIA who presented with hip or groin pain. And he was being investigated for hip arthritis, and actually at the end he had testicular torsion. So don't always limit yourself to the joints. Think about other things that may be going on. And remember, children's histories aren't particularly good. So you do have to go through that process. So non-inflammatory pain, this is by far the most common type of pain you're going to see in children. It's something like at least half of adolescents at some point. I mean, we've all had non-inflammatory joint pain, but enough to come to a clinic appointment. The vast majority of the people I see in clinic have non-inflammatory joint pain, which is worse at the end of the day and after activity. Sometimes they get something called delayed onset muscle soreness. So this is an example of this is, say you go to the gym when you don't go to the gym normally and you do lots of heavy weights. The next day, your arm's not going to be able to be moving properly and it's going to be really stiff. So stiffness in itself doesn't mean that you have inflammatory or non-inflammatory pain. It's more the pattern and the repetition of the symptoms. And the reason people get non-inflammatory joint pain is because of the sedentary lifestyle, and they've got poor fitness, deconditioning of the muscles, and they may have hypermobility as well. The examination tends to be grossly normal. There may be some hypermobility and there's no systemic red flags, and they often complain of fatigue, and the response to the over-the-counter pain relief is poor. So moving towards inflammatory pain, that tends to be worse in the morning and improving with activity. Morning stiffness is predominant. It's important to ask young people what they mean by stiffness, because a lot of people say I'm stiff, but you need to ask them, okay, so when you wake up, it's hard to move the joint. I'm not talking necessarily pain, but is the joint stuck in a certain position and it takes time to move. And actually in studies and in validated tools, the degree of morning stiffness, the time of morning stiffness correlates quite well with disease activity. So it's important to quantify that. There's joint restriction, pain or swelling. And the diagnostic criteria for rheumatological diseases talks about having 6 weeks at least of symptoms. But usually if you're talking of these kind of symptoms for over 3 weeks, you do need to start thinking about whether it's inflammatory, and you may need to do some further tests. Ask about skin. So particularly if there's photosensitivity or recurrent vasculitis type presentations, the classic one would be someone with joint and skin symptoms who's got eczema or psoriasis that's not really responding as you would normally expect. Proximal muscle weakness is difficult to fake that, so that's something that you need to investigate. And do think of family history, not just of arthritis conditions, but other autoimmune diseases, particularly inflammatory bowel disease, psoriasis. So this is a table that you can look at in your own time about limping in children, because there's some age groups where certain types of pathologies are more common. The ones that sort of span the whole age groups are things like inflammatory joint pain, like JIA, osteomyelitis and septic arthritis, trauma, and for more age-specific diagnosis, think about things like Perthes disease in someone with a recurrent atraumatic limp who's around 4 or 5 years old. And for older adolescents who have a raised body mass index, think of something like a slipped upper femoral epiphysis if they've got an acute limp. So do be aware that certain diagnoses are more common in certain age groups. So how do you investigate first line for a limp or recurrent joint pain? Most of these won't need any blood tests. So reassurance and sort of advice about activity and the type of things to do, particularly things like cycling, swimming. These are quite difficult things to do, especially in England where there's no sun. But, generally increasing activity levels will help. But to rule out the bad diagnoses we talked about earlier, you need to do a full blood count, a blood film, and an ESR. Use knees, LFTs, a bone profile, and vitamin D. This is important, but I think unless you've got metabolic and biochemical evidence of rickets and radiological evidence of rickets, it's unlikely to cause significant symptoms that are impairing the child's life. But you would supplement that anyway if it was low. CRP is important if there's sort of muscle weakness or muscle pain, a CK and an LDH. A ferritin's good if there is a fever with multiple arthralgia or myalgia, because in rheumatological diseases, there's a complication called macrophage activation syndrome, which is a very severe complication of those, and it's associated with a really high ferritin. You could do an X-ray of the affected joints. Occasionally, there's trauma there. You might find a benign bone tumor, especially if it's localized to one place. You should probably do that. And, we're going to talk about this a little bit further, but I wouldn't do, unless you're very convinced there's inflammatory pathology, an anti-nuclear antibody or rheumatology screen. And we can talk about the reasons why, but it's got a poor diagnostic yield. So get a specialist opinion, seek specialist advice before you do that. Now, very quickly about transient synovitis v septic arthritis. There are certain sort of clinical features that differentiate one with the other. And there's been a study done by Kocher et al., which is quite a famous study, looking at the risk of the probability of having septic arthritis versus reactive arthritis with a hip effusion. And the things that they looked at in that study was you're more likely to have septic arthritis if you have a fever, you're not putting any weight on that joint, the child looks unwell, and also you have an ESR more than 40 and a CRP more than 20 and a white cell count more than 12. However, it can be difficult, especially in the initial stages, to differentiate between both. And remember, transient synovitis is a diagnosis of exclusion. So if you're worried and someone's limping with a fever, you do need to seek specialist advice and at least do a blood test and observe them for a little bit. Juvenile idiopathic arthritis, again, I'm just going to skip through this, but the most common subtype is oligoarticular, which is less than 5 joints at onset. And for oligoarticular JIA, a anti-nuclear antibody predicts the risk of anterior uveitis. The most common joints that we see tend to be the knee and the ankle, but particularly the knee. The next most common subtype is polyarticular, and that can be rheumatoid factor positive or negative, but rheumatoid factor positive is really, really rare. The other ones that you might see in outpatient type setting is the enthesitis-related arthritis, where there's often a family history of ankylosing spondylitis in a male relative. They present with back pain and they're HLA-B27 positive. And just remember, do consider inflammatory joint pain in someone who's been diagnosed with osteomyelitis and septic arthritis, and they're not responding as you would normally expect with washouts and non-steroidal anti-inflammatory drugs. If it's persistent, just think about whether the diagnosis is different. So I think I've got a poll now, just very quickly about the treatment for JIA. So which one of these statements is false? Either ibuprofen is the first-line treatment, the most used DMARD is methotrexate, and the DMARDs usually take 6 weeks to have a full clinical effect, and adalimumab acts against TNF alpha. So which one of them is false? The one that's not true is that a DMARD normally takes 6 weeks to have a full clinical effect. So non-steroidals are the first-line treatment for JIA. They're evidence-based and they reduced inflammation. So naproxen or ibuprofen are first line. And remember, there are JIA doses, and you need to give them with stomach protection. The most used DMARD in children is methotrexate. The best bioavailability is subcutaneously. And DMARDs usually take 3 to 6 months to work, but you're looking more like 6 months for them to have a full clinical effect. And adalimumab acts against TNF alpha. So moving on to more common presentations you see. So growing pains are nothing to do with growing, but they are common in growing children. So they happen in children aged 3 to 12 years. So one of the things you can tell parents is that it will get better. It can cause a lot of anxiety and suffering in the children. It tends to happen at the end of the day. It always starts at the end of the day or at night. And sometimes they report that my child wakes up at night crying, but the pain has always started before then. And the next day they don't have any limp. They don't have any systemic symptoms. The examination is normal. And the pain tends to be non-specific, sort of at the lower limbs, both sides and at the back. So if you give the parents the rules of growing pain, then you give them some reassurance that you can do some gentle massage, you can use hot water bottles, have a bath before bedtime, and make sure they wear supportive shoes such as trainers during the day. That should be okay. And you don't necessarily have to do any investigations for it. So this is my second poll. Hopefully it will work. But we're moving on to hypermobility now, which is another common problem. So just what do you think is a significant Baton score in a child? So one of these is true. So a Baton score has no role in children. 7 out of 9 is significant in a 4-year-old. 5 out of 9 is significant in an 8-year-old. And 6 out of 9 is significant in a 13-year-old. Okay, so quite a mix. Yeah. So a Baton score is the hypermobility score, and the way you do it is shown in this diagram. You have to take time to do it properly. Okay, so the finger one, the little finger one, means you have to put their hand flat on a table to do it. Okay, and the elbow, it doesn't mean a little bit of hyperextension. It means more than 10 degrees. And for the bending forward one, they have to have their hands flat on the ground with the knees straight. So you have to make sure you do it properly. A Baton score is often high under the age of 5, and that's just the way your joints normally develop. So hypermobility in a young child unless it's very, very extreme, is irrelevant really, because that's how your body develops. In a younger child, we say a score of 6 or more is significant. And in an adolescent, 5 or more is significant. But different people with different Baton scores have different effects on their life. The main thing when you're looking in hypermobility is you need to exclude a connective tissue disorder. So you're going to look at the hyperelasticity of the skin. You're going to look for chest wall deformities, cardiac involvement, all of those things, high arch palate, all of those things that lead you more to a genetic diagnosis. You need to ask about functional impairment and their baseline, because often hypermobility is associated with non-inflammatory joint pain, and it can affect and cause fatigue. It can also be associated with easy bruising, but that's benign and not associated with any clotting problems. Clickiness, again, is benign and it's not dangerous, and you just need to reassure people. And they often have poor coordination and proprioception. So it's often worth, in that case, to strengthen the muscles as well and improve proprioception to refer them to physio. And the key thing about hypermobility is having strong supportive muscles. That's the key with hypermobility. So adjusting your activity, adjusting your, if you're getting symptomatic, pacing that and balancing that with activity, and also reassurance that there's no disease here. It's just the way your body's made. And just touching on that, there's the Ehlers-Danlos Society 2023 diagnostic criteria. So we've moved away from diagnosing prepubescent children with hypermobile Ehlers-Danlos syndrome. You cannot diagnose prepubescent children with Ehlers-Danlos syndrome. You can look at the website and also this diagram in your own time, but basically the way it's moved now is a diagnosis of pediatric generalized joint hypermobility with or without other organ involvement like skin involvement or other core comorbidities, and then you give them a diagnosis like that. And the emphasis has to be on what you can do to help them. So keep them strong, physio and activity, pacing activities, understanding how their posture can affect their joints, talking about wearing supportive footwear, and also managing pain. And sometimes, unfortunately, hypermobility gets a more prominent role than it needs to in these chronic pain type presentations and fatigue. But if you do the right approach with a consistent message and you involve physio, normally these children do well. Just very quickly, bow legs, they're common and it's normal until the age of 3. You need to rule out vitamin D deficiency and treat rickets. The main thing is referring, if necessary, to orthopedics if it's very pronounced, so that's more than 6 centimeters intercondylar distance, if they have any functional impairment or is asymmetrical or persistent. In or out toeing is another common one that people very strangely get very wound up about, in terms of parents get really worried about it. In toeing is normal and normally resolves between 8 and 10 years of age, and it normally has to do with the mechanics of your hip. So if you W sit, which is what this baby's doing, your hip, the mechanics of your hip moving, your hip tends to internally rotate naturally when you walk, and that causes in toeing, and it's not dangerous. And again, out toeing, most young people out toe when they're younger, and again, that resolves by the age of 4. So again, take the time to look at a neurological exam. If there's any rigidity to the foot, any evidence of joint swelling, if it's asymmetrical or extreme, refer to your specialist colleagues and to physiotherapy. Tiptoe walking, again, really common, very common in autistic spectrum disorder. So the key question here is, can they walk with their heels down? And normally it doesn't persist beyond the age of 3, except in autistic children. And usually if they can walk with their heels down, it means everything's okay. So do a neurological exam, see if it's persistent, and again, refer those who are sort of out of the limits of normal and reassure. Again, flat feet normally resolve by 6 years. The way you can check if someone's flat-footed is by lifting up their little toe or getting them to go on tiptoe. And again, if it's asymmetrical, associated with neurological signs or functional impairment, what I do if they got a little bit of foot pain is I refer them to orthotics to look at their footwear and maybe give them some arch supports in their shoes. But normally I don't have to do anything more than that, and I just reassure. Clicky joints is because when you click the joints, there's some air bubbles between the joints and then it pops, and that's why you get clickiness. It's more common in hypermobility, but it is not dangerous and has no long-term issues as long as the rest of the exam is normal. So don't refer for that. Tendon apophysitis is a set of conditions where there's inflammation, where the tendon inserts into the bone in growing bones. And the most common of these is just in the tibial tuberosity under the knee, which is called Osgood-Schlatter's disease. It's normally worse with activity, and it's associated with tight muscles and tendon units. So do an X-ray to rule out trauma. And again, it's non-steroidals, altering activity, modifying activity, and referring to physio. Back pain, I mean, I would say back pain in an under 5-year-old is unusual and something to take seriously. Most people have biomechanical or non-inflammatory back pain to do with their postures and stuff. So assess for scoliosis, see if they have stiffness, have a low threat, advise them on postures and exercises, and, assess for neurological signs, and consider a physio and ortho referral, but do an X-ray, whole spine and lateral views, because sometimes you can pick up some subtle problems there that can be treated. And just in terms of referral pathways to finish, if you have someone with joint pain, don't do a rheumatological screen, do your basic assessment, do a history and examination, and always follow a limp up because it's a symptom and not a diagnosis. For non-inflammatory joint pain, that's not really affecting their quality of life and functioning. You can probably manage that as an outpatient or discharge and get physio involved and give some simple advice. If you suspect inflammatory joint pain or there's a significant impact on the child's life, you probably need to keep seeing that patient and looking after them and involve physio. And just the last thing, the resources are really good. I mean, the one that's really, really good is the Pediatric Musculoskeletal Matters. This is a really good free resource for parents and also for clinicians about these common MSK problems. And I think that's it. Any questions?
Thank you so much, George. One question about the tiptoe not actually being able to walk or stand on their heels, which I think you spoke about being a bit of a red flag.
Yeah.
So yeah. But apart from that, no, my only question was going to be about the test for the rheumatological test, which you're coming on to now. So
Yes, my favorite topic. Okay, let me share again. Okay, so my next talk is about diagnostic tests in rheumatology, but generally, the reason this talk has come about for me is because I get a lot of referrals using anti-nuclear antibody positivity and other things like a positive ESR as a screening tool for rheumatological diseases. And I thought I would look into this, and actually it's triggered me to do this QI project with some of my colleagues who I think are on the talk, looking at ANA testing in children. So I thought it'd be quite useful. And there's an animation thing, which is very weird. Okay, so we're going to go into the use of any test as a screening tool and how you can practically use tests as a clinician without, and giving a little bit of thought about whether a test is useful for you or not with what you're trying to do. And I'm specifically going to look at ESR anti-nuclear antibodies and double-stranded DNA antibodies. So take a minute to look at this before I do the poll. So this is a sort of fake table of a screening tool for COVID. Okay, so it's split into columns where people have COVID and don't have COVID. So they definitely have COVID or definitely don't have COVID. And then whether they test positive or negative for this test. Okay, so take a minute to look at it. And the question that I've got is, I'll give you a little bit of time for it before we put the poll in. Which of these is correct? The sensitivity of this test is 93%. The specificity is 95%. The positive predictive value is 93%. And the negative predictive value is 93%. You can put the poll up. Okay, give people like maybe 10, 20 seconds to do it. Okay, let's see what people have done. Yeah. Now, interestingly, the correct result, the correct thing is the positive predictive value is 93%. So let's talk about that. Okay. So this classic thing that you learn once in medical school about statistics. And the way I look at it is this: sensitivity and specificity. The way you work it out is you look at columns. Okay. So you look at the columns of the disease present and the disease not present. So sensitivity means the number of true positives in those who have the disease. Okay. Specificity is the number of true negatives in those who don't have the disease. So specificity and sensitivity are to do with columns. And for the positive and negative predictive values, you look at the rows. Okay. So the positive predictive value is everyone who's tested positive with a positive test who has the disease. And a negative predictive value is someone who's who's testing negative and doesn't have the disease. And this is important. So looking at our example, these are the calculations. So this is important, because you can think about how these things translate into your day-to-day practice and what tests that we do actually have diagnostic value and can be used for screening. So the way you do it in practice, for example, in rheumatology, we deal with rare diseases. And in rare diseases, like in rheumatological diseases, you're going to have a lot of false positives because you're going to test a lot of well children who are going to test positive for this test who aren't going to have the disease. So what they do in practice is to increase the positive predictive value of the test. They change the population that you're screening. So for example, in mammography, they do it in women over 40. The prostate specific antigen test is done on men above a certain age, and then you can increase the positive predictive value for a test. And I would argue in your practice, using things like an anti-nuclear antibody as a screening tool, the way that you increase the positive predictive value of that test is by seeking a specialist opinion and asking the rheumatologist who's used to seeing these patients to do those tests rather than you. But we'll move on to ESR now. So ESR is an erythrocyte sedimentation rate. So it's a blood test, and you use an anticoagulated tube, so an EDTA tube, and then it's put in a specialist tube, and then it's allowed to sit for an hour. And then you form these two sediments where the plasma and the red cells separate. And the ESR is calculated in the millimeters between the top of the plasma sediment and the top of the red cell sediment. So how far these red cells have fallen in an hour. And that's why you get it in millimeters per hour. And the way it's important is because red blood cells normally have a negative charge and they repel each other, and they don't really fall very quickly. Whereas when you have inflammatory states, you form acute phase proteins that have a positive charge. And so acute phase proteins means things like fibrinogen and immunoglobulin. It doesn't mean something like CRP. So CRP doesn't increase your ESR itself, but the process can increase the ESR. So when these acute phase proteins bind to red cells, it causes these stacks to form, or aggregates, called rouleau formations. And that increases your ESR because your red cell mass is increased and it falls quicker. So that's why your ESR is higher in inflammatory states. Now, what things increase and decrease ESR? So elevated acute phase proteins like fibrinogen in infection, inflammation, and malignancy. High immunoglobulins increase ESR. So that's why it's important when you give an IVIG, for example, in Kawasaki's disease, ESR isn't a useful marker of inflammation in those disease anymore. If you have bigger red cells, they'll fall quicker. And also you've got technical things, which is why it's important when you do an ESR that you probably do a venous sample, you make sure it's mixed, and you send it to the lab straight away because you're more likely to get a true value. Anemia, like iron deficiency, increasing age, and female sex can also increase your ESR. So there's different things that can influence it. And in terms of disease processes that increase ESR, the most common ones are infection and malignancy, renal disease like glomerulonephritis, In rheumatological diseases, the most common ones are polyarticular and systemic JIA, vasculitis, and SLE. And don't forget other diseases like inflammatory bowel disease and celiac disease. These kind of go under the radar as a cause for a raised ESR. Now, comparing ESR and CRP and the assays. So remember, ESR is a surrogate marker of inflammation, whereas the CRP measures the direct level of the protein. And the CRP will rise quicker than ESR, so it will rise within 4 to 6 hours of the onset of inflammation and probably double within 36 hours of the inflammatory process starting. Whereas ESR tends to rise slower, so within 48 hours after the onset of the inflammation. And coupled with that, ESR takes longer to resolve. So it may take weeks to get better, whereas CRP falls quicker within 48 hours of treatment. So that's why CRP is probably more useful for acute processes like response to infection, meningitis, healing after surgery, whereas ESR might be more useful for chronic diseases and monitoring those. In terms of SLE flares, now in systemic lupus erythematosus, in an SLE flare, the ESR will go up, but the CRP won't. But it will go up in SLE if you have an infection. So that's why ESR is quite useful for assessing for SLE flares. And there are other uses for ESR and CRP, which I'll go into. So now I'm going to look at some evidence about the use of ESR in children. So remember we talked yesterday, my last talk about in children with a hyperfusion and a fever, an ESR more than 40 is one of the diagnostic criteria and Cocker's criteria that can be used to distinguish septic from reactive arthritis. So that's quite a good test in someone with fever and a limp. They did a study in young children under the age of 10 on average with an ESR of more than 100, and they found that half of these had a infection and only 1 in 4 of them had a connective tissue disorder. So a high ESR doesn't necessarily mean you have a rheumatological disease. It's more likely it's going to be an infection or something else. And also there's a lot of evidence to show that in someone with abdominal symptoms where you've not identified any other reason for a raised ESR, do consider screening for celiac disease and inflammatory bowel disease. In rheumatological disease, like I've said, it can be used to monitor a flare in SLE. It's part of diagnostic criteria for rheumatic fever and correlates quite nicely with disease activity. You can't use ESR in Kawasaki's disease after you've given IVIG, so you need to use CRP. And in juvenile idiopathic arthritis, systemic onset and polyarticular JIA are associated with high ESRs. And quite often I see oligoarticular JIAs have normal ESR, so it's not so useless with those. Like I've said here, it doesn't often go up also in uveitis. Now, what do you do for the well child with a raised ESR? So the normal values we see in pediatrics are 10 to 20. So in adolescence, as you get older, your ESR gets higher. So 20 is probably the cutoff for most assays. Studies have shown that BMI linearly increases your ESR and actually can be significantly higher in obese patients. So do consider obesity. You're talking about 30 millimeters or higher ESR level in obese versus non-obese peers. Certain ethnic groups like African descent can be higher ESR as a baseline, and it also goes up with females and with age. And there's certain drugs that can influence ESR, particularly steroids can make it go down and non-steroidals, and the oral contraceptive pill can increase it. So do look at the whole picture, not just ruling out a disease before interpreting an ESR. In adults, there is some evidence that ESR can be used to prognosticate in certain diseases. However, in Paeds, there are no positive or negative predictive values for ESR thresholds. So there's more research needed in its use. So my clinical bottom lines for ESR. So if you've got a well child with an ESR that's moderately elevated, look more for, you need to examine them to rule out disease or infection. And do consider that other things such as race and BMI can be contributing to it. And you can probably discharge them. In those children with an ESR 30 to 100, that's a bit more gray, and you probably do need to more actively look and screen for other diseases. So you probably need to do an infection screen, have a low threshold to rule out things like celiac disease and other autoimmune diseases. And you might need to keep them under follow-up. For an ESR more than 100, you should suspect underlying inflammation or infection. and a normal ESR doesn't rule out inflammatory diseases. And in certain diseases, ESR may correlate with disease activity, but in other diseases, such as Kawasaki disease, CRP is more useful. Okay, anti-nuclear antibodies. So anti-nuclear antibodies, they're antibodies to cellular components in the nucleus and the organelles as well in the cell membrane. And they also include a group of antigens called extractable nuclear antigens. The gold standard way of testing for the presence of anti-nuclear antigen is to do an indirect immunofluorescence assay where you dilute the serum and you label the antigens with a fluorescent dye, and then someone manually looks at these different dilutions to see if the fluorescence is still there. And that's where you get the titer. And then the cutoffs used in the labs are like the 95% centile for this. And you can get different patterns. You can get homogeneous, speckled, peripheral, or nucleolar, and they correspond to different types of antigen in the cell, and these can be linked to certain diseases. Okay, but the one I'm going to concentrate on is when you get an anti-nuclear antibody, that you get a titer of 1 in 160 or 1 in 320. So how do anti-nuclear antibodies develop? So in rheumatological diseases, you get so genetic and environmental factors cause autoreactive B cells with T cell help to proliferate. And there's failure of immune tolerance, and then you get autoantibodies and immune complex formation. However, in anything that causes polyclonal B cell activation, such as infections, inflammation, and environmental exposures, you can also get the same process happening. So particularly processes like viral infections, such as COVID or EBV, drugs, malignancy, infectious and autoimmune hepatitis, and particularly celiac disease and autoimmune thyroid disease can have quite high rates of positive ANAs. Okay, so don't just think it's juvenile idiopathic arthritis that's doing this. So I've got a quick poll. Which is true for ANA in rheumatological diseases? So the disease where most patients are ANA positive is systemic sclerosis. ANA has a positive predictive value of 50% in rheumatological disease. Only around 50% of children with JIA are ANA positive, and ANA positivity persists for life. Give you a couple of seconds to do that. Okay, so look at the results. Yeah, so yes, that's right. I mean, we'll talk about that. So the titers that's often used. So remember, the higher the you get the antibody result in 1 in 160, 1 in 80, 1 in 320. So the higher the bottom number, the more dilutions the serum has had to go down to, and you still see the presence of anti-nuclear antibodies. So the more significant the result is. The data comes from the cutoffs come from an adult study where they found the 95th percentile in the population was 1 in 160. So that's where you get that result from. There is no consensus among experts for significant screening dilution in under 16-year-olds, and ANA has a very poor sensitivity and specificity and positive predictive value for rheumatological disease, and up to 30% of healthy children are ANA positive. And particularly, we saw lots of high ANA positivity rates in COVID. And this is important for you to consider because ANA testing costs in Bart's Health, it costs £14.50. And what we looked at in the Royal London is we looked at data over the last 5 years, and we found that about 7,500 ANA tests were sent in under 16-year-olds by general practitioners, pediatricians, other hospital clinicians, and that corresponded to a cost of 100,000. And what we're looking at in those numbers is what corresponds to rheumatological disease and autoimmune disease or not. So the disease where it's very unlikely you have it if you are ANA positive is SLE. For the rest, it's got poor sensitivity and specificity. And actually, the positive predictive value of ANA is only 11% in rheumatological disease. Now, I'm going to go through a few studies of anti-nuclear antibody and what they mean. I'm just going to breeze through this. And if anyone wants the references, just get in touch with me. But studies have continuously shown these type of data. So there was one study that looked at pediatric patients coming to rheumatology clinic. around 50% of those who were ANA positive did not have rheumatological disease. Another rheumatology clinic where 110 patients were referred with ANA positivity, more than 3/4 did not have rheumatological diseases, and a significant amount of them had an identifiable infection. Studies have shown also that a high titer ANA does not discriminate between rheumatological diseases or not at presentation. So you can't use titer alone to make your decision. There was this study done in Turkey in over 3,000 patients, and they found that this is a pediatric center where they tested ANA, and they found that only a third of those who were ANA positive had autoimmune disease, and the commonest one was JIA. And the sensitivity, specificity, and positive predictive value for this test increased when it was sent by a rheumatologist. So this is what I'm talking about making sure the right person sends the test. Now, the other interesting thing for this one is half of those with autoimmune disease who were ANA positive had high ANA levels, and most people with JIA didn't have a positive ANA. So again, it's sort of part of the picture, but it's not what you should use. Other studies have shown that a significant proportion of non-inflammatory joint symptoms present with a positive ANA, and sometimes this can persist. So 22% of these people had persistent ANA, and none of them developed rheumatological disease at 5-year follow-up. And the other thing to know is that more than half of 18-year-olds had MSK pain, and 30% of children have chronic pain in the last 6 months. So these are common presentations in children. So you shouldn't just use the presence of joint pain and fatigue as an excuse to do an ANA. So what's the bottom line for ANA testing? Don't order it unless there is a strong suspicion or clinical signs of an autoimmune disease. If you are not sure, don't do the test, but refer it to someone with an expertise. If you don't have any autoimmune disease on physical exam, but the ANA is positive, for some reason you've done it, think of non-inflammatory symptoms, reassure. You don't need to retest the ANA. However, what I've said is that if it's a titers more than 1 in 640, that's a little bit more unusual, and probably as a MSK rheumatology physician, I'd probably want to see them. So I'd probably ask to see them. And remember, a negative ANA doesn't rule out a rheumatology disease. And for oligoarticular JA, ANA positivity is important because it looks at your risk of uveitis. And very quickly, double-stranded DNA antibody. So this is a test that, again, is commonly done. They normally, in our lab, they don't do it unless you request it, and also unless your ANA is positive. It's antibodies against the double-stranded DNA or the antihistone. And the assay that's done at the Royal London is called an ELISA, and for it to be significant in children, it needs to be more than double the reference range given in the lab. So that's what a positive double-stranded DNA antibody is. And again, it's quite specific and sensitive for SLE, but it's got a poor predictive value. And you need to use the specific diagnostic criteria for SLE to diagnose SLE. You cannot just base it on double-stranded DNA. And I would ask you why you are doing it. If you're that worried about SLE, you need to refer. It is useful in monitoring SLE activity and also in SLE flaring, but I would, as a rule, not be doing it routinely. So, my take home from this talk is before you order a test, think, is it going to be useful for me? Is it going to change what I do, or do I need to seek a specialist opinion? Autoantibody tests are really common in children and usually due to infections, and don't do them unless there are convincing signs and symptoms of autoimmune disease. And ESR and ANA have poor sensitivity and specificity for these diseases, and it can be quite a nice QI project where you can save a lot of money. That's it.
Thanks, George. We've got a few questions before we move on to a whistle-stop tour through the dermatology. So there's a question about the difference between reactive arthritis and transient synovitis. So I don't know if you wanted to pick that one up quickly, and then.
Yeah, so reactive arthritis tends to be, it's something post-infectious, really. And there's different it used to be called things like Reiter syndrome and stuff, but it's usually something that happens post-infectious, usually caused by a GI infection or strep. That's what I mean by reactive arthritis, but I can answer that a bit more in the chat. Transient synovitis is a sort of viral urti with a limp that goes away within 2 weeks and sometimes associated with an effusion. So they're slightly different.
Yeah. The other question is, which I'll actually just let you answer later, about when to repeat certain tests, and which, if any, I assume you'll say no, antibody blood test is specific and sensitive for arthritis in children. None. Yeah. But I will let you answer those.
Don't do it. Don't do it. I'll answer this. I'll go to the next one.
Yeah.
Yeah. All right. Okay, whistle stop tour. I'll try. Okay, so this is more case-based and it's related to the rheumatology. Okay, so these are real patients. So this is an 11-year-old girl referred to the pediatric rapid access clinic who'd had this itchy rash over her face with some swelling of the face and around the eyes, with fatigue for the last 4 weeks. She'd had 2 courses of antibiotics and topical steroids, nothing really improved. Her blood tests showed a hemoglobin, which was slightly low, a slightly low white cell count, a slightly raised ALT, and normal ESR and CRP. So have a look at what that rash looks like. This is a bit more detail of that rash. So you can see that it's predominantly on the cheeks. There's also some rash over her lower part of her neck and this sort of white bit, and periorbital edema. Okay. So what do people think the most likely diagnosis is? I mean, it's a bit unfair, but what do you think? Juvenile dermatomyositis, SLE, Sjogren syndrome, or systemic sclerosis? You can put the poll up. Okay, let's have a look at the results. Yeah, okay, interesting. Yes, okay, let's keep going with this one. So she struggled to get up from the chair and had thigh pain and joint pain. She had proximal muscle weakness. I think you know where this is going. Her muscle enzymes were very high, so the CK, the LDH, and the AST. And she had this beautiful MRI of her thighs, the T2 weighted image, which shows inflammation of her thigh muscles and a bit of subcutaneous edema. Okay. So she has juvenile dermatomyositis. Okay. Now, it's one of the first groups of muscles to go with juvenile dermatomyositis are your neck flexors in terms of your proximal muscles. And I've never seen anyone with JDM be able to lift their chin up from a lying position and lift their neck up and flex their neck because they're always so weak. Okay, so that's a really good kind of screening tool for JDM. Anyway, the diagnostic criteria are you need to have the typical rashes, which we'll talk about. You need to have muscle weakness, positive muscle enzymes. So remember CK, LDH, and transaminases. We don't tend to do muscle biopsy anymore, but if you do, you'll see sort of muscle fiber necrosis, perivascular cell infiltrate. EMG may be positive, but it's sort of invasive and painful. So it's tend to be superseded by MRI. This is the heliotrope rash, which is this violaceous telangiectatic rash over the eyelids, over the nasal bridge, and over the cheeks. Okay, that you see in JDM. It can be quite subtle and it can be different shades in different people. So you need to look at it. And then you've got the Gottron's papules, which are the sort of plaque-like papules over the small joints of the hands, the elbows, and the knees. And again, they can look slightly differently, but once you've seen it, you get a good idea of what they look like. They can be quite subtle on the knees. I mean, you can see here, you may be able to miss that. And they can even appear a bit more petechial or telangiectatic. In darker skinned people, it's even more subtle. So it can be, the diagnosis is often delayed. And you can look at websites called Skin Deep, etc., to look at what they look like. But they often present just as hyperpigmentation. All right. Gotrons like papules and skin eruptions can also occur in other areas of the body, particularly on the nape of the neck and around the neck. That's called the shawl sign. And also in the front of your neck, that's called the V sign. And just remember, these areas are often exposed to the sun. So photosensitivity is important in rheumatological diseases. And you can see there's skin breakdown here where the skin has ulcerated. Again, more pictures of these rashes that you can see. And actually, skin disease may be the most prominent thing in juvenile dermatomyositis and rheumatological diseases. The other thing that's quite prominent in JDM is the malar erythema, and it spares the nasolabial folds, which is a good clue, and also periorally they're sparing. And the other thing that often happens in JDM is they get edema of the face, and often they're diagnosed as cellulitis or nephrotic syndrome. This is a really good test for any rheumatological disease like a connective tissue disease. Often the base of the nails is quite red and erythematous. And what this corresponds with is what's called a vasculopathy, so inflammation of the small capillaries and blood vessels. Normally, your nail fold capillaries are nice and linear and folded nicely. However, early on in connective tissue diseases, and it correlates with disease as well, you can get disruption of this, and you can get special equipment for it, a capillaroscopy, but you can also use lubricating gel and an ophthalmoscope to look at it. So I often do that. And sometimes you pick up connective tissue diseases early, especially in someone, for example, has interstitial lung disease and you don't know what's going on. And formally, you can do this at Bart's or the Royal Free or Great Ormond Street. Another pathognomonic sign in JDM is this ulcer in the inner canthus of the eye. Is really only seen in JDM, but you can get more severe presentations where you get ulceration, and this requires urgent treatment. And remember, with these connective tissue disorders or mixed type connective tissue diseases, you can get Raynaud's phenomenon. Calcinosis, so calcium deposition can be really, in cartilaginous areas are more common. You can get these white specks in hyperpigmented or red areas. They can affect function if they're affecting the joint, and they can be the most prominent aspect of the disease. And they respond quite well to anti-TNF biologics like infliximab. Sorry. And you've got a really beautiful X-ray appearance of the calcinosis there. So all these signs sort of get you more likely to have a connective tissue disorder. Look at the fingertips in rheumatological disease to look for things like vasculitis and ulceration is really important. And you can have overlap syndromes like scleroderma, systemic sclerosis with myositis, and the fingers can look very tight and the skin can look very tight. And like in adults, it doesn't increase your malignancy risk if you have JDM, but the most common multi-organ involvement is with your dysphagia and GI involvement, and also interstitial lung disease. So it's really important that they get that screened as well. And arthritis tends to affect, the small joints of your hands or your knees, and again, can be a prominent feature. What they're doing nowadays with JDM has become a lot more sophisticated because they're sending myositis-specific antibodies, and we can actually send these in the Royal London now. They tend to go to a lab in Bath, but what they do is if it's positive for a particular antibody, you can predict what associated clinical features and what prognosis that child's going to have. So you can really be aggressively screening for these diagnoses. For example, anti-MDMA5 antibody is more associated with interstitial lung disease, so you probably do lung screening a bit more often. Skin and muscle resolve differently. So this is a graph looking at the skin disease activity score, which is the solid line, and the muscle disease activity index. And you can see the muscle disease is well controlled quickly when you give medications, whereas the skin disease can often lag behind and be difficult to control. And your management approach really is the same as any rheumatological disease, is multidisciplinary, steroids and non-steroidals first line. There's quite a prominent role for methotrexate and IVIG, and newer treatments like biologics and things. And then topically for the skin, you're talking about emollients, sun protection, and calcineurin inhibitors. Now, I've put this slide up because there's a new class of drug in rheumatological disease called JAK inhibitors. So that's Janus kinase inhibitors. And what they do now in rheumatological diseases is they look for expression of interferon pathway related genes, and that's called an interferon signature. And if you test quite highly for that, then they will target the interferon pathway a bit more with JAK kinase inhibitors. And this young person had really problematic skin disease, and when he had baricitinib, he got better. All right. Then the next case is a 15-year-old girl. She had a facial rash for a month. Again, this was seen in rapid access clinic in Paeds. Her face started peeling. She had intermittent fevers and myalgia. She didn't complain of joint pain. She was started on an anti-acne medicine a couple of weeks before and antibiotics by the GP. And that's what her rash looked like when we saw her, which is quite interesting, isn't it? When we examined her, she had facial swelling with facial erythema. She had this petechial rash on her legs and a bit of swelling of her legs. And she had some swelling of the hands, so more like edema rather than arthritis. But the rest of her clinical exam was normal. And she said she had a normal, no mouth ulcers, but we saw a mouth ulcer when she was examined. And you can kind of see that there. In terms of her bloods, she had slightly anemic, low white cell count, low lymphocyte count, a very high ferritin, raised creatinine, raised liver function test, normal CRP, raised protein creatinine ratio, very raised ANA and double-stranded DNA and a low complement. And she also had some extractable nuclear antigen positive antibodies too, called anti-Smith and anti-RMP. So I think this one's a bit easier. You can put the poll up, Jeremy. What's the diagnosis? Polyarteritis nodosa, SLE, systemic sclerosis overlap, or Behçet's? Okay, let's have a look at that. The results of that. Yeah, so yeah, this is SLE. Now, the diagnostic criteria for SLE, now we're using the SLIC criteria, and there are clinical and immunological criteria. So normally you need a positive anti-nuclear antibody with at least one clinical and one immunological criterion. So do have a look at those because they're very clear. And these are the criteria. I mean, bear in mind there's a lot of skin stuff on this, and there's a lot of multi-organ involvement, and there's also lots of immunological criteria. And the main one, it's very unlikely that you'll have SLE if your ANA is negative. So just have that in the back of your head. Now, looking at cutaneous lupus manifestations, it can be lots, but we're going to go through them. But this is a list of what they can do. I mean, the commonest one that everyone knows about is the malar rash that can have different morphologies. It can even be scarring. It can be erythematous, more maculopapular. It can be hyperpigmented like we saw in that girl. But remember, sparing of the nasolabial fold and periorally is a good sign. Discoid lupus is these coin-shaped lesions that are often raised. They can be painful and they can be scarring, and they can increase the risk of skin cancer. So they do need to be referred to a dermatologist. And you can see this one is in the malar distribution. Chilblains. Okay, so chilblains, or the big thing was COVID toes. So it's basically these little lumps or macules or papules that occur usually in response to cold in the toes and the fingers. And they can happen recurrently. There is a subset of those. So when you have someone with chilblains, if it's very clear that it's chilblains and it's a one-off, I wouldn't do anything and reassure them. If it keeps happening, you probably need to do a screening for rheumatological disease. So I would do the bloods and an exam to rule it out. Sometimes it's associated with Raynaud's disease. But there's a specific subtype called chilblain lupus, which you can only diagnose with a biopsy. So consider referring to derm if they're persistent, because 20% of these become full-blown SLE. Vasculitis, so it depends on what levels of inflammation and size of blood vessels are involved, but small vessel vasculitis, you have petechiae or palpable purpura. Medium vessel vasculitis, you have bruises or nodules. And remember, Vasculitic rashes can also ulcerate and become pustular, and they can be painful. They tend to be painful, actually. And the other type of skin presentation for medium vessel vasculitis is the reticular or lace-like discolorations called livido, especially if it's persistent on the skin. So not the ones that just happen with a cold, but this persistent patch of livido. And you can see the livido here, and you can see, I mean, this is Kawasaki's disease, and this is HSP, and these are different types of vasculitis. And there's excellent guidelines for vasculitis, which are the European Consensus or SHARE guidelines for vasculitis in pediatrics. So the best thing diagnostically is to do a biopsy, and there's a set of investigations detailed in this guideline to do a vasculitic screen. Sarcoidosis can present in a lot of different ways. I think 1 in 3 of them do get erythema nodosum or erythema nodosum-like rashes, but they also present with these persistent sort of skin-colored maculopapular skin lesions that don't respond like eczema does. So if you've got a rash that doesn't respond like it should, get a dermatology opinion, because quite often we get diagnosis of sarcoidosis from a biopsy. And just a little word about erythema nodosum. So these are the bruise-like nodular lesions that you see on the shins, but they can occur on the thighs, forearms, and face. And it's a paniculitis. It's an inflammation of the subcutaneous fat. Usually occurs in 10 to 14-year-olds, and the most common cause is either idiopathic or infective, most commonly strep. But do a system exam and do consider other causes like inflammatory bowel disease or sarcoidosis or TB. But by far the most common cause is strep. And remember, erythema nodosum doesn't ulcerate. So if it's ulcerating, it's something else. The systemic onset JIA rash, remember, is the classic fever pattern, but the key thing about this is it's described as salmon pink, but the main thing about it is it comes and goes. It's evanescent with a fever. It can occur anywhere, but if it comes and goes and changes location with a fever in someone with myalgia or arthralgia, consider systemic onset JIA and consider sending the bloods and a ferritin to diagnose it. So dermatological lesions are common, and they are part of the diagnostic criteria for rheumatology diseases, and they can be the clue to the diagnosis. Perform a biopsy that will help you with your diagnosis, and always have an MDT approach with dermatology for these things, and it's really important to be aware of them. That's it.
Thank you so much, George. It was indeed a whistle-stop tour and really, really interesting. We're a little bit late for our break now, I think. So we are going to ask you to do the questions online, if that's okay.
Sorry.
You was good.
All right. Thanks, everyone.
So I'll start my presentation. Good afternoon, everyone. I appreciate I'm the only surgeon amongst all of you very bright pediatricians. I'll stick to what I know best, and I'm going to discuss about the pediatric surgical referrals, just the common referrals that we get, the common things that will help you understand the process, and just talking about the RTT, which I've put here on the left, not typically in terms of how the managers describe RTT. RTT, I just mean referral to treatment, just to give you an insight into what to expect once you've referred the patient to us. So these are the few conditions I hope to discuss. It's a very long list, so I'll discuss some in detail. The rest I'll just touch upon. I shall start with a question. Basic anatomy, back to medical school. We can't get through a surgical talk without hernias and hydrocele. So, which of the following is incorrect? You can read the screen. Hydrocele results due to failure of closure of PPV. Hernia results due to failure of closure of PPV. Hernias in infants have a lower chance of irreducibility. And strangulated hernias can compromise bowel as well as testis.
And the delegates can put it in the chat.
Thank you, Akshay. I'll give you a few seconds. Do you have any answers? Even one will do. So I can't
It's a
quite see the chat, Akshay.
it's a combination of 1, 2, 3.
It's a
Lots of
combination of
different
1, 2,
answers.
3. Lots of different answers.
Super. So let me give you the answer. The only answer that is incorrect is hernias in infants have a lower chance of irreducibility compared to older children. So both these pathologies occur because the PPV hasn't closed. Another thing to mention is hernias in infants. 1 in 3 of the hernias will have a risk of irreducibility or strangulation. So what I'm coming at is hernias at any age, even if they are neonates, infants, they need to be referred. And a strangulated hernia can compromise the bowel as well as the testis, because these are small babies with small inguinal canals. And if the hernia strangulates, even the testicular vessels can thrombose. Of course, it can compromise the bowel as well, as you all know. Just going through this diagram, you learn this in medical school. A hydrocele transilluminates. The hydrocele is the one on the left. And a hernia doesn't transilluminate. You can see that a hernia is an inguinoscrotal swelling. Just one thing to mention here, since we are doing neonatal and pediatric surgery. In infants, the bowel sometimes is so thin that even a hernia can transilluminate. So just beware of this one finding of transillumination. In a hernia, you cannot get above the swelling like you see on the right side. So these are a few pictures of hernias and hydroceles. The one on the very left, you can see large bilateral hydroceles. This is a neonate. The point I want to make, and the point most of you will know, is that these usually close by 1, 2, even 3 years of age. Hydroceles can differ. The picture in the middle is a localized scrotal. Sometimes you can get it extending into the groin. Most of the times the testis can be felt separately in a hydrocele. And what furthermore, I want to say, if the testis is not separately palpable, then sometimes it's worth getting an ultrasound because of the odd testicular tumor that you might miss. If you examine many clinically, you will know the difference, but you should be able to feel the testis separately. The picture on the top right is just to show that girls can get hernias, where you can get an ovary or bowel stuck within the hernial sac. Just the diagram to give you the pathology, what's normal. The PPV is meant to close. If it doesn't close, like in the picture on the right of your screen, you have a communicating hydrocele. And if this opening is large or very large, then it allows not only fluid, but it will allow bowel into the scrotum. And that's called a hernia. So those of you who put options 1 and 2, the hernias and hydroceles present because of patent processus vaginalis. And in terms of referral, my message to you is hernias. Refer when you see them. They can be operated. We will operate on them at any age. Hydroceles, you can leave them till they are older. If you see a 3, 4, 5-year-old with a hydrocele, then of course do refer. I come to the foreskin. Please write in the chat, at least some of you. Picture 1, 2, 3, 4. And the 4 options you have, or you have to match these pictures with, are a normal prepuce, megaprepuce, a BXO, and a paraphimosis. I'll give you a few seconds. Akshay, will you please call out the chat as it comes through?
Ashwini, what I'll do,
yeah,
when I speak, you could mute because
When
there's
I
an echo
speak, you
coming
could
through.
mute because there's an echo coming through.
Okay.
Perfect. So we got answers coming through. Number 1 is BXO. Number 4 people have put as mega prepuce. Number 2 is normal. People have put. So a variety of answers have come through. Ashwini, unmute yourself. Ashwini, you're on.
Pardon me, all of you know exactly what you're talking about, and I'm very pleased to say that all of you, most of the answers are correct. So, focus on number 2, normal foreskin. You'll be surprised, it seems very easy here, but you'll be surprised the number of referrals we get with all sorts of descriptions. Hence, I've put this up. Number 2 is a normal physiological phimosis. You see the foreskin, it opens up. Whereas the picture on the left is typical of BXO. It's pathological phimosis. Once you see it, you can't forget it. This has to be referred to us. In the past, one of my bosses used to say, if you see BXO in an under 5-year-old, I'll give you a tenner. I didn't earn anything in that posting of mine. Just shows that BXO is extremely, extremely rare in under 5s. So we avoid circumcisions at all costs. This I'm talking medical circumcisions without BXO. Picture 3, people often get confused in what they call phimosis, paraphimosis. Picture 3 is paraphimosis because the foreskin is retracted, it is stuck, it's become edematous, and this is a medical emergency. And although we say physiological phimosis, the picture on the extreme right is a rare situation where this is a mega prepuce. So the whole prepuce is awkwardly, inappropriately attached. Sometimes these get called, even they get referred to as DSD. If you have normal testis and a picture like this, the urine is accumulating underneath this foreskin, and that's a mega prepuce. So if you just see these pictures, it will be clear. Next, we move on to undescended testis. We leave the poll out. I'll just put these questions to you. 6 questions. Which of the following is or are incorrect? I'll give you a few seconds to have a look at it. Just somebody put in the poll, when do we expect spontaneous descent to occur up to? Somebody put in the chat. Akshay?
$12 months.
12 months.
Okay, thank you. The next is changes occur within the testis within the first few years. Undescended testes have a lower incidence of hernias and malignancies 5 to 10 times higher. Ultrasound is a useful tool. Can somebody put number 5? Is that correct or incorrect? Ultrasound is a useful tool. What do you think?
Most of them agree.
Most of them agree.
Most of them agree? Okay, except me, I will disagree because these are in ultrasound is not a useful tool at all. If you have somebody with an undescended testis, impalpable testis, ultrasound, we usually don't do ultrasounds because ultrasounds can have lots of false positives, false negatives, giving false reassurance either ways to the parents. Because sometimes we find that the ultrasound has said there is a testis and there isn't. Ultrasound says there's a testis in the abdomen. Parents cling on to the hope that there is a testis and there actually isn't. So I think this is a message for you guys that ultrasound is not, it's good for lots of things. It is not particularly accurate in picking up location of testis. An exception would be if you're considering, if you're thinking, could this be DSD? And then, yes, there is some indication to do an ultrasound to give us some idea. Also doing an ultrasound of the pelvis where you're actually looking at Mullerian structures. Coming back to this list of answers, spontaneous descent usually occurs by 6 months. If it doesn't by 6 months, I think you can refer. Different people will give you different numbers. Usually say 6 months. If you say 12 months, also it's not wrong, because changes start to occur in the testis quite early on and can affect spermatogenesis. In terms of malignancy, yes, the risk is higher. And surgery, 6 to 18 months. The Australian guidelines say anytime after 3 months. Our guidelines say 6 to 18 months is fine. Just to give you an example, on the left, you have an undescended testis, poorly developed scrotum, empty scrotum, no testis. Look at the picture in the middle. You can see a bulge on the perineum just adjacent to the right scrotal half. And that is an ectopic testis. So when you palpate, if it's not there in the scrotum, feel in the groin, feel at the pubic tubercle, feel adjacent to the testis. And on the picture on the extreme right, you have all the locations for an ectopic testis. Very rarely, it can even be in the thigh. So these are all the sites to examine for a testis. Management, yes, you're right. If you say 6 months, 12 months is fine, refer them to us. We like to operate on them early. I don't think there's any particular role of ultrasound, CT, MRI. Don't waste time. And one important message I want to give is if you have bilateral impalpable testis, or if you have it associated with hypospadias, you must think DSD. And I'm going to come to that in a minute. So how do we manage UDTs? We don't necessarily get scans. What we do is, if it's not palpable in clinic, if it's palpable in the groin, they're booked for an orchidopexy. If they are impalpable, we will book them for an examination under anesthesia, laparoscopy, and proceed. Again, under anesthesia, if it's impalpable, we'll put a laparoscope, and that's the foolproof diagnostic way to look for a testis, and it's also therapeutic in that we can bring it down. So 40% will be intra-abdominal. These are impalpable testis. 30% won't have any testis. So they'll have a solitary testis if there is a testis on the other side. Just touching upon retractile testis, perhaps. Retractile testis, I usually follow them up, maybe annually. The two questions to be asked in retractile testis. One, if the baby was born at term, because if they're born at term, and if you have testis palpable in the scrotum that were noticed in the red book, it's very likely that the testis are going to be descended. Because after the first 3 months of life, the cremasteric reflex becomes quite active. Testes are usually sitting nicely in the scrotum at birth, and then they start to become retractile. But when you examine if you can bring them down, I would just suggest a follow-up maybe in a year till such point that you think they're not in the right place, or till you're satisfied that they come down into the scrotum. And ascending testis is a definite condition, definitely down in childhood. And then through growth, this patent processus vaginalis hasn't kept up, hasn't lengthened, and the testis has now ascended. Just to bear in mind. This is an intra-abdominal testis. We operate on it in stages. The picture on the right is just showing we have ligated the testicular vessels, because these are the testicular vessels you can see in the middle. They are the ones that are holding the testis. We can't mobilize the testis because of these vessels. Testis then gets collateral supply from elsewhere, and we can do an orchidopexy. This is what I mean. Quite abnormal, the genitalia. You can see fullness on the right side, a palpable testis in the right groin. This is a neonate. no gonad palpable on the left. And in the second picture, you can see a very proximal urethral opening. That's a very severe hypospadias. These definitely should be flagged up soon after. This particular child, when we laparoscoped, you can see in the picture, had a streak gonad on one side, had Mullerian structure or uterus in simple terms, and this child had mixed gonadal dysgenesis. So whether in the neonatal period or whether in an older child, if they're bilateral impalpable testis, or you have one impalpable testis and a hypospadias, or the other things are of course clitoromegaly, testis in a girl, hernia, all of these, think DST. Are there any questions so far? We'll move to hypospadias then. What is the recommended age for hypospadias? 1, 2, 3, 4, 5. Just take a look. Akshay, if there's anything in the poll, please let me know.
So
Or
people are
in
putting
the
it in.
chat,
People are
sorry.
putting
So
it in.
people are putting it in. People are putting it in.
Sure.
Looks like 2 is favorite.
Looks like 2 is favorite.
2 is favorite, well done. Because 2 is my favorite as well. 2 is the favorite of the surgeons as well. Child is still in nappies. Of course, hypospadias repair does not control or does not affect potty training as such, but it's good to do it when they are in nappies. 2 to 5 years is not wrong. The reason being, some of the children have very small penises. You want growth to take place. Some of them have other congenital anomalies that need to be sorted. And furthermore, some need staged repairs. So by the time they come to us, we do the first stage, we do the second stage. We usually say that by the time they are around 3, around potty training age, we want to complete all the stages of the repair. And we wait for 12 months because the penile growth takes place in the first year, after which it's easier to operate. Patient choice, this is coming up more and more, particularly for the very distal hypospadias. Many people are of the opinion, do nothing, because it's not going to harm them in terms of adulthood, fertility, etc. That's something we are seeing more and more. You see the difference between the two hypospadias, left, distal, right, very proximal, severe chordae, the meatus is very low down. They require, this one on the right will require a 2-stage repair. So just to summarize, and sometimes if they're really small, then we need endocrine input. This is how it looks after reconstruction. Some rare pictures that I have, there's a picture on the left, it's not very clear. Gets referred to us as epispadias. Why? Because the preputial opening is slightly on the dorsal aspect. Epispadias is not, that is not epispadias. That is just an off-center preputial opening, which once the prepuce retracts will be fine. A proper epispadias is picture number 3. Number 4 is extrophy with epispadias. And number 2 is a megameatus, something they picked up after a circumcision in the community. Just rare things you might see, send them to us. I'll talk a bit about hydronephrosis. Hydronephrosis, by definition, is just a dilatation of the pelvic ileal system. Doesn't necessarily mean an obstruction. This is dilatation. You can see the difference, and it's very important for us to know whether just the pelvic ileal system is dilated or whether the ureter is dilated, because it makes a world of a difference to the diagnosis and management. So this is how we investigate antenatal hydronephrosis. The main thing, if it's bilateral, particularly in a boy, we want to get an MCUG because we are looking for valves and we're looking for reflux. Reflux, of course, if it's asymptomatic, we don't need to operate. Whereas if you have unilateral pelvic ileal dilatation without ureteric dilatation, then it's going to be either reflux or it's going to be a vesico-ureteric junction obstruction. The one on the extreme right, where the bladder is bad, where the ureters are dilated, this is going to be valves, and this is how we would investigate. So again, if you have bilateral dilatation, or if you have ureteric dilatation, or if you have a bladder abnormality, then we would definitely get an MCUG. MCUG we can usually do in a child till they're about a year old. After that, they will resist you, they will fight you. Catheterization is very difficult. One thing to say, you don't need to refer all of the hydronephrosis to a pediatric urologist if it's mild, less than 10 millimeters, even less than 15 millimeters. Don't refer. Just follow them up every 6 months, annually if it's stable. And if 2 consecutive readings are below 10 millimeters, then they can be discharged. I've just drawn this diagram for some of you if they don't understand what is this APD. We are all about AP pelvic diameter measurements. This is just my diagram, the diagram on the right where you have prone, transverse. This is what we measure because it's a fixed point. We as urologists are worried if the AP diameter is over 25 millimeters. And anything beyond that, then we get very worried. And then they could need an operation. So, what are the indications for MCUG? Let's go through this. Unilateral hydronephrosis in a girl, there's no need to do an MCUG because we're not worried about urethral obstruction. Even if they have reflux, we can put them on antibiotic prophylaxis. The ones that we are worried about are the ones I've put in red. And if somebody is symptomatic, then we need to do an MCUG. A multicystic dysplastic kidney doesn't need anything but a follow-up to make sure that the opposite kidney or the contralateral kidney is growing. This is just to show the difference between a normal ultrasound and this is a pyeloplasty, small incision. Other renal anomalies, each of these have to be treated based on their individual units. Just because it's a duplex doesn't mean we need to do something, doesn't mean they need prophylaxis. I might have a duplex, not know about it. It's only if there is dilatation, obstruction in all of these systems, then we need to worry about it. A solitary kidney, always careful. I've just put in the picture the various renal anomalies. So, where would you consider prophylactic antibiotics? A few seconds just to think about it and put down what you think in the chat.
Lots of hydronephrosis.
Lots of hydronephrosis.
Okay, and the others?
Number 1.
Some are put 4, some are put 6.
Some are put 4, some are put 6.
Okay, so if a horseshoe kidney doesn't have dilated moieties, no need for prophylaxis. If a duplex kidney doesn't have dilated moieties, no need for prophylaxis. Well, you may put them on prophylaxis till you get scans and till you're sure that's not a problem. But if you have a dilated system, then we would like them on prophylactic antibiotics. I've put anorectal because these kids are associated with lots of urinary tract abnormalities. They also have a fistula. So we have these needing prophylaxis. An example, a 6-year-old girl, 1 UTI and wetting walks into clinic. She's otherwise very smart. She goes to the toilet, she voids, and despite this, she's constantly wet. She's fecally continent, no bowel problems. Investigate or not? Put in the chat, please, just yes or no.
Lots of yeses.
Lots of yeses.
Because she could have a duplex with an ectopic ureter, she could have neurological problems, she could have, you're going to take a good history. And this is what I want to talk to you about a wet child. Just bedwetting, just enuresis, which is essentially bedwetting. There's no need to refer. They can be followed up in the local enuresis clinic, in the local continence clinics, but it's the daytime we want to evaluate because they can have all of these problems. So enuresis, which is because of physiologically gets better, whereas if it's daytime and nighttime, the first thing to rule out, we want to rule out anatomical, structural problems that may be associated. And once you've ruled them all out, then we call it functional urinary incontinence. So continuous incontinence, day and night, is a problem. Daytime incontinence, we take it seriously. Non-monosymptomatic enuresis is also important. And by that we mean if they have daytime incontinence, if they have bowel problems, if they have any neurology, if they have poor stream of urine. We recently had a 12-year-old boy with wetting who we picked up had posterior urethral valves. So I think we need to look at all of these. These are the ones we would be interested in. Enuresis. What age is a good time to start to investigate? Every child is different. Around 6-7 years, some girls are very aware very early on. Some children are not bothered for a very long time. Bedwetting, we're not worried. Daytime incontinence, that's getting better. Also, we can treat it conservatively. These are all the signs or the things we take seriously. You can see all of these. Bowel, bladder go hand in hand. So all of you know to take a very good bowel history, treat the bowel. We had a 3-year-old child treated for constipation. Again, nobody picked up that his urinary stream wasn't there. He was dribbling. He had posterior urethral valves. Bowel and bladder go hand in hand. These are just some investigations we undertake to help us pick up urinary problems. The other things we see, UTIs, I mean, unless there is any anatomical problem with UTIs, I think they're very nicely managed by you guys. Reflux with recurrent UTIs, yes, we can help, we can do stings. If they have any obstruction, any dilatations on ultrasound, then yes, send them to us. But otherwise, we rarely have any sort of magical cure for UTIs without anatomical issues. Intractable constipation is something I know you guys send to us. Different units have different sort of thresholds for accepting these children. Important ones here are if they fail to pass meconium, they're failing to thrive, you're giving maximum laxatives, they're soiling. Then there are surgical options that can be entertained, which include creating an ACE for washouts of the colon, or even a colostomy. And for us, CNS support that we have is extremely vital. We have some other referrals. Tongue ties, you tell me what needs to be done. We have no strong preference for or against. Parents have their own ideas. I think after the age of 1, we will probably divide because there is some evidence to say that it can affect speech, which in itself is so complicated. So if you talk to different surgeons, you'll have different thoughts. Talk to neonatal nurses, neonatologists, pediatricians, they'll have different ideas. So I've left that one as a query. Umbilical hernias, definitely leave them. Lymphatic malformations, vascular malformations. These days we have specialized clinics for the AAV malformations. Lymph node biopsies, yes, we get referrals for biopsies, but otherwise I think they can be managed. They're very, you guys manage them very well. I've put thyroglossal and branchial because when I was training, we used to do them all. Now there is a big overlap with ENT. I think ENT surgeons are also interested, increasingly referrals are being done to the ENT surgeons. Lots of referrals for children with feeding difficulties. I think majority of the times we would try, or you would try, NG feeds, NJ feeds, whatever the case is. And if it's becoming difficult with the NG feeds, if they're needing frequent replacement, or if sometimes the patients want, we wouldn't offer gastrostomies just because parents want it. They have to have earned their gastrostomy placements. PR bleeding is another common cause for referral. The first thing to ascertain is whether this is an urgent referral or whether this is a routine referral to clinic. Obviously, if the child is having large, frequent bleeds or fresh PR, they may be referred as an emergency because they could have a Meckel's. But these are all the things we look at with PR bleeding. Common things, constipation is a very common cause of PR bleeding. Just to show you Meckel's, polyps that we sometimes find in these PR bleeders. And then these are other specialist referrals. Refer to surgical centers. Liver oncology, as you all know, is specialized and centralized. Sometimes we see unusual presentations. This 10-year-old boy, while playing football, got kicked. This is a common history given. Injured while playing football and got an acute scrotum. Injured while playing football and developed abdominal pain. Injured while playing football, this was the X-ray. Often, this history of injury, not always, definitely not always, but on the odd occasion, it is something that brings to their attention something that might be causing a problem. This boy had a congenital diaphragmatic hernia. As you can see, thoracoscopically, we reduced it, but you can see the defect in the diaphragm on the right. I've put the title on top. I've put the arrow there as well. This is a neonate, but it's not infrequently. We get these at an older age. Why? Because at the postnatal check in the neonatal period, this opening wasn't, nobody actually saw the anal opening. Every time the baby pooed, every time for a nappy change, full of stools, nobody actually picked this up. We have seen quite a few at a later stage. And then this is very rare. I think I'll see one in my whole lifetime with an ectopic scrotum that was actually on the thigh. And we reconstructed it, as you can see on the right. So yes, advances in pediatric urology. We have a lot more day case surgery, hospital at home, which you guys know very well. Post hypospadias, we're doing catheter removals at home. Many of these procedures are laparoscopic these days. And we are embarking on robotic surgery in children. Some centers have already taken it on. We hope we'll be able to do robotic procedures here. And as you all know, 22, 23, 24 weekers, there is improved survival. That is increasing the surgical referrals. And in utero surgery is on the horizon, is one to watch. I haven't covered all of the topics because every topic by itself is a big presentation. And I want to thank you for listening to me. Happy to take questions.
Wonderful. Wonderful. I think for the purpose of echo, maybe when I ask you the question, you mute and then answer. I'll take a couple of questions. Let's do it that way. There's quite a lot of questions, Ashwini, on undescended testes, imaging of choice, and we've said no imaging. Does your view change, or you're going to still say no imaging?
Yeah, I'm still going to say no imaging because they need to be sent across. We need to assess them. If it's palpable, we do an open oculopexy. If it's impalpable, we will do a laparoscopy and an oculopexy. I just want to ask you how it helps. What do you tell the parents?
I think with the undescended testes, it's important to don't give them false reassurance. What we'll have to just tell them is realistically, we've not felt the testicle, and we will need to have a specialist, like a surgeon, to have a look at this. because that sort of whole concept of, oh, if you do a scan and we might find something might not help. So I think so that might be counterproductive.
Yeah, I think so. But also sometimes, yes, they cling to false hopes because an ultrasound saw something, or they are disappointed because an ultrasound hasn't seen. We had a child who didn't come because the ultrasound didn't show anything, and he had actually had an intra-abdominal testis. And I remember from many years ago when I was training in a rural environment, I saw a 19-year-old with a big mass in the epigastrium, and this was para-aortic lymph node, secondaries from an impalpable or an intra-abdominal testis, which was never picked up. So no need to waste time, I think, with ultrasounds. If they are impalpable, we will do a laparoscopy. And so my message, I think my opinion.
I think so. The rest of the questions are something like a GP referrals for undescended testes. Will you take it and other things? So maybe you could answer them, Ashwini. I think so. In the Q&A, you could just put your answer there. You can type it on. But a massive thanks to you. Wonderful talk. And first time we're having a surgeon on board. And welcome on board, Ashwini. It's really good to have you.
Thank you so much. Thanks, everyone.
Lovely. The next talk, we've got Dr. Naik back with two lovely talks, the liver function test and crap talk, Dr. Naik. And Selina's going to be moderating. Over to you.
Hello, everyone. You're all doing so well. So we've got two final talks of the day, and they're going to be brilliant. It's my pleasure to introduce our final speaker, who's Dr. Sandhya Naik, one of the consultant pediatric gastroenterologists, that was a mouthful, at the Royal London. So thank you, Sandhya.
Thanks very much. And a huge thank you to the 200 plus who are waiting. I'm sure you feel slightly saturated after 2 days. But the last two talks hopefully will keep you engaged. It's going to be fun. We've got some polls. So let's start. So the first talk is going to be on liver function tests. And I'm hoping that's working because I can say it. So I think the first thing to think about when it comes to the liver is to remember it is actually a complex organ, despite non-gastro people. And what we've got to think about is the actual source of what test we're thinking about. So obviously, ALT, we always think hepatocytes, but you have to remember that your AST actually can come from muscle too. Your gamma GT and your alk phos obviously come from the biliary side, but of course, don't forget kidney and bone when it comes to alk phos. Bilirubin, immediately we think jaundice, liver, but don't forget all the hemoglobinopathies. So it's actually a heme pigment. And albumin, obviously, you can lose it through your gut or you can have it synthesized by the liver. So, and finally, clotting, obviously a complex array of coagulation factors, but the extrinsic pathway, the liver's crucial. So that's where the INR is for. So this is just pictorially to kind of put it into context so that if your ALT and AST is slightly abnormal, let's think about the hepatocyte and transaminitis per se. If it's the alk phos, the gamma, the bili, let's remember our biliary tree. And hopefully you won't get a child with fulminant liver failure or someone who's decompensated. But if you do, then they're going to have a low albumin, possibly ascites, as in the picture on your right, and a coagulopathy. Now, on my previous talks, I was a bit boring and kept going on about detailed history. I hate to say that it's the same for liver as well. And there are clues. So, for example, the age of presentation. Neonatal jaundice would need a different kind of workup to somebody who presents with jaundice at the age of 10. Now, I know that there are some of my colleagues who do the same panel for everybody, but actually one can be selective, and we're going to talk about this as we go along. May or may not be fever. Obviously, if there's jaundice, it's a little obvious, but there may be bruising with low platelets, Itch is really important. And sadly, now with our teenagers, we do have to think about alcohol, recreational drugs, lifestyle. Hopefully not for our little neonate. And examination. If they're septic looking, it may well be that's the case. It's not actually liver. Any dysmorphism. Crucial, crucial. Don't just take what the parents say the stools look like. Try and have a look at them yourself, or look at a picture, or look at the baby's nappy. Make sure you examine for murmurs, etc. And as we go through some of the cases, I'll kind of explain why this particular attention to detail is so important. Now, these are the basic tests that I think, med student will know. If you've got abnormal tests, let's repeat them to make sure they're not just a one-off, slightly dodgy sample. Always do the clotting, blood count, split billy if they're jaundice, your U's and E's. And in the young ones, if they are jaundice, just make sure there isn't any evidence of sepsis, be it urine, UTI, blood cultures. A baby, and by baby I mean breast, milk fed, so under 6 months, a pre-feed glucose is quite important because children with liver disease will often have silent hypoglycemia. Again, depending on your trust, it may or may not be easy to get an ultrasound there and then. But before we go on to how to interpret abnormal LFTs, do we know for sure that it is actually coming from the liver? Because I've already mentioned kidney, bone, muscle. So what we're going to do is start off with some polls and some cases, all of which are true ones, and highlight why it might not be liver to begin with. So our first case. So guys, ready for our polls? A 4-year-old, really common presentation, recurrent abdo pain. He looks well. There's no family history of note, but the GP, kept going to the GP, and the GP has referred them into you guys in Paeds because the ALT and AST were raised, but the billy was normal. And what I would like you to know is you're going to arrange to see them, repeat the LFTs, but in addition, you're going to do one blood test now. And note, he's not jaundiced. So, are you going to do a gamma GT? Are you going to do a blood culture in a 4-year-old? You're going to do clotting, even though they're not jaundiced, and they haven't got a distended tummy, or are you going to do a CK? What do you guys think? Thanks, Jeremy. It's almost like we've done this before. Okay. And let's see what you think. Oh, this is interesting. So we've got a third, 29, my eyesight, sorry, 29% want to do a gamma. Thankfully, you've realized you don't want to think about sepsis in a 4-year-old. Few of you did say a creatine kinase. And the answer is, oh, even more suspense because I forgot to press my button. It was the creatine kinase. Because in this well child who was 4, there was no jaundice, there was no ascites. And so what we wanted to really know was actually, while we repeat the LFTs and the AST was sky high, we did the CK. We went back and took a bit more of a history. Are you sure there's nothing else? There was a really subtle, always starting to trip over a lot. And it turned out he had Becker's. So if you have got abnormal LFTs, has there somewhere along the line been a normal CK? So well done to half of you. And I think we've still got everyone engaged. So let's go for it. An 8-year-old, cerebral palsy, GMFCS4, wheelchair dependent, I believe 5 now, seizures, gastrostomy feed. Hopefully you guys are all aware that if anyone is fully dependent on tube feeding, they should be attending for annual nutritional bloods. And so they do. And the ALT and AST are raised, but the bilirubin, the INR, and that was done as a reflection of vitamin K deficiency. The vitamin D were all normal. Copper, zinc, selenium, all normal. So what do we think the diagnosis might be? Do we think they've got autoimmune? Do we think they've got drug-induced, viral, or fatty liver? And I didn't give you a height and weight, but they're on the 25th centile. See what you think. Yay, 2/3 of you have gone for drug induced. I guess for the third who went for fatty liver, I did sort of say afterwards that they were on the 25th centile. And it is quite unusual for globally developmental kids to actually get fatty liver disease, because it means that the dietitian isn't really watching it. Now, most of the time it's actually their anti-seizure medication, and they could have been on it for quite some time. And the good news is that if it's mild, it's usually reversible. And this nowadays, with the use of things like Keppra, it's really easy to switch their seizure meds over with consultation with their seizure doc. So those were just two cases. So really what I wanted to highlight is, don't forget about drug-induced abnormalities of liver function. An isolated ALK phos. I do an adolescent clinic with my adult hepatologist, and he says he's going bald because he's tearing his hair out of the number of referrals for an isolated ALK phos when it's just a teenage 18-year-old who's still growing. So don't forget about growth and vitamin D deficiency causing an ALK phos. Don't forget about muscular dystrophy. I mentioned that Becker's case. I've also picked up two Duchenne's in a similar manner, where I almost went up to biopsy them and then looked back and realised they didn't have a CK. I'm not going to, for the sake of time, go into these conditions such as Gilbert's and Kriegler-Najjar. Gilbert's nowadays, you can do genetics, and it's usually a really subtle, isolated bilirubin, sort of between 25 and 50. Kriegler-Najjar can present a bit later, even though it's usually in the infantile period. But what happens is it's rebound. So say they do get better, it comes back again. And again, genetics for that. So now that we know it's not liver, let's talk about liver. So what we're going to do now is to have some fun with some more cases and polls. And we're going to understand, hopefully, expand our knowledge or refresh, depending on your experience, of jaundice in the infants and children. Try and get a bit of a structured approach, and obviously understand that I've been given half an hour to do a talk that could last a whole week. So there's a wide spectrum. So here we go. This is a standard case, a 4-week-old who is breastfeeding well. They have abnormal liver function, all of them, both biliary and hepatocytic. And you can see the picture. For those who might not be clear on their screens, on the left-hand side is a white, pale, abnormal stool, which is theirs. And on the right is the normal pigmented stool. And my question to you guys is, what's the diagnosis? Is this cystic fibrosis, biliary atresia, intestinal failure associated liver disease, Alagille's, or all of the above? Let's see what you guys think. You have to give it a few seconds because there's 200 of you trying to answer. Right, so 2/3 of you have said biliary atresia, which it could be. A couple have said Alagille's or CF, and 1/3 of you have said all of the above. Ooh, aren't 1/3 of you clever? And why is that? Well, the answer is you do have to exclude biliary atresia, but then they need a full workup. So the answer actually is it could be any of them, because CF, Alagille's, intestinal failure, liver disease are all conditions that can cause cholestasis stroke obstructive jaundice. So let's talk about biliary atresia and why it's important to exclude that first. Most of you will possibly have dealt with a case, depending on how long you've been practicing, and will have had direct contact with Kings. There's no point going via gastro. It's 1 in 14,000, and it's a congenital abnormality where there is destruction, essentially, from the porta hepatis to the duodenum. And the treatment is essentially a portoenterostomy, which I'm going to show you a picture of. And it's the bit in yellow that I've highlighted. If we diagnose, and by we I mean the collective medical profession, before the age of 8 weeks, 90% will clear their jaundice. If, unfortunately, they've had a delayed presentation and they're over 8 weeks, but less than 12 weeks, the chance of having a successful CASI is down to 45%. And if by chance they're more than 3 months old, and this is usually, but not always, those who've lived abroad and have come over for specialist opinion, who can afford it, your chance of clearing your jaundice is actually a 1 in 5. And in those babies, nowadays, they often will end up going straight for a transplant rather than trying to bother with a CASI. So what is a CASI? Well, first we have to see what type of biliary atresia we've got. And here pictorially, you can see the 4 types. And the most common is where there's complete obliteration, which is type 4 on the bottom right-hand side of your screen. And what happens is, if I use my arrow, this duodenum is divided along here and split into a Y, with one part going up to the porta hepatis, another part joining to the rest of the duodenum, so it's a Roux Y to allow drainage from the porta down. So we talked about cholestasis, and we said, oh, well, it could be CF, it could be Alagilles. Well, what else could it be? And here's the big list, which is why gastro and hepatology always like lots of blood tests. Extrahepatic cholestasis is on the left-hand side, and you can see there's quite a few, some of which are more common than others. There's associations, for example, association with trisomies, particularly Downs. Choledochal cyst mimics biliary atresia. Gallstones, particularly in the older child. But then you've also got the intrahepatic causes of cholestasis. And in here is also drug-induced. We've got the metabolic ones, like we've mentioned, and it may be with or without the biliary tract. So I'm just going to run through 1 or 2 more interesting, perhaps more common ones of these, even though they're not common at all. And the first thing I'd like to talk about is PIFIC. So progressive familial intrahepatic cholestasis. Now, I know this slide isn't so clear, but what you can see is you've got your biliary duct, you've got your hepatocytes, and what you've got are the genes now identified that can cause intrahepatic cholestasis that's familial. And you can see there's P-lectin, there's a few newer ones coming through. So this slide's a bit clearer because what it also shows you is when you've got your hepatocytes and you want to get your flow through the biliary system, you've got bile salt export protein, you've got your ABC4, 8, G8, 5, MDR3, that's your cholestasis in pregnancy, and we've got a whole load of bile transporters here. So I can imagine that a few of you are looking at this and going, yeah, we're above my head. Why is it so important? Because now we can treat these kids. Before, these kids would have intractable cholestasis, horrendous itch that just made their quality of life horrendous. They would scratch so badly, they would just cause themselves secondary infections with excoriation. And all you could do was sort of simplify it by, you know, a bit of urso, a bit of cholestyramine. Some of them had biliary diversion, but it never really helped much. But what we can do now is actually inhibit the bile acid absorption in the gut, and therefore their itch reduces, their cholestasis improves. And there are now 2 licensed bile acid transporters. They're called IBATs, short for ileal bile acid transporters, and we can inhibit them. And these are now available on the NHS and has revolutionised the lives of children with these types of cholestasis. So while we're on cholestasis, what's another one that we can talk about? So let's go back to another case and another poll. Hopefully you're still with me. So this time we've got a term infant losing a bit of weight because their feeding's not so good. They are yellow, so clearly yellow sclera. And on auscultation, I'm going to give you an even bigger clue. It's an ejection systolic murmur in the left sternal edge. And I want to know what kind of X-ray is going to help the diagnosis. So the choices are a chest, an abdo, a spine, or a hip. So what X-ray to help the diagnosis of the cholestasis in this kids? Let's just give you a few seconds. Two-thirds of you said spine. Nobody said hip. Yay. One said abdo, which you might get. So, and a couple said chest X-ray. The answer is, I think you're all after the same thing, but just which X-ray. The answer is X-ray of the spine, because what we're talking about is Alagille syndrome. And what you should be aware of as pediatricians and med students is that you get hemivertebrae or butterfly vertebrae, which is exactly as it's described. They either look like a butterfly or they look like half a butterfly. And usually it's a spinal X-ray. If you go for an abdo or chest to look at the spine, if you've got a really good radiographer, they're not going to use overexposure, so you're not going to see the spine well. So just ask for a spine. You also want your ophthalmologist to look in the eyes because there's a remnant called a posterior embryotoxin, which only ophthalmologists can see, and it's just an association with Alagilles. It's a clue, a bit like blue eyes with osteogenesis. Echo, obviously, to confirm pulmonary stenosis, and the genetics, which is the JAG1 mutation. And what we do know is the JAG1 mutation, it pretty much affects more than 90% of kids with Alagilles. It's autosomal dominant, but with a variable penetrance. But often the child is diagnosed and then we go back to the adults and often they've had undiagnosed pulmonary stenosis or they've got FACEs that look like their child. This review that I've highlighted at the bottom of the slide is slightly old, but it's just a really easily readable one. And I would say that apart from the treatment of cholestasis and transplantation, not much else has changed. So still a good review. Okay, just in case you've lost track, we're still on jaundice in babies. So an ex-prem, 28-week, had neck, only had PN for a few weeks, is still a bit yellow. What's the diagnosis? Jeremy, our next poll. Lovely. So again, do we think this is IFALD, biliary atresia, alpha 1? Oh, I've dropped off, or something else. Sorry, there should be a D. If you can't say it, just don't answer and then I'll know. IFALD. So IFALD used to be called PN cholestasis, but now we have to call it intestinal failure associated liver disease, which is just a bit of a mouthful. It could be one of the others, but what's the thing that we need to remember about IFALD? Is it's a diagnosis of exclusion. And there are probably 20 plus differentials that it could be. So I'm not saying you're wrong for those who said it might be CF or something, but it's a diagnosis of exclusion. And what do we know about IFALD? We actually know it affects the majority of babies on PN, but what happens is the majority of them, it resolves because they're ill with their neck, they then get a bit of sepsis, they've had an operation, so of course all their LFTs go off, but as they recover, it all settles down, and you can't really then pick out that they had a little bit of PN IFALD. But for those who stay on PN or have had a significant injury from the PN, they will get cholestasis as infants. They will then get steatosis in an older child, and up to it's quite a varied variety when you look at the literature evidence, but up to a fifth could end up with a liver transplant. So it is an important thing to diagnose and pick up. And it's kind of common sense for many of you who did neonates that the more short gut or the worse neonatal condition with early jaundice, lots of sepsis, more prematurity, excuse me, the more likely it is that you're going to get IFALs. And the way to prevent it is early trophic feeding in the neonatal period, much to the behest of your neonatal consultants and the surgeons, but push that 1 ml or half a ml to help protect the liver and ultimately aim to get to a third of their requirement. So I said it was a diagnosis of exclusion of other cholestatic disorders, and I said 20. And I'm just listing some that we would think of immediately, but it's not an exhaustive list. If they're a neonate and they're jaundice, and we've got to think about the torch screen, the full viral panel, and by this I mean things like the herpes family, CMV, parvo. Obviously exclude any bacteria, depending on where you actually practice. So worldwide, got to think about TB parasites. And then you've got a few of these metabolic conditions which can present just with simple jaundice. Alpha-1 and CF actually mimic biliary atresia, so it's always quite hard to diagnose them. So what do we do? We've got jaundice baby. Are we testing for all of these? Well, the answer is there is a bit of a workup, and I'm going to come to that in a second. So what we know is that there is a wide spectrum of neonatal jaundice. And actually what you have to do is, as I've said, exclude biliary atresia and then work your way through the others by doing essentially tests for the conditions I've just shown you. So what about the older child? Is that still the same? Do we have to do the same workup? Can they present late? So let's go for a 10-year-old now. They've got abdo pain. They've got fatigue. They've got abnormal liver function, but albumin, alk, phos, and bili, so the biliary side, is all normal. And we've got another poll coming up. Hopefully we're all there. What do we think? 10-year-old this time. Autoimmune, viral hepatitis, NAFLD, that's your fatty liver disease. I know it's called MASLD now. We'll talk about that in a sec. Wilson's, or all of the above. And I'm delighted that there's still over 200 of you listening in. So please engage. It's the only way to keep going on a Friday night. Let's go. Right. So we've got a mixed picture, but more than 50% of you said all. And I'm really pleased about that. And the reason being is that it is all of them. So what is the basic workup this 10-year-old needs? Well, if we're thinking about Wilson's, which is this age group, then you've got your INR, your serum copper and ceruloplasmin, and your urinary copper. Wilson, sorted. And then refer. If it's the viral screen, make sure we request the right viral request. People get a bit mixed up with antibodies and antigens. So to be clear, we want a Hep A IgM, a Hep B surface antigen, and a Hep C antibody. So that's your viral screen. So you don't have to worry about things like CMV because that's usually congenital. Unless there's something in the history, don't need to think about the other viruses. Then for autoimmune, autoantibody panel immunoglobulins. Nice and easy. So we don't have to do the whole metabolic because they would have presented by now. So what do we know about viral hepatitis in children these days? Well, if your Hep C antibody is positive, we then have to confirm it with PCR. We know there's 4 genotypes, and depending on your ethnic background, where the kid was born, where the parents were born. So, for example, Egypt, genotype 4, Pakistan, heritage, genotype 3, white Caucasian infant of a drug addict, type 1. But what's very exciting is that hepatitis C can be globally cured. One of the few diseases in liver that can be cured fully. And what we do is we use a DAA, that's a direct acting agent, i.e. oral tablets or granules, for 8 to 12 weeks, depending on their genotype. And basically, we monitor them, depending what age we picked it up, until they're 3. That's the youngest we can treat. And there's a national framework. We present the case, we get Blue Tech funding, and they get what we call SVR, which is sustained viral response. Immediately at week 12, sustained at 1 year, and at 2, and then they can be discharged. So that's really exciting. Hep C curable. Obviously in countries that can afford DAAs. Hepatitis B, not quite the same. We can look at the viral load, and then at the Royal London, what we're doing is looking at the surface antigen level, because we can risk stratify them, not just whether they're E antibody positive or negative, but whether their surface antigen is low or high. And by low, we mean less than 10,000, because these ones with the low surface antigen level are actually much less risk of becoming severely ill and decompensate as time goes on. And they fall into the immunotolerant group. The direct acting agents, which a lot of the adult population are on, merely suppresses your viral load, does not get rid of your surface antigen, and hence they're still positive. And now current research is looking at agents to target the inner core surface antigen. Wilson's disease. For those who are, I won't say elderly, mature, it used to be called hepatolenticular, if you look at the really old textbooks. And that's because the copper builds up in both brain and liver, and it can present with either neuro or liver or a little bit of both. We know the gene mutation. We treat it with chelation with penicillamine and zinc. And we also avoid some high copper type foods. Did you know that meat, shellfish, nuts, and chocolate have high content of copper? And a few might end up with a transplant. Oh, apologies. I've just realised I can't spell absorption. And we know it's 1 in 30,000. So some of them will present with the neuro very subtly, where the handwriting's going off, they're becoming a bit clumsy at school. Some will present just with chronic liver disease, and some will present with fulminant liver failure with high INR and low albumin. And then the third one, which was in that differential, was autoimmune disease. Type 1 SMA positive, type 2 liver kidney microsomal positive. Just like many autoimmune conditions, steroids for induction, immunosuppressants. If they decompensate, they might end up with a transplant. And then just for the last couple of cases, to look slightly wider, we know that there is liver involvement in inflammatory bowel disease. So we've got a 12-year-old who's been referred, and they've got abnormal LFTs. So my question to you is, what percentage of pediatric IBD has liver involvement? And I don't mean a transient, I mean actual liver disease. 1%, 3%, 10 or 15. Pediatric liver disease with liver disease associated with it. Let's see what you think. Half of you think it's 10%. A third of you think 3%. And then we've got a scattering. And the answer, with bated breath, is 3%. 3% of all pediatric IBD has liver disease. It may be autoimmune. It may be primary sclerosing cholangitis. And it may even be an overlap feature. So we do the immunoglobulins and autoantibodies. But to confirm the diagnosis, they're going to need liver ultrasound, an MRCP, and more than likely a liver biopsy. So that's IBD liver disease. And then we've got another case, similar age, an 11-year-old, and the GP's referred in to you guys because they kept going with constipation on Movicol, stimulants, abdo pain. And my question to you is, what do you think is the most common liver disease in children in the UK currently? Drug-induced, including paracetamol, viral hep, biliary atresia, autoimmune, or fatty liver? Going to be interested on this one, what you all think. Most common cause of pediatric liver disease. Two-thirds of you say it's fatty liver disease, and about 1 in 5 said drug-induced. No one said biliary atresia, which is at least something because we just said it was rare. And the answer is, sadly, in the UK, the most common cause of pediatric liver disease is fatty liver. So always ask the height and weight whenever you've got abnormal LFTs. And specifically, quite useful to ask about family history. I've got quite a cohort of fatty liver where their fathers or mothers have got significant fatty liver disease and have aggressive cirrhosis. So it is worth getting a family history too. Now, MASLD is the new terminology. It's not, because in kids, particularly non-alcoholic fatty liver disease, it's no longer thought to be appropriate. So that's metabolic associated steatotic liver disease. Just call it MASLD. It's about 10%. And it is reversible in the early. Now, this is my favorite slide. You've got normal hepatocytes, you've got your fat droplets, you've then got expanded portal tracts, which is fibrotic. And then here you've got essentially totally destroyed, isn't it? There's either fat cells, there's no normal cells, expanded portal tracts, this is cirrhotic. This is not reversible. Fatty liver, just droplets of fat is. So we really have to knock hard the lifestyle changes and dietary exercise. There's been a recent practical approach to the management of fatty liver. So I put a reference there. We do need to think about GLP-1 agonists in the extreme cases, and even possibly bariatric surgery. The caveat to both of those is if you stop the GLP-1, the weight goes back on. If they don't lose weight before bariatric surgery, they can't even get eligible for it. So fatty liver disease, I'm sure you see all of it, and they don't always have to have abnormal LFTs. So guys, I'm going to end it there. Hopefully you've learned that abnormal LFTs doesn't always mean liver, that there's a huge spectrum of liver disease. Some of the tips are, of course, exclude sepsis. Please correct any coagulopathy. We now know what the most common cause of liver disease is, sadly. Do a workup according to their age rather than just tick boxing. Do a bit of thinking with a detailed history. And of course, discuss it with your friendly gastroenterologist or hepatologist.
Thank you so much, Sandia. You've given us a really fantastic overview on how to approach abnormal LFTs. And it's always tricky because there's such a breadth of diagnoses which you've shown us. We've got two questions. The first is, do you follow up or do anything special for children with alpha-1 antitrypsin PIMS defect carriers?
So if they're heterozygote, no. I just counsel them that basically they don't know if their partner in the future is going to be a heterozygote too, because then it's going to affect the baby, obviously. So just for those to remember, it's your protease inhibitor, and MM is normal, ZZ is alpha-1, SZ is when you get the emphysema, alpha-1 in the lungs when you're an adult. So if you're just an MZ, it means you're just a carrier. And as you know, just like we would do if someone's a CF carrier, we wouldn't necessarily follow them up. So if it was picked up just as a carrier, I wouldn't specifically follow them up, just to counsel them accordingly.
Thank you. Maybe I'll do one more question and then two, I might leave you to answer. Oh, we've got lots of questions now, but I'll focus on the ones related to fatty liver.
Yep.
So quite a few people have said a bit concerned about picking up fatty liver, and just want you to clarify when they should arrange follow-up, when to be concerned, and what we should be doing as general pediatricians.
So basically, because I've harped on that it's so common, it's a bit of my personal bugbear. And I know a colleague says, is it actually a medical condition or is it a social and economic condition? Listen, essentially, if you've got an overweight child, they may have normal LFTs, and if they're significantly overweight, get an ultrasound done. If there's fatty liver on an ultrasound, then it's 6 monthly follow-up, an annual ultrasound, and 6 monthly follow-up with dietetic input. I, in my liver clinic, can, because it's so common, only take it if their ALT is like 100 plus, so 2.5 times normal. So anything less than that should be followed up by general peds. And what they do is see them 6 monthly, ram it in with dietetic advice, which may or may not be useful. You tell them to lose, what you're aiming for is trying to lose a kilo a month. They usually gain a kilo a month, so it's a bit of a challenge. And see them 6 monthly just to keep reiterating. The caveat is that if they've got fatty liver on ultrasound with normal LFTs and they go into proper dietary change and exercise, that ultrasound can become normal in a couple of years. And similarly, the LFTs can normalize. So there is a small handful who have a really genetic predisposition to advanced disease, but they're the ones whose ALTs are going to be sky high, and you're going to refer them anyway.
That's super helpful. Thank you very much. There's a couple of questions on there, but maybe I'll leave you to answer those online and we can go to the next talk.
Sure. So guys, if you can just bear with, I know it's the end of the day. We've got a few more polls and I will be able to catch up some time on the chronic abdo pain talk. So, okay, chronic recurrent abdo pain. If I use the initials, I'd be saying crap throughout the talk, which I have been told I shouldn't really be doing in this day and age. So I won't talk about crap referrals and I won't talk about management of crap. I will use the term RAP. Now, there's a really old definition that aptly used based on school children. And he worked out back in 1958 that there's an awful lot of tummy aches where it's non-organic. And as pediatricians out there, it's your heart sink. It's the heart sink for gastroenterologists. It's the heart sink for everyone, where it's kids missing school because of tummy ache. And you're just a bit stuck what you're going to do with them because parents just don't know what to do with their screaming kid. But, of course, we cannot assume they're functional because it's a diagnosis of exclusion. So what we're going to do is run through some cases with some polls of what are the organic causes that need thinking of or excluding before we assume it is recurrent abdominal pain. So here's our first one. These are two pictures. I'm not going to describe them for you. I'll let you just look at them. And my question to you is, how do you test for this? Do you do a breath test, a blood test, a poo test, or an endoscopy? Well, not you, refer for endoscopy. Excuse me while I just get a bit dry. Promise you that's just plain Pepsi diet. Right. Let's see what you think. Yay. So we've got 1 in 5 did say a breath test. That used to be the answer. But 2/3 of you said stool. So Helicobacter officially is a class 1 carcinogen, according to the World Health. Remember, it can cause a raised fecal calpro. So if you do stool tests and you've got a fecal calpro, make sure it's not just HP. We use triple eradication as per BNF. Might need a repeat. Oh my God, another spelling typo. Can't spell repeat. And then what you should do is, after the treatment finishes, wait 3 months and then repeat the stool antigen. If you do it too early, it'll still be positive. But the bottom line is the most important thing. If you find incidental H. pylori, we are now obliged, because of WHO, to treat it, but it might not be the cause of their abdo pain. So, makes it a little bit difficult, but you have to just treat and see. Okay, what else? Here we've got another case. Excuse me. They've got a variety of all these symptoms. And my question to you, which you should know if you were paying attention yesterday, what's my gold standard test? I'm expecting 100%, guys. Barium, pH, impedance, endoscopy, or none of the above, clinical only. This is where I know whether you were listening to my reflux talk yesterday. Oh, only half of you were listening. Oh no, I'm going to give it to the third that said clinical only, because you're right. There is some children with reflux and abdo pain, but this is about abdo pain. So it's not going to be the babies. It's going to be the older kid with abdo pain. But if they've got some symptoms that's suggestive of reflux, might need to consider an impedance. So I'm not going back on what I said yesterday. Okay. I wouldn't be a gastroenterologist if it didn't have at least one endoscopy picture. So picture on your left is endoscopic. I think you can see it looks a bit bumpy and a bit flat. That is not normal. The histology on the right-hand side looking at you is flat. You've got normal villi on the left. Once we diagnose this, we've got a choice of what foods need to be excluded. I'll let you read them out and I'll let you work out what is the correct combination. And as you can see, it's between wheat, oat, barley, rye, maize. So let's see which combo you like. I thought I wouldn't read it out because I'd probably get confused myself. 46% have said wheat, rye, and barley. Few have decided that oats should be in there, and a couple have actually put maize in. Maize is sweet corn, you know. So, of course, we were talking about celiac disease, and I'm hoping that you are all aware now that in about 50%, possibly more, we can now use the non-biopsy route to diagnose celiac disease. You've got your reference there at the bottom. We don't need to do HLA typing. So it's a bit busy slide, but I'm just going to run through it. Basically, do their TTG. And if it's positive, basically they need an endomesial positive and a TTG positive. I'm jumping straight here. And so if you've got two TTGs greater than 10 times the upper limit of normal and a positive AMA in a symptomatic child, you can confirm celiac disease. And what we would do is say, yes, I agree with your blood tests. They've got celiac. Please see with a dietitian. If there's any reason they don't have those, then we might need to consider a biopsy. Okay. So I think a lot more celiac can be managed in secondary care rather than tertiary because we now no longer need to do as many biopsies. And a really helpful resource for celiac disease is actually on the Celiac UK website. If you go onto it, there's a tab for parents, which is all sorts, but there's one that is for healthcare professionals. It gives you diagnosis, it gives you things to look out for, it tells you about monitoring. So a really useful resource. Just go onto Celiac UK. Okay. Now, as you know, people who have older children with UTIs often will have abdo pain. But if we exclude the UTI and everything else, how common is RAP? I want to say crap. How common is RAP in childhood? 1 in 5, 1 in 10, 1 in 20, going up to 100, 1 in 100. How common do we think it is? Think about your ped clinics and your heart sinks. How common are you seeing these kids? Beautifully timed there, Jeremy. Thank you. We've got a bit of an even split, about 38, 35, 31% ranging between 1 in 10, 1 in 20. A couple think it's as common as 1 in 5, and a few think it's 3% think it's 1 in 100. The answer is it's 1 in 10. Now, obviously, I mentioned UTI, so again, just remind you there is a UTI NICE guideline, and swiftly moving on from that. Again, I love my IBD. So I've got 5 statements. I want to know which of the following is true. So just to give you an idea, that left-hand picture is Crohn's, the right hand is UC, the middle is erythema nodosum. What do you think's true? Is Crohn's more common than UC? This is all in kids. Is erythema nodosum responsive to exclusive nutrition? Does a sibling of a child with PIBD have a 20 times risk of getting it? Is it all of those are true or none of them are true? Making you think last thing on a Friday. 2/3 think all of them are true, and 1 in 5 think none of them are true. That's quite a varied. So, oops, lost my arrow now. The answer was none of them. The reason being is UC is more common than Crohn's. Erythema nodosum needs steroids, doesn't respond to nutrition. If you've got a child with IBD, their sibling has a 15 times risk, not 20. And so that's why it was none of the above. So well done to the 20% who got that right. So I'm just going to quickly mention inflammatory bowel disease because I know we didn't have a chat on it. 25% of all IBD presents under the age of 16. I've put down the prevalence and the incidence. So when it's per 100,000, for those of you into footy, think about Wembley Stadium, and then you can work out how many numbers. A few key things. If it's bloody diarrhea, it's a bit obvious. But don't forget something like nocturnal diarrhea or chronic diarrhea more than 4 weeks. Perianal disease is a bit obvious. Fever, not so obvious. And what we do is that for UC, if it's really mild, we might just start with 5-ASA. For Crohn's, we would start with enteral nutrition. They might need steroids. And the old, I wouldn't say old, but historical way of managing would be just to do a step-up approach. But now, biological treatment with anti-TNF, so these are drugs that you will have heard of, infliximab, adalimumab. This is pretty much standard of care for children with IBD, at least 2/3. And there are clear indicators at diagnosis. Really deep colonic ulceration, long segment small bowel, panenteric disease, severe growth delay. They needed IV steroids at diagnosis. They're going to go on to early anti-TNF pretty much immediately within a few weeks. I know the world of treatment for IBD is ever expanding, more so in adults than in kids. So all I've done here is in the top line, what is standard of care? And the age is related to licensing, but we do use it off-label with Chair's Action. But there are other drugs around, and just so that you're familiar with them, I've kind of put what age group we can use them in, what their name is, and what the target is. And I think this time around, I've saved you from a complex immunology picture. Now I'm going to talk slightly slowly for this slide because it's one of my pet hates. A fecal calprotectin is a very useful test in the right context. It is not diagnostic. Firstly, can I plead with you, if there is even a handful of you that are doing it, and anyone less than the age of 2, the best use of a Calpro is if I've got a diagnosis of IBD, I have a Calpro, I put treatment in, and then I'm going to repeat it. I know their response. But I think this table is quite useful for you guys as to how likely is it, if I've done a Calpro, that it is IBD. If it's less than 250, can we think about the list on the right-hand side? Have they taken non-steroidals? Have they had an infection? Have they got H. pylori? Is there a constipation with a tear? Have they got bacterial overgrowth because of constipation? But if it's over 250, and definitely if it's over 500, absolutely refer to gastro. So if anything, this is your favourite slide to save, please. Now, we've talked about recurrent abdo pain, and we're still on the organic causes. Don't worry, I will get to the non-organic. I just want you to tell me what you think the most common cause of acute pancreatitis in childhood is. And I've put to remind you all that even in children, we use the mnemonic get smashed, which gallstones, ethanol, trauma, steroids, mumps, measles, autoimmune, scorpion, hypercalcemia, herpes family, post-ERCP and drugs, just to remind you. But what do you think is the most common cause? CF, gallstones, alcohol, genetics, or idiopathic? Let's see what you think. Two-thirds have said idiopathic. I love the one who's a cynic and said alcohol. You know, mate, you're not wrong. There nowadays you do have to think about it, but the answer is idiopathic. And all I've done is there's a beautiful working group paper by the Paeds Gastro Society published last year. So if you want to know more about pancreatitis, have a good read. And the most common liver disease picked up on routine investigation of abdo pain is what? Viral hep, Gilbert's, fatty liver and gallstones. Come on, guys, I said it earlier. Yeah, fatty liver, of course. We are getting more and more children with gallstones, and that is because obviously it's related to their obesity. And that's why they've got gallstones. But yeah, it's still fatty liver. So I know there's a bit of an overlap, but fatty liver, abdo pain, all related. I know Jin did a whole chat on fatty liver, so I don't on obesity. This is purely about Masold, and what I wanted to point out is that the ultrasound that you were asking about, you know, how often should I monitor them? When should I follow them up? So if you read this practice guideline, it's really, really helpful. It is slightly old. There is a newer one available by SGAN, and it's basically just monitoring 6 monthly, really. And then, what is the most common cause of irregular periods and abdominal pain? So we've got polycystic, endometriosis, an ovarian cyst, or a normal variance. We are going to run over by about 5 minutes only, just to let you know, guys. It won't be longer than that. Normal variance, yes. Although polycystic is quite common, it is actually normal variance. You know, teenagers, slightly irregular periods, and they get tummy aches. So, as you can see, two-thirds of the talk about recurrent abdominal pain was actually about excluding organic causes. And that's important because if we miss an organic cause, there's no excuse. And then you do remember yesterday that we had a bit of an irritable bowel chat, and I did mention the Rome 4 criteria. And within there is the Rome 4 criteria of functional abdominal pain. And NOS means not otherwise specified. Huge research about, is it dysbiosis? Is it motility? Is it hypersensitivity? The only reason it's worth saying you have Rome 4 criteria of functional abdominal pain, NOS, is because parents like a label. And you're going to say, am I going to give you the magic answers on how to manage it? No, because it's back to common sense. Unfortunately, we haven't got the magic cure. It is all about reassurance, and it will mean time invested. And so what you'll end up doing, particularly in the DGH, is you'll probably worth off seeing them again in a few months, but giving them a double slot because they do take more time. give them a double slot, reassure them, get that psychosocial history. And if you have local psychologists, intervene early if they can take these kids on. I have no problems in simple analgesia, but I do have an issue with non-steroidals. I don't mind Buscopan, it's fine. It doesn't harm, usually, unless you overdose, which one of mine did. Hot water bottles, no offence, but I think secondary care paediatricians are much more holistically trained and much better at referring for mindfulness, distraction techniques, hypnotherapy, formal CBT. And I know the easiest knee-jerk response is, I'll just send it to gastro. Mate, we haven't got the answers. And depending on who you refer to, they will actually, I refuse to give a scope to a child when I know it's going to be normal. I don't see the point. Because at the end of the day, I will feel bad if they have a reaction to that anesthetic. So I will only if I'm desperate do it. Otherwise, we're only doing scopes for pathology. So unless there's red flags, which for the past 2 days we've mentioned lots of red flags for GI issues, try and hold on to them, develop a rapport with them, get an internal second opinion, another general pediatrician. They do like dysbiosis, it won't harm them to have Activia yogurts. It won't harm them to have probiotics. It won't harm. So just the main thing, like we all know, do no harm. But don't give them false hope by saying, if you are going to refer to gastro, do it honestly and openly, saying they may not be able to find pathology. So RAP, stroke crap, is common. It's 1 in to 2 in every 10 kids. We need to stop over-investigating these children. You've had a chat about FII. We need to avoid over-medicating. We need to invest time, and that's why a double slot. Easier said than done, I know, but we really need to reassure. Try and signpost, and nowadays, post-COVID, I think everyone is a bit better about recognizing mental health, anxieties, and stresses. And the reason we want to pay a bit more attention is there is very solid evidence. If we can address these recurrent abdo pain kids earlier and improve them, they will not go on to become chronic pain patients as adults who become ultimately opioid addicts and just a downhill. And then there's a really nice patient info doctor resource if you haven't seen it, which hopefully you will have at the bottom of my talk. So guys, I'm going to stop there. I think I've gone over by all of 5 minutes. Apologies.
But it was well worth it. Thank you. And I think
Thank you.
really important as well, the role we play as general pediatricians in containing and holding these patients with recurrent abdominal pain, because certainly in my experience, those referrals often escalate symptoms as well. So it can be difficult, but thank you. We've got we've got quite a few questions, but I'm going to pick up on the pertinent ones. We've got one interesting one. Are hydrogen breath tests for carbohydrate malabsorption and small intestinal bacterial overgrowth useful and reliable? And I'm just going to add on, when should we consider doing that?
Yeah, sure. So we used to regularly do so these are hydrogen breath tests. So they're slightly different to the C13 urea breath tests that used to come for H. pylori. So we used to do hydrogen breath tests, and actually they're very good in that you ingest something and you've got a nice peak as soon as it hits the gut, and a secondary peak if you've got bacterial overgrowth. The problem is it takes a bit of time, and a lot of gastro units are doing them, but many have stopped doing them simply because we've lost funding for CNS and lost funding for the tests. So bacterial overgrowth basically is very simple: gurgly tummy, bloated, bit of abdo pain, and usually I just go very much with simple measures. Probiotics, which we've mentioned bifidobacter as the key one. Never harms to have healthy diets like Activia yogurts or the similar. And also prebiotics are foods that the body naturally breaks down into probiotics. And now that parents are much more into dietary manipulation, I spend a bit of time talking about prebiotics. And the simple thing is, it's root vegetables. So particularly in winter, it's carrots, turnips, parsnips, all of those root vegetables, sweet potato, great one. If you introduce those or increase those in the diet, they are natural prebiotics that the body will convert to pro.
Amazing, thank you. Another question. In the 250 to 500 fecal calprotectin range,
Yeah.
would you still recommend gastro-referral if there was low index of suspicion for IBD? Or could you just repeat later, then consider referral then?
Mate, whoever you are, I think you answered your own question. You just said there's low index risk. If you don't think it's IBD, why do you think I will? Okay. So what I would say is if it's borderline and there really is no clue to IBD, like they're growing really well, they've not got an abnormal poo habit, they've not lost weight, you really can't find it, then it might be a resolving infection that hasn't been picked up. They may have had Brufe and they've not mentioned it. They may have a bit of bacterial overgrowth. So I simply would say is there's no harm in waiting if there's no red flags and repeat it after 2 months. And we do that in some of our referrals when it's a borderline one. If it's over 500, absolutely please refer, even if there's no real history.
Amazing, thank you. And we've had lots of thank yous in the chats as well. There's quite a few questions left, but maybe I can leave you to kind of write answers to those. Thank you so much, Sandhya.